Concepts of blood conservation have really evolved over the last couple of years to really include a team-based approach. And we're trying to go through and discuss in a team-based approach how to limit blood transfusion or do blood transfusion but in a responsible way to benefit patients, to be cost-effective modalities.
Today, while I'm here at this conference, you're going to enjoy meeting me upstairs when we talk about ECMO, extracorporeal membrane oxygenation. We'll do some simulation, we'll run through some plays, get your hands on, and you'll have a lot of fun today.
I'm very excited to have my team here as we grow our CV program at Willowbrook, and to be able to bring the techniques of our HMH, as we all know, standardizing that care to the suburb area, so we will be able to provide the same paramount of care to our patients.
So I'm most excited about doing the hands-on things, working with machines. I heard we're working with the ECMO today, and so I'm excited to use that and kind of get more experience with that so I can use it on my patients.
The one that interested me most, being here with the simulation. I love to be in the simulation, especially with, doing the sternotomy. I haven't done it yet, and it really helped me, especially the gowning up and the preparation of the sternotomy.
Really surprised to hear about the blood conservation and the things that we're doing with that in terms of our campuses, and that's definitely something that I think that we can carry into our smaller community hospitals.
The importance of this conference, and I think the uniqueness of it, is bringing people from different facets of imaging to talk about, one, what is the latest, two, how do we apply it in clinical medicine, and three, how can we be better clinicians and serving our patients, learning about all these imaging modalities.
The beauty of this conference is that it looks at the role that imaging, all techniques of imaging, have in the diagnosis and management of heart disease, and I think that's absolutely critical today, because imaging of the heart is really the gateway to diagnosis and management. This gives you a chance to look at the breadth of these imaging modalities, learn about something you don't know about, get a better appreciation of it, and really understand how all the integration of these imaging is going to make a major difference in the future.
Every time you come, you learn a little bit more. You get familiarized with the scans, you get familiarized with what's the latest out there, and you have to constantly be adapting to change, because we have to stay up to date with the latest inventions, the latest scans, the latest protocols that will better help the patient.
Dr. Lumsden, can you hear us? Gotcha. You hear me? Yes, sir.
We're going to let the bell ring for a minute and make sure we gather everybody before we get started. All right. Okay, well, good morning. My name is Huey Lin. I am the director of the Adult Congenital Heart Program here at Houston Methodist. But more importantly, welcome. This is going to be a really exciting next 2 days. Welcome to the very first DeBakey CV Congress. I think we're all going to have a really great time. And to showcase some of the really amazing technology that we're going to be showing in the next couple of days, we're going to lead off with this introduction of my boss, Dr. Alan Lumsden, the medical director of the DeBakey Heart and Vascular Center. Dr. Lumsden.
Well, thank you, Huey. This may look like I'm sitting in a stadium somewhere. Think of this as the modern-day Roman Colosseum. And I start off with an apology, but we're going to try and overcome some of the barriers. And it relates really to this story. I'm going to show you a little presentation to start with. I'm going to give you, share my screen here for a minute. And what we're going to do is show you a little bit about why I'm not sitting there in the audience with you today. Okay, so the title of this little presentation, which was somewhat impromptu, is Coronavirus in 2020 Medical Education. And so the story really begins a little bit like this, in that I went to the Six Nations tournament in Italy, in Rome, last year. Like 3 days ago, basically, I went there. Went to Rome and arrived there on Friday morning. And on that Friday morning, there were 3 or 4 cases had been described in Italy. However, we arrived there basically to watch a rugby game, and this is what the rugby game actually looks like. It's called the Scotland versus Italy Six Nations tournament. It's very popular among Scottish people. And here you can see the theme of this is lots of crowds. And so what you're going to see here is the march basically of the Scottish fans from downtown in Rome, some 2 to 3 miles out to the Olympic Stadium. A lot of people actually participating in this. And this is us marching over one of the bridges to get into the stadium. And the stadium is the backdrop that I'm showing you at the moment. Unfortunately, I'm not there. So I got back from Rome on Monday evening. And in that 3 days, basically, when I left Houston to go to Rome, the number of coronavirus cases went from 3 to 4 to now close on 300. And that really shows you that Rome actually is in the center of Italy, right down here. Actually, there are really not many cases there. In fact, I don't think there are any cases there at the moment at all. Most of it was in northern Italy. However, what happened yesterday is that the CDC placed Italy on what's called the level 2 alert, which basically means that we're trying to limit the number of people who are traveling to Italy. And our organization yesterday afternoon, this was published yesterday afternoon, came out with this advisory strongly discouraging any personal travel for Houston Methodist employees and to cancel all work-related travel for employees. And you can see there are barriers basically if you return from an area such as this that's designated a level 2 country. And because we've been in a stadium with about 70,000 people, it was felt that there was some risk associated with it. And so, right now I can't come into the hospital. Unfortunately, that's where you are at the moment. I only noticed this little bullet point at the bottom. As I made this slide yesterday, employees may not be paid during this 14-day period. So that's really, why I'm not going to be there with you. However, we, as part of DeBakey CV Education, have been highly interested in remote education. We've often basically thought that you really don't need to travel to Houston for us to give you a lecture. We can do this remotely, and we've really been building this capability. And so that allowed us to scramble yesterday afternoon and to try basically and link me in. And so we've built several things. So, for example, we have a studio. Some of you will get interviewed in that later today, whereby we can link people in through the studio, and we'll be using that. I'll do those interviews remotely this afternoon. But right now, it's a little bit less sophisticated than this. This is my extra bedroom at home. We've kind of built this little studio. That backdrop is essentially in front of a blank wall. And you can see where we're going to link in this afternoon. We're going to use, where we're doing the demonstrations upstairs, I'll link in through what's called a Visitor One robot from store. So hopefully the show can actually go on. So, and that's my excuse for not being there. I apologize to Dr. White and Dr. Stone, who traveled to be here, not to be there to greet them in person, and hope and beg their forgiveness. However, we see this as an opportunity to kind of showcase and refine the ability to perform remote communications and remote education. And hopefully you'll all sign on to our Twitter page and onto our YouTube channel. Our YouTube channel is one of the real forums that we use to deliver education remotely. And, you know, that's got nearly 2.5 million views, nearly 21,000 subscribers. So I'd encourage you all to participate in that. So that's really the exciting part, basically, of this presentation. Now I've got to give you the disclosure announcement as part of the standard CME presentation. And that is in accordance with the policies of Houston Methodist and their ACGME and ANCC guidelines. The Office of Continuing Medical Education and Continuing Nursing Education is committed to the practice of disclosure by anyone who has the potential to influence the content. For your reference, the disclosure of financial and other relationships are included in the activity material. Any organizations or companies that provide educational grants or other support for this activity are also acknowledged, and you've seen that on some of the slides that are rolling. If at any time during this activity you feel that there's been commercial or promotional bias, please bring it up to our immediate attention. And please answer the questions about balance and objectivity in the CME, CNE activity evaluation. So thank you for your attention. Once again, I apologize for not being there in person. Hopefully this servitude is not going to last too long. And with that, it's my great pleasure to introduce Dr. Rodney White. Rod and I basically are the co-editors of the Journal of Endovascular Therapy. He's been very active in ISCVS, and he's got a long-time interest in intravascular ultrasound. So Rod, again, my apologies for not being there in person, but I know that you can carry the show, and we look forward to hearing about IVUS. And the way this meeting is set up is we're going to go through some of the basics of the imaging capabilities this morning, and then evolve into the second session of how we're actually applying these. And then this afternoon, tomorrow, you'll get to see and experience the hands-on opportunity to understand how we use these. Thank you very much indeed. And I'm going to now unshare my screen. So thank you again. And Rod, appreciate you being here, and thank you for the opportunity for you to come and actually participate. We really appreciate it. Thank you.
Well, thanks, Alan. Yeah. We all think you rigged this, actually, Alan. We're waiting for the hologram to drop down, so if you can work on that, we'll see you later. First presentation is intravascular. How many people know about intravascular ultrasound? Everybody knows how to use it? So, because I'll go through some of these early slides here quickly then. These are my disclosures. Chris and I were just sitting there talking about conflicts. None of these relate to the talks. IVUS has become really a core technology that we use in a lot of our endovascular procedures now, particularly because we get a transmural view of the vessel. It lets us identify branches. In the dissection cases, as I'll show you, it's really become a very important part of that, and also in some of the newer venous technologies. The intravascular ultrasound technology this is the catheter inside the blood vessel, and what you see is a new perspective. Rather than just looking at the lumen with contrast, now we can look with ultrasound technology and translate that into a three-dimensional picture so that we see the lumen, the plaque, and the surrounding tissues. And really, just as Alan's shown us now, this has moved along to where we can look at it. It has also changed the quantitation of how we look at and characterize lesions. When you look at a blood vessel, if you have a plaque here and the rest of the wall is normal, this is what it would look like. And some of the studies that have been done in the coronaries really rely on being able to look at the plaque quantitation and come back later. So it really has changed how we do studies and quantitate that sort of work. There's two different types of catheters. The one that most frequently is used now and we'll be using later has signals that go directly out parallel to the device, so that we're looking. Some of the others in earlier prototypes, the catheter beam was built different ways so that you actually, in some perspectives, look forward. There's two different kinds of catheters that are available. The one that's most easily used is a phase array, where you work over the lumen. The catheter or the wire goes through the lumen, so you don't have this catheter artifact along the side, and you'll see that in some of the later images. So this is a picture in a normal iliac artery of an ultrasound probe here. This is the artifact that you get from having a wire next to it. And then what you're able to see is the three-dimensional wall characteristics here, or 2 dimensions of really the entire wall and its surrounding capabilities. This is just another view in the aorta. This is the ultrasound probe, the renal vein. So it lets us look and be able to identify vessel and surrounding anatomy. A lot of these systems you'll also see not only translate this longitudinal image into a 3D characterization along the wall so that you can see where the catheter is gone and look at the wall morphology. Now like conventional ultrasound, this is the ultrasound probe here. This is a soft plaque, so you're able to see through that to the surrounding tissue. Here, where there's calcification, that stops the signal, the same as it attenuates ultrasound in other places. So it lets us be able then to characterize the plaque if it's got a calcified component to it compared to the soft tissue itself. Or in this case, in the aorta, where this is what would fill with contrast if we did an arteriogram, but you actually have a large thrombus burden in an aneurysmal segment. So it gives us the ability then to really quantitate all those different factors. This is a superficial femoral artery. This is the normal segment here, again, that 3-layered component. And now in another area where the lumen itself, we all know that when the early evolution of a plaque, what happens is the entire vessel diameter gets bigger to accommodate that plaque up to about 40%. And this is, in this case, an example of that, where there's the wall, here's the plaque, but the lumen on arteriogram would look as though it's exactly the same size. Another example here in the iliac of a patient where you can see, the pointer's not there, it is. These are the ultrasound images. Here we're looking here, and on the arteriogram, this was quantitated as about a 70% patent lumen. When you look at it in this perspective, it's about 40% and calculated. So it does have a significant impact. Now the other thing is, this is a picture of an intramural hematoma, and I'll show you one of these again later, but where it's blood in the wall that has a higher water content compared to what would be the plaque, then you tend to get this sort of an image where you see the tissue and the other components. At the visceral vessels here in the aorta, this is the renal vein, so this is a relatively normal looking aorta, and if you just move it down a little bit, there's that left renal artery and a large plaque with a component and again some shadowing behind that calcification. There's a lot of ways some systems again give you these longitudinal images so that you can look at the neck. Here's the aneurysm, the lumen, a calcified area in this part. So it gives you the capability to look along the entire length of this and characterize what you're looking at. The other thing about in a lot of patients where they've had a previous surgical procedure, you can't tell, maybe they have a pseudoaneurysm or something where the vascular graft itself ends and the normal tissue starts. And this is an example here of what the Dacron graft looks like compared to a normal artery. So it gives you the capability to very carefully look at that and look at it. Technical aspects are that when you set up a room, and we're going to be focusing on an endovascular room, so it's important, and everybody figures out their own way to do this, but to put that IVUS in a position, if it's a freestanding unit where you can see it, or many of these are integrated systems now where it actually comes up and then you see these on all the floral panels, and a lot of you are familiar with that. What you have to do, and there's some people look at the images when they're not familiar earlier and they sort of say, I can't figure this image out, but once you do it, if you very carefully move it through the lumen and look at the perspective of it, this is easy to interpret after a while. For examinations in the periphery, most of these catheters are in about an 8 megahertz capacity, although if you look at it, in terms of depth of penetration, and this is where we use most of the probes here. If you increase the megahertz and you get up into 20 or 30, that's where the coronary probes are in the smaller perspectives. So depending on how far you want to see, and in most cases in the aorta, we want to see out 5-6 centimeters. So these 8 to 10 megahertz probes are what drive that area. Now, there are some limitations to ultrasound. You have to also use this when you're looking at the images. As you pass the catheter through the lumen, when the vessel is tortuous, you'll see that that catheter at various points is closer to the arterial wall. And it gives you in an area like here, where if the catheter probe were in this position up against the wall, you get an elliptical pattern. And what we've all learned is if we're trying to measure dimensions is use this smaller dimension, because in this perspective, it's because of that angulation, and it really is not the exact diameter we want to look at. Where when the catheter is centered, then anywhere you can go, you can make a measurement of diameter. This is another example of how just the megahertz of that probe is important, but this is in the aorta with a 12 megahertz catheter where you can see the surrounding soft tissue, compared to a 20 megahertz where you really get very limited penetration beyond there. So depending on that, again, how far you want to be able to see, you choose a catheter related to that. This is just another example of a CT angio and how this shows you the morphology of where we see this on the angio, but in this case, here's the arterial wall with some small penetrating lesions down along. Here's another one into the iliac. There are also color flow applications. This hasn't come along as quickly, but it does have some use. This is just to show you what it looks like. This is what the artery looks like with the color flow, and then you'll be able to see the pulsatile flow. Here's a stent segment in a color flow, hypogastric artery. Or it has some use looking for endoleaks, where you can look through the aneurysm and see these collateral vessels that are actually filling in. So, but again, the color flow application really hasn't quite taken off as we all would have suspected. Many of you that follow the peripheral vascular literature, venous applications have developed IVC filter placement. Some folks, this is an example of a probe here in the iliac vein, and you'll see as we pass it up, how flat. This is a patient who, when he lays down, the cave, so if you had shot an arteriogram in this, or a venogram in this direction, you'd measure this as the diameter. Here you can see the renal vein. So for vena cava placement, it not only lets you characterize the size and diameter of that vena cava. Here's a thrombus down in the iliac vein then. So this, if we were going to place the catheter, what you can do is put it in, measure from here to here where those locations are, and then be able to put the filter next to it and actually place it based on that length measurement without having to use any other sort of modality, and sizing that vena cava filter to that dimension. Another application that's come along quite reasonably in a patient that has May Thurner. So this is injection into the femoral vein. You can see the iliac vein here is occluded. And when you look at these in various dimensions, these are the angles on an arteriogram. As you rotate this around, you can see the compression here. It's thinner in this regard, so you have to use a lot of angiography in order to be able to characterize that with the ultrasound. An important application now is here in that lesion. Here's the ultrasound probe, that constricting lesion, the compression of the iliac artery, and you can see the iliac vein. In another case here, there's thrombus, that compression, and this has become very useful then not only to find the location of that lesion, but also again to size a stent. Because if you measured it in this perspective, you'd be using a very smaller dimension, or in this case, so you're able to size that appropriately. This is after a stent's been placed. You can see here this stent now is still compressed, so that coming back and making another enlargement or putting in a balloon expandable stent, here's with the full expansion, and then also what occurs is this recurrence of lesions over time. So there's the stent, here's a lesion, and then the size of that lumen related to the ultrasound probe. So in these kind of venous applications, it's become very important. Aortic interventions, we use the IVUS a lot. An example here of an intramural hematoma. This is a 3D reconstruction of a patient that has an intramural hematoma here. You can see on the CT this little area, and on the IVUS be able to, here again is that point where the entry for that intramural hematoma is, and it's very hard to see that on an arteriogram. So we use that to be able to find it, and then here's that same patient over time where we cover just that segment because we're trying to limit the amount that we cover, and then the regression of that out to a month. In traumatic transections, a lot of these patients, as you know, come in to the emergency room there and have multiple injuries, and when we take them to be able to treat them, the IVUS is an important part of that. You can actually, by passing a wire around the aorta and then putting up the ultrasound, this is right up near the subclavian. Here you can see the traumatic lesion, and then lower down again the aorta. So it's made it so that once the patient's been resuscitated, you can look at how the aorta is expanded, use that for sizing, because just doing it on a CT when the patient comes in and hypovolemic, particularly if they're younger, you can undersize an endograft. So to be able to use the IVUS, and if you really don't even want to heparinize the patient, you can put up a wire, run the ultrasound, map it out, and put a device in very quickly without even having to use heparin. This is an example of that, a traumatic transection here, placing the device, and you've all seen this, and then the follow-up at 6 months. In the dissections, this has also become a very important technology. You're all familiar with the various classifications, and we're going to be talking just about the type Bs, looking for that entry point. In an acute dissection, this is an example of a patient's aorta with a dissected segment. So what we're looking at is an entry point, flow through that false lumen. You can see how thin that is, and although there's controversy about how that remodels later, when these become aneurysmal, you can see why. And this is an example of the ultrasound probe. If it were in this true lumen here, that flap, and then out here is the false lumen. And the other thing that you get from the IVUS probe is not only in this case where the arterial flow is faster, when we get stagnation in that false lumen, you actually get that grayscale component to be able to look at that. So it's an important part of that, not only the size and look at the lesion, but also to be able to characterize here, again, the true lumen. We want to make sure we're in that all the time, and then this flow in the false lumen. At branch vessels, these dissections normally either two mechanisms, they close in a dynamic fashion against the wall, or in most cases they actually tear off, and you can see here this at a superior mesenteric artery, the true lumen. This is the flap where there's actually then perfusion of that SMA from both lumens. Now I'll show you some still images before I talk about it, but this is a catheter where we've placed it in a dissection up into the ascending aorta, and we're going to pull it back along the aorta and then down to be able to characterize the length of that. So here up you can see the carotid artery here at the subclavian where the dissection is. We're able to see right there's the entry flap, the ultrasound probe in the true lumen, false lumen here. And then the other thing we get is in chronic dissections, you can actually see the dynamics of that flap and how with thickening there's less motion of that, and when you pulsatile. This is an example of a patient who came in. This is the 3D reconstruction afterwards with an acute dissection. The entry points up here in the usual position, distal to the left subclavian. This is the true lumen, the false lumen down through. And this guy came in, he had no pulses in lower extremities, had belly pain. So this is an acute malperfusion syndrome where on the CT, this is the false lumen, the true lumen here, and why you see that compression. Now, in the area here down lower in the aorta, this is the false lumen, there's the flap, the IVUS probe, and the true lumen, so you can see why there's that degree of compression. And then after we put the endograft in at that same location, now that true lumen becomes, in this case where the false lumen is the pulsatile lumen carrying the blood flow, the true lumen becomes pulsatile. You can see the stagnation in the false lumen, so it lets you know that we've actually covered the appropriate entry points. In a second, I'll show you the pullback of this. So the probe would be here, and we're going to come back down the aorta. And as we get here at the subclavian, you can see the beginning of that tear. A little lower down, now we're in the true lumen here, false lumen there. And once we get down lower in the aorta where there's malperfusion, now the true lumen is very small. And the other thing in this case is it looks very small, but it actually is almost nothing with that because the catheter is holding that lumen open a little bit. And down at the celiac artery where there was complete compression, you can see this dynamic. Here we're in the true lumen, false lumen, and this is why there's actually malperfusion here at the SMA, celiac, and the renals. So this is a video now of the ultrasound probe in the ascending aorta, and as we move it backwards here, there's the innominate artery, carotid, subclavian, the beginning of that tear. Here's the probe in the true lumen. We always want to verify that. You can see this flap and how dynamic it is. So this is false lumen. And as we come down lower through the thoracic aorta, pulsatility here in the false lumen. This is the true lumen being compressed. And as we get down lower, you can see now this flap gets closer and closer to the wall. Again, that's why this patient has malperfusion. And here the ultrasound probe, we go by the celiac, the SMA, the renals, it's completely compressed, and that's why he had no flow to the lower extremities. Once we put the endograft in, here at the subclavian, we've covered that so you can see the stent struts. Here's subclavian. This is the carotid. It's open so we can see just the struts across. Here's the subclavian. And then lower down now, the endograft, and beyond that, what's happened is the true lumen's popped open. It's now got the pulsatile flow. This is at the SMA where it was no perfusion, and that false lumen is much smaller. This is the IVUS pullback after that. That's the innominate vein up at here's the innominate, carotid, subclavian covered, and here's the endograft. Now it doesn't completely open up at the beginning, but you can see there's a much where this was compressed. Here's the stent graft. This is the false lumen. In this case, there's two grafts, and now down lower, pulsatility has been restored to the true lumen. This is the false lumen here, and then celiac, SMA, renals, and perfusion to the lower extremities. So it lets us look at that afterwards and be able to see where we've remodeled it and if we should add other components, or if in fact there's something that needs to be revascularized in another segment. The other thing that's useful, and we occasionally use this in patients where we don't want to give them contrast, is you can put the ultrasound probe and identify, in this case here, we want to put an endograft down to the celiac. So there's the ultrasound probe, the device coming up. And what you can actually do is just with the ultrasound probe in position, bring the endograft up, deploy it in the position where you want it, and not have to use any contrast to make that deployment. In the chronic dissections, as I mentioned, the flap's thicker, the dynamics are a little bit different, and it's sometimes going to be very tricky. This was a patient, and I'll show you some images, true lumen, false lumen with some flow, and then thrombus and this very complicated anatomy down lower in the aorta. When we first put the probe up in this patient, we're actually in the false lumen. So this is that big thrombosed false lumen with, as you saw, there was some flow. Here the true and false connects. We're pulling this catheter down. And then as we get to the viscerals, here's celiac, renals, lower down in that component in the infrarenal aorta. So we're in the false lumen, we want to get into the true lumen, and what we can do is bring it down to where a septum, where it's broken, redirect the catheter, and then put it back up in the appropriate lumen. The other thing it lets you look at, here's the aorta, here's the flap, and the catheter, when you first put it up, or a wire, here's the flap, you'll see this is where it is crossed over. Actually, there's an opening or a tear that we may have made where the wire goes from one lumen to the other. So it's a very important way to be able to make sure you're in the true lumen where you want to be without having to inject a lot of contrast. This is an example of that afterwards, and then again how we were able to put the graft in the true lumen by defining that. So when you compare IVUS to other imaging modalities and where we use it pre-intervention or during, is that the IVUS here in particular gives us a lot of the same characteristics as we see on angiography, but we get that dynamic component in the measurements and lets us be able to do this without contrast. So with that, I'll finish. We can talk later and walk through this. Thank you very much.
Thank you, Dr. White. That was really fantastic. Some pretty incredible images there. So we have a slight change in the schedule as the COVID thing continues to give us challenges across the board. Dr. Bavari, who's actually supposed to give our next talk, is actually in the operating room. Next up is Dr. Joel Karami. He is the medical director for vascular ultrasound at Houston Methodist. He'll be talking to us about some pretty exciting things that have certainly saved me in my hybrid operating room experiences. Dr. Karami.
Thank you. No. Thank you for the introduction. I would like to teach you what is my passion and transcranial Doppler monitoring, what I'm doing in operating room or in inpatient care. My motivation was that when I was coming for an interview, I was traveling together with Dr. DeBakey, and we had a flight emergency while he went back to sleep. I took care of the medical emergency, but during landing, I asked the flight attendant, I need a picture with that gentleman. So this is why traveling to my interview, I had the pleasure to travel together with Dr. DeBakey. My other disclosure that we are in Houston. So when an astronaut comes home from the space station, we attack him with everything we got. So we have an ultrasound machine in Houston, has 3 different probes, like a polyp. No, this is 3 different ultrasound, doing his neck, eyeball, and the heart. But those are just my fancy disclosures. I'm really proud to be a medical director, and what was funny that the ultrasound lab in Houston Methodist was funded before any ultrasound existed. So 76, so we celebrated the 40th anniversary. The first ultrasound ran 82, 83, so even before you had ultrasound, we had an ultrasound lab. I'm extremely proud. We have about 20 sonographers, we do 24/7, and we do about 20,000 ultrasound studies a year. And you probably saw that in the brochure, and one of my favorite parts of our new fancy operating room is my toy. That is the robot TCD. I'm going to show you what we're using. So probably in that hybrid operating room, my toy is still the cheapest, but still as a new ultrasound equipment. And again, I think Dr. Lum, I had to steal a slide from him. So imaging as I think we have a bunch of different ultrasound machines, but out of these, TCD is still the cheapest. So that yellow box is not the Ferrari color, but this is how you're supposed to recognize the TCD in operating room. It's still running around a price tag of $30,000 compared to all the others. Very important that you understand your machine, you understand the technology, and I think definitely education is a really big part. Unfortunately, around the country in the ultrasound school, they forgot to teach TCD. So, and TCD is a really fancy term. Sometimes they call it TDC, or some other terms start with the S, but I'm not going to continue on that one. But what transcranial Doppler does is truly able to go through the bone window and able to give you an insonation on certain depth of the blood vessels, the intracranial blood vessels. And again, the first ultrasound was just a single depth. Now we have an M mode, give you a GPS map where the blood flows are. And if you're not colorblind, you can really see the direction of the flow. Red coming towards you, blue is going away from you. And if you are colorblind, then pay attention to the bottom screen. That's your spectrum. That spectrum going to tell you that between your measurement point and the heart, there's no obstruction. When your systolic upstroke is straight, that tells you there's nothing obstructed between your measurement point and the heart. So this is what we're using for carotid disease, or if your both MCAs are delayed with upstroke, then you're certainly think about aortic valve stenosis. And watch this video. I'm going to compress the carotid. Look at how the waveform is changed. That's how simple it is. So not just the objective way of giving you a velocity, but also to show you how the waveform kind of changes when you have obstruction. And this is how a gorgeous TCD screen looks like. Just get used to it because you're going to see a few examples. And this is how we started. We're able to detect an intracranial occlusion with an acute stroke patient, and we're able to monitor it for 2 hours, and we see immediate localization with TPA. And sometimes we are selecting these patients to do an angiorescue therapy if we don't see the recolonization. So this is 2003. We had a clinical trial really comparing the NIH stroke scale with our recolonization rate. That was a clot bust study. So we are the clot busters, and definitely what we learned from the acute stroke, we brought it to the operating room. This is, we do not want to see that the blood vessel front of my eyes occludes. Cool? So this is like reversing your acute stroke finding and the monitoring and showing you what is the blood vessel remains open, and the moment it occludes, you can initiate rescue therapy. You don't need to wake up the patient, hey, move your arm. You're not going to see any movement when your middle cerebral artery is occluded. So again, there's some good bubbles, bad bubbles. We use some contrast agent for PFO testing. We believe we are so much better than our cardiology colleagues detecting PFO with TCD, because the TCD doing a 3D flow, we can do very good Valsalva because we're doing it in a sitting position. And again, these are the different patterns. This is the left upper corner, Definity contrast agent. You can see that like a whole brain is lighting up. Those white signals shows you there's something else traveling in your bloodstream which are not red blood cells. This is how you're differentiating them. But again, when you see the emboli, you want to see how the flow is improving. Do I have a pointer? No, I don't have a pointer. But what you see on the left-hand side, the blunted signal becomes better. This is what happens when immediately with the stent placement in the carotid, you see the immediate improvement of the flow. Watch this. Patient lifting the arm up, and look at my yellow box, the signal is gone. Cool? So again, we are hemodynamic testing. While you are laying down in the CT or MRI with flat, no movement, we really can test what is your blood flow doing. And this is again, a PCA monitored when you're lifting your arm up. What does it tell you? That your bypass is maybe kinked. The other vertebra is also out. And again, with some assistance from Ponraj, have you guys seen a color angio? This is the eye flow on the left-hand side, arm down, right-hand side, arm up. Is that cool? Think about how many times you do an angio with really confirming an ultrasound finding, but we are really good to find you those. What this guy tells you, that look at the vertebral delay. When your arm is up, huge delay, arm is down, no delay. Super cool. So also we are planning and experiencing what is the speed of the bubbles coming from the neck to the brain. So this is again a flow on the neck. This is how long does it take to get to your brain. What also goes up, comes out. This is my own head. Sometimes we want to monitor the vertebral artery. And this is an embolus traveling in a vertebral going into basilar. So these are really cool things. Again, a white thingy-bingy, which is not a red blood cell. Lots of different devices going to monitor the flow. This is like a halter for the brain, just attached to the glasses. And can I have the sound, please? Maybe I don't have a sound, but what I want you to see is that we are balloon angioplasting an aortic valve, and the gentleman tells, okay, balloon is down, and I don't see the flow. In the same moment, I would like to introduce you how to do the CPR in Italy. This is for Dr. Lumsden. This is how you do it. So I'm so glad that Dr. Lumsden came back from Rome. This is how you do CPR in Italy. And what is my flow shows, can you turn the lights off on the front? Because it just, you don't see the slides at all. So what you see is with the rapid pacing, you don't have any cardiac output. And when the heart restarted after the successful CPR, you see a trash of lots of air coming out and showering the brain. So again, not the rapid pacing, but when you restart the heart, then it's flushing out all those emboli. And here's something, the valve is positioned, there's no flow to the brain. We quickly removed the valve and started that Italian fashion with properly, with the arm down. But when your fellow is scared that they're still doing x-ray on the arm, make sure the arm is on the chest. That's pretty cool. But you can see there's no effect of your CPR. This is when your senior surgeon takes over and you see the spikes. So there is something, you need to listen to those senior guys. So this is the senior surgeon hand, and you see the flow improving and how your flow is there. My favorite video. This is why you guys came to see. If it plays, right side, left side. Aortic valve, the core valve is crossing the arch. And why is crossing the arch? Is stretching your left side. Unilateral, this is your stroke. Unilateral loss of signal, not bilateral. And that signal never comes back. 30 minutes later, with the neuro guys, we're taking out the clot. Cool? Yes, you can do something about it. So when people are ignorant and saying, oh, why do I monitor this? Well, there's certain things you can do about it. I'm going to skip this part, but I want to show you my fancy 3D video. So this is my 360 Dr. Lumsden, right there with our fellow. This is where my TCD is sitting. I hope you like my video. I'm not sharing it with you. And this is my old-fashioned way of putting the head frame on. And what we do is we have a band holding the head frame on the head, and this is my new ways to doing it. So this is the robot automatically finds my signal, and we didn't believe it. So with these fiducials, the robot takes a picture with this camera and have a computerized window where it's going to learn where is my signals. So this is how we are practicing with our sonographers. And again, this is how we're practicing with our anesthesia. So our anesthesia just don't know how properly put the head frame on. But I think it's more dangerous because anesthesia is still having problem with this hybrid suite too. And this is how we properly do it with a robot. So what you see here, the robot comes in, automatically finds a signal. And with these two screens, so this is regular TCD, and this is just a robotic screen going to initialize that signal, and the robot automatically going to find my signal after taking those two pictures. And then I'm able to see that this method after initialization is about 2 minutes. This is why I speed it up for you so you don't need to wait for me too long. And this is how the signal looks like, and this is just a side view. And you can see before putting on a patient head, when initializing and want to make sure the robot is working, so in the robotic space able to point a bunch of different directions. And this is when the robotic arrows in action going to show you where did he found those signals. I'm not going to focus on the surgical part, but I really want to show you a few slides, and I think I want to show you this is my beautiful slide. So with less than a minute, we're able to secure an MCA signal. So when anesthesia and surgeons are anxious, they don't give us too much extra time. Don't tell me you don't have a minute to find that MCA signal. So if I have a minute, I'm only asking for a minute to secure a signal, and we're able to monitor it. And if the robot losing the signal, then we're able to find it. And I think the future is, this is again, in the 90s. They are measuring what's your MCA depth, what's your angle. We can do the same. This is again with Ponraj, you're gonna learn a lot during the lunchtime. We are measuring based on the CT, what is the depth of my MCA signal on both sides, what is my angle. So I think we can even beat that 1 minute, and we can do it even faster. And when I'm traveling, like Dr. Lumsden can remote in and I can assist the surgery. This is my happy face that I don't need to be in an OR. Here's my TCD. And I'm able to see both signals, the TCD and also what's the operating field. So just Monday, we did the first Methodist system CA monitoring in the Woodlands. So, and I think this is our goal, that you're able to provide the same services in our suburban hospitals. Because you're gonna see some neurosurgeon robots, green room. I was fascinated that how these guys through the nose taking out these tumors. What you can see on this, that this carotid is already occluded. Here's the flow void that tells you that the carotid is still open. Look at how close is that carotid to that hypophysis tumor. Cool? So what you see, taking out your MC is good, your carotid is safe. This is your carotid. Cool? I hope you like my slides. I'm going to finish up with my love and message to my cardiologist friends again. My sonographer comes and says there's an embolization on the carotid and maybe coming from this plaque. Do you guys believe it? Don't. So what your question is, what is that toy? They call the Impala running, and different P values going to give you different embolization. P4, no embolus on a TCD, you can see a pulsatile, beautiful waveform. Less pulsatile, more emboli. Guess what happens with P9? Bilateral showers. Cool? I hope there's lots of cardiologists in my audience, and they are learning that the P setup is very important, and we're here to help. LVAD, embolizing, return of the LVAD, pulsatile flow, no emboli. You know you have a clot in your LVAD. So it's indirectly, but we can point you that you start your LVAD again, your pulsatile flow disappears, you're gonna see clots. Just give some TPA and you should be fine. And this is my last favorite thing. We can do also doggies. So dog MCA occludes with injection. Cool? So that is not just human, but I think we can do some other TCD. This is my TCD under X-ray, able to show you the same vessels, what we do every day. I'm not going to talk about my testing, but because you're on a robotic conference, I was really kind of bored training my fellows. They never follow up. They just don't listen. And I just, within 1 hour, I train my robot. 1 hour. Left hand holds the carotid, right hand stick the IJ. Why? You're wearing a spacesuit. You're gonna stick the arm? No. Your only access to give life-saving medication is your neck. So the robot is already doing it, so thank you so much for your attention. If you want to learn ultrasound, just find me, okay? Thank you.
So next up, I'd like to introduce Dr. Gopi Shah. She is a cardiac imaging specialist with the Interventional Cardiology Associates here at Houston Methodist. She's going to share some insights on echocardiography for interventional procedures.
Is the talk loaded? Who do I tell?
So I think while we're waiting for our slides to come up, there we go.
Okay. Good morning. I'm excited to be part of this conference and walk you through what the Echo is doing in the hybrid OR. We now have a very new and interesting and challenging role since the evolution of the transcatheter procedures in the structural heart disease field. Okay, I need to figure out. Okay, no disclosures. Okay, so when I was a fellow, the fanciest things that were done in terms of structural heart disease from interventional standpoint were the balloon valvuloplasties, aortic, mitral, and the PFO secondary ASD closures. Then came the TAVR revolution, and it was not a random event. It was an inevitable result of the decades of bold progressive iteration in all the fields: surgery, cardiac imaging, and transcatheter therapeutics. And what followed was the birth of the heart valve team approach. And what does that mean? The surgeon, the interventionist, and the imager became an integral part of trying to lead this effort to bring the cascade that followed next, which was the, as I can go through, we now do the occluder devices in the left atrial appendage, the mitral clip, edge-to-edge annuloplasties, TMVR, tricuspid valve repairs, the TTVR, the leaks that we repair, and the valve, and as Dr. Lin here does, the ASD, VSD closures too. So these are some of the devices, represent some of the devices that we have, and you can see the progression of where we have come in the last 2 decades. And echo has been an integral part of it right from the beginning. Obviously, the benefits of echo are well known to most of the people sitting here. But what is interesting is that transthoracic TE and the intracardiac echo all have evolved to make this a very robust field, along with the emerging, the 3D, which is integral to all the modalities. So what does an imager do? We have a pivotal role right from the selection of the patient to guidance during the procedure and the evaluation of the patient during the procedure and after the procedure. With selection, we decide the severity, the structural details, the best procedure that we can offer for that particular patient, and of course the device sizing. During the guidance, it's the safe guidance of the transcatheters and the delivery equipment up to the structure that is involved, deploying it safely and efficiently, and then seeing how does the device function, what else needs to be done when the patient is on the table. We have become a fully embedded part of the structural heart disease team. So in the foxhole, now we are no longer in our own silos, no longer an imaging non-combatant sitting in the echo lab. We are right there with you in the OR. I want to show what the OR looked 100 years ago. And Dr. Garami showed some fancy pictures. These are the OR that looks today. And what does the echocardiographer do? He helps facilitate the fusion for the operator between the fluoroscopic maneuvering of the device and the real-time echo imaging. I think I can best illustrate it by taking you through some of the cases that we do. I want to briefly mention here that as the structural heart disease has evolved, there has been an incremental value that echo brings to the table depending on which problem we are tackling. And here you can see the added value keeps incrementally increasing as you go up. And the reason for this being that at the high end, the tricuspid, the mitral valve, are a much more complex structural problem and a hemodynamic problem than, say, a straightforward ASD PFO closure or a LA occluder. TAVR falls somewhere in between. And you can see that there is an incremental value that an echocardiographer brings to this. And this will later feed into why training in interventional echo now becomes of increasingly importance in tertiary care centers that are now gearing to provide transcatheter-based approaches for the structural heart disease. So what do? We do the pre-procedure. It can be TE. Sorry, let me go back. Oh, can't let it go back. Anyway, let me show you this. This is the, I want you to focus here. This is the mitral valve, and you are seeing the regurgitation of the mitral valve due to the P3 prolapse, and you can see it's a significant mitral regurgitation. So you have identified the problem. Now, with 3D imaging, we can actually define exactly which part of the mitral valve that we need to target. And you can see here the P3 scallop is prolapsing. In still images, you can see it here. And in a longitudinal axis, you can see it here. So we are going to help the operator determine the target for the clip placement. And this is the procedure actually when it's being done. So you can see here transseptally positioning of the device. Here we drop the grippers. The grippers are these. It actually allows the clip to grip the P3 and the A2, in this particular case, scallops of the mitral valve. And you can see as the arm closes, the clip is deployed here. And then we assess okay, we have deployed one clip. What is the MR doing? And you can see there's still significant amount of MR present. And this shows it again. Again, it's an extremely eccentric jet, and you can see that there is a lot of maneuvering that goes to show. Here it doesn't look too bad, but if you see here, it's a very wall-hugging eccentric jet. So from an echo perspective, the echocardiographer in the OR is instrumental in defining the success of the procedure and what needs to be done next. So here it is determined that obviously we have not got a great result with just one clip. And so we go ahead and say, okay, what should we do next? And here we say, okay, this is your first clip. This is still your P3 as it in systole, as it prolapses through. So we can still possibly deploy another clip to decrease the severity of the MR. And this is exactly what we do. We help guide the operator. And here you see again the second clip coming. These are the clip arms. And we help him deploy successfully at A2P3 junction another clip. Let's see how are our results. Again, showing you the first clip, the second clip, and you can see the gradient. We have to monitor for gradient because we don't want to create a mitral stenosis in order to treat a mitral regurgitation. And after implantation, you can see there is significant reduction. It's now only mild MR. One thing I have to emphasize is when you deploy more than one clips, there are multiple jets created. And as an echocardiographer, we have to determine how much of the MR is remaining. And there has been elegant papers and studies done by Dr. Steve Little looking at how to measure multiple jets with the vena contracta diameters and area, and add it to determine the severity of the MR. That's a talk entirely by itself, so I won't go into that now. And let's look at what else we can do. We actually can demonstrate the hemodynamic effect of what we have done. So this was before the patient had the clip. You can see predominantly diastolic flow in the pulmonary veins indicating high pressure with systolic reversal. You can see the stroke volume at the LVOT was reduced at 35 cc's. And now, post-mitral valve clip, you have systolic diastolic equation. That means the pressures in the left atrium have improved, and you have an improved stroke volume. So 60% increase in the forward stroke volume. This was a successful procedure. All this by being present in the OR, helping guide the operator and validating the results of what he has done. So what is next? And I really want to emphasize how much important the echocardiographer is here. The next complex thing that we are going to deal with is the transcatheter mitral valve replacement. Is that too tall a mountain to climb? Because mitral valve is not as simple as the aortic valve. It has an incomplete annulus which is tilted. It has subvalvular apparatus. It is in close proximity to the LVOT and can cause obstruction if not deployed correctly. Most importantly, there are different commercial valves in trials with different anchoring mechanisms. So I have to say that role of imaging, particularly echo, becomes even more important when dealing with this complex valve. So here I'm going to show you one study where we had deployed the Intrepid valve, and you can see this is a poorly functioning LV. You can see that there is a gap in coaptation of the mitral leaflets. This is a severe secondary MR, and you can see, if I could place this, sorry. And we rely on our colleagues to, how can I make this play? It was playing perfectly fine. Do you know how it was? Okay. So, and in this one, you can see, in the 3D, you can see the coaptation, the mouth of the mitral valve being open. So you can see this is a severe secondary MR from LV dysfunction. Okay, now we did, okay. And we rely on other different modalities, such as CT, to size the mitral valve, and this is very important, and I want to draw attention to the neo LVOT that we create. We call it neo because when you deploy a mitral valve, you have a new LVOT which is kind of narrowed, and you have a new axis. So there are a lot of caveats to consideration for selection of the procedure and assessment of, more importantly, selection of the patient. The aortomitral angle becomes important. The size of the LV becomes important. The thickness of the LV septum becomes important. All these factors are important in considering which patient would be ideal for a transcatheter mitral valve replacement. This is our hybrid OR, and as you can see, this is the doctor accessing at the apex. These are the transcatheter device used. And we do what is called a finger poke. And this finger poke is done to establish the axis at which the delivery device should enter at the apex, making sure that we do not hit the chordae, the paps, and do not cause any, and go straight across the mitral annular plane. So you can see this here is the finger being poked by the surgeon to see which should be the point of entry. And again, showing you the axis at which you want to enter, clear, free of any subvalvular apparatus chordae okay, so here we are now advancing our delivery system. You can see we have crossed the mitral plane. We see this as an orthogonal view. You can see this in the 3D as you see it from the atria. You can see the device across the mitral valve, and then we deploy. And as you deploy, you can see the unfurling of the valve as it comes out. It's still not fully deployed here. You can see that there is the annulus rim. This is the valve is still above the annulus. And depending on the valve and depending on the anchoring of the valve, you help the operator assess the annular size, the thickness, and the landing field of the valve. And here this is valve that has been completely deployed across the annulus, across the native leaflets. And here you measure the gradient, and this is a 3D view of the completely deployed mitral valve, transcatheter mitral valve. Again, I wanted to share this. This is the LVOT prior to the valve deployment and the severe MR, your 42 cc stroke volume. This is post mitral valve. Again, you can see a significant 57% increase in the stroke volume. Again, the hemodynamic effects of a successfully deployed valve, all this information we can provide. Now, we do a lot of fancy other things, more simpler stuff, and this is the TAVR valve and valve. You have a valve which is a bioprosthetic valve. It has a leakage here. We deploy, I wish I could play this one. And you can see that there is a significant paravalvular leak. We advanced a a new valve across this valve. We deploy this valve, and you can see there is there is almost no paravalvular leak, excellent profile of the valve-in-valve with no evidence of stenosis. This is another bioprosthetic valve, but this one has a significant leak, which is directed very eccentrically anteriorly towards the mitral valve. And here we have a different approach. What we are going to use here is a occluder device similar to the ones used for ASDs, and we are going to cause, again, very trivial AI. So as you can see, echo plays an integral role in all the structural heart diseases in the hybrid OR. And I'm going to end by saying that defining the problem, data to plan the procedure, guiding the procedure, and defining and anticipating the problems during the procedure are key. Follow-up of the procedure device function, residual lesion, and the cardiac response. One last thing, the advanced echo competency is required, and ASE has worked on it, that to be an interventional echocardiographer, you need to have additional training, and there are guidelines for that for good tertiary care programs. Thank you.
Thank you, Dr. Shah. That was a real tour de force. So we have actually a tag team of speakers coming up next. So it's my pleasure to first introduce Dr. Mohammed Shamsi Pasha, and then later Dr. Eric Yang, who are both echo and MRI specialists. So Dr. Shamsi Pasha.
Good morning, everyone. Thanks, Huey and Dr. Lumsden, for the kind invitation. So beautifully, Gopi has set the stage that interventional echocardiography is no longer a luxury tool, and if anything, it's actually a necessity in this world of structural heart interventions. And what I really want to show is, if this one moves, next slide, there you go. What I really want to show, just want to add some flavor to what Gopi mentioned about percutaneous closure of paravalvular leaks. Here's a young patient who had both a mechanical aortic and a mitral valve, and he comes in with shortness of breath. He has a very loud systolic murmur and what appears to be normal clicks, and then on transthoracic echocardiogram, he really has normal velocities and gradients. So the next best step is actually do a transesophageal echocardiogram, and as you can appreciate, he has a very eccentric regurgitation that's coming outside from the surgical ring. So this is basically a paravalvular leak at the mitral valve position. And with two-dimensional TEE, you really do not have the spatial resolution similar to three-dimensional TEE, which these images are acquired in real time. And if this movie plays, you can actually see the, sorry, I'm just gonna go back. Do you mind playing this slide, please? So what you can see here is the bileaflet disc of the mitral valve, and then on 3D, I'm not able to isolate where is the leak coming from specifically. So then these real-time images, what you do, you actually add color to this 3D image, and now you can beautifully see the discs. You have the normal washing jets at the origin, and then you can nicely see there is a paravalvular leak, which seems to be located at the 2 o'clock position, assuming that the aortic valve is on the 12 o'clock. So you have a 2 o'clock position paravalvular leak that you can nicely reproduce on reconstructed two-dimensional images. And with that, you can actually able to trace, using those 3D color data, an anatomic regurgitant orifice area, which in this case turned out to be a 0.2 centimeter square. So sounds kind of fits in the moderate range, but the beauty about 3D color, we were able to isolate where the defect is, we were able to estimate the size, the extent, along with the course of it, and this will help guide the interventional cardiologist in order to proceed with a percutaneous closure. Obviously, no one wants to go and do a redo open heart surgery in someone who's young, already had two mechanical mitral valves, and this is what they do in the cath lab. Basically, you have a catheter that gets advanced across the interatrial septum. They basically isolate where the leak is, and then nowadays we are using PDA or VSD occluder devices, small, in order to plug the hole across this paravalvular structure. And you can see the final end result here on this patient, a normally functioning mechanical mitral valve, and you can see here a patent ductus arteriosus occluder that's all implanted percutaneously and all guided by real-time 3-dimensional transesophageal echo with color. So really kind of a take-home message that echo along with 3D TEE plays a fundamental role in diagnosing paravalvular leaks in addition to pre-procedural planning, and it also helps with intra-procedural guidance. Thank you all for your attention.
Let's just get connected here. That's not. You can use this one. Sure. Thank you all for attending today, and thank you for the opportunity to present on a quick discussion of peripheral MRI, and just some disclosures. In terms of MRI techniques, there are actually different things that can be done, and it's not just all contrast-based. I do want to quickly give an overview of non-contrast MRI techniques that are possible. Also, the fact that MRI angiography is still possible in patients who do have renal insufficiency. I know you guys are maybe perhaps aware that gadolinium is contraindicated in patients with GFR less than 30. Give an example of its use in an endovascular leak case, including some other time-based techniques, and also for cine imaging and assessing aortic dissections, and also to give a very brief overview of our future directions. So when we image all cardiovascular patients, we start off with what's called known as a bright blood technique, and this is a very fast technique, doesn't use any contrast at all. It gives a really rough lay of the land, and it gives us the ability to scan in any plane and look at the overall anatomy and relation of the vascular structures. We can actually null the blood too and do what's called dark blood imaging, and while this may be a little more limited in smaller vessels, especially in the calves, this allows us to look at the vascular walls and look for evidence of vasculitis, thickening of the walls, etc. Without contrast, we can actually do a technique called time of flight and also quiescent interval single shots. What this does is it nulls the surrounding structures and then allows blood moving into the plane to be imaged. So while we can't necessarily image blood that's moving within the same plane, we can image blood that's moving through the plane. And shown here is an example of a patient with a runoff using the KISS technique. Versus the same patient getting contrast agents, and you can notice quite clearly that this patient has SFA disease. Of course, we always talk about gadolinium contrast. This is a rare earth metal. It's ideal for MR imaging. It is, like I said, contraindicated in patients with GFR less than 30 or acute renal failure. There is an FDA black box warning about that because of the discovery that it can cause nephrogenic systemic fibrosis. So usually in patients with renal disorders, in most centers, MRA with contrast is a bit limited. However, there is the off-label use of using ferromoxetol. This is an iron nanoparticle, so it allows us to do intravascular imaging and still image patients looking at runoffs, etc. We do have to be careful, though, of course, in patients with iron overload in these patients. Keep in mind that it's ferroheme nanoparticles, iron-bound in nanoparticles that are used, not just any good old IV iron agent. Going very quickly, for an endovascular leak case here. We have a patient who's had prior AAA repair. And we can do something called a time-resolved angiography, where when we inject the contrast through, shown here is a 3D MIP illustrating the contrast transiting through the different phases. And shown over here is as each individual 3D data set at each individual time point, so that we can actually in patients who can't hold their breath, do time-resolved angiography, chase the pulse of contrast, pick out the ideal 3D data set, and do arterial phase analysis for you guys. Showing more of the same. We can also do, after injection of contrast, a technique called post-contrast 3D imaging. We call it VIBE based on the vendor here, Siemens. And this allows us to look at, after injection of contrast, again, at surrounding structures, whether or not there's delayed enhancement. And shown here is a very nice case of a hematoma in a repaired thoracic aortic aneurysm case, again, with contrast extravasating into the hematoma, indicating endoleak as well. And so this is also possible in the peripheral angiography as well. Of course, one of the great strengths of MRI is that fact that we can do dynamic imaging. And shown here is an example illustrating this place. Showing dynamic obstruction of the celiac artery in a repaired DeBakey type 1. And you can imagine in a case with iliac dissections or other runoff cases, we can also evaluate if there's any dynamic mobility to a structure. Okay. Of course, courtesy of Panraj, in the future, or actually the future is already here, for vascular planning, we can actually take these 3D data sets and take them to the fluoroscopy suite. And at our center here, we are able to actually fuse these images in live cases and allow them to do CT reconstructions live with 3D MRI data sets and allow for vascular planning. Of course, in the near future, we're also doing another technique called 4D flow. And this is kind of akin to vascular Doppler, where we can look at the actual blood flow through the vessels in all 3 dimensions and reconstruct a phase contrast angio and actually look at the flow dynamics as well. So this is on the horizon. So in summary, I like to conclude by saying that non-contrast MRI techniques do exist, and they do allow for peripheral vascular assessment to a limited degree. Dynamic imaging is possible with MRA, so we can do time-based techniques, looking at blood flow, looking at the contrast as it's transiting through the vessels, and also looking at any dynamic mobility to different structures. And while guideline contrast is preferred for peripheral vascular assessment, alternative agents do exist for renal patients. Thank you for your attention.
Well, so instead of running up and down, I'm going to go ahead and do this from here. So our next speaker is Dr. Sumin Chang. He's an associate professor of clinical cardiology, and he's actually one of our experts in cardiac CT. So he's going to be talking to us about CT cardiac imaging and image fusion. Dr. Chang.
Thank you, Hugh. Thanks for organizing and inviting me. I want to show you some pretty pictures, for sure. It's too early to go through too much data, but I'm going to show you some data, mostly from our experience for the last, I would say, almost over 5 years, collaborating with the interventional cardiology, vascular surgeon, CT surgeon, and just to give you a flavor, later on you're going to have some more in-depth lectures by Dr. Langston and by Dr. Lin regarding the role of CT for helping interventional procedure. Okay, let's see how to do this. Okay, traditionally, interventional procedures done in a cath lab using fluoroscopy, and the plain film has a significant limitation because it reduced the 3D anatomy into 2D projection images. So information regarding the dimension parallel to the X-ray beam are lost, so the depth is not perceived. So therefore, for current era of complex cardiovascular intervention, the demand is high because of complex anatomy, small dimension of the heart, rapid movement of the cardiac chambers. So we require imaging that could prepare a patient who has a technology who has higher spatial resolution, which CT is the best in terms of all the non-invasive cardiovascular imaging, high temporal resolution, fast coverage, and important thing is synchronization with cardiac cycle. And obviously, we need good contrast resolution and most importantly, 3D imaging. Just to give you some flavor of the latest generation CT scanners, is able to perform these images in 1.4 seconds. So, and we are able to deliver images like this with about 1 month of background radiation when you live here in Houston. So it's probably about 1 week if you live in Denver, Colorado. This case, protocol allowed you to do very low contrast, iodinated contrast. In this case, a patient with LVAD with 30 cc of contrast. And this is for Dr. Lamstein, the 4D imaging of the aortic dissection. And this is something we're working on currently. It's called time resolvable dynamic CTA, will allow you to see how the blood flow goes through certain cardiac chamber or structure throughout the cardiac cycle. And obviously, we can get pretty picture like this. I don't know what it's good for, but it looks nice. The clinical utility of CT fused fluoroscopy co-registration guiding the cardiovascular intervention because CT angiography right now is the gold standard imaging for pre-procedure evaluation because of all the impressive images that I show you. And now we have most of the, a lot of companies already have seamless integration of 3D CT imaging with 2D fluoroscopy. So it doesn't replace the real-time TEE, but I think it rather enhance the real-time imaging and also MRI guided procedure in some cases. So just a little overview of the how does this work. You obtain the CT angiography before the procedure. You work in the background in our CT reading room, 3D planning or marking a relevant landmark. Then you can register with the AP and oblique fluoroscopy called 2D, 3D registration, or you can do a combined CT in the hybrid suite, and that would be a 3D co-registration. And you can select optimal working projection from the CTA, therefore saving a lot of time, and ultimately overlay the 3D landmark and fluoroscopy. One of the first experience we had with a TAVR procedure, essentially this is the same workflow that I just mentioned, and this is how it looked like in the screen of the interventional cardiology. And this, like this case, immediately after deployment, we were able to, you see there's a little under expansion of the skirt of the prosthetic valve, and by co-registering with the prior CT imaging, you can see the problem was obviously evident. There's a lot of calcium in that area preventing for the fully expanded. So we have some experience in the beginning, obviously when our operator here was starting doing the procedure. We showed that by using this approach, we were able to decrease the number of planning angiogram. Like this case, almost 3 planning in patients who only have CT done versus a little bit just over 0.1 in patients who had this co-registration. We presented this data several years back. Now we have about to finish collecting about 200 patient experience, and hopefully we will be sharing it with you. Real quick, second group of patients who are working very actively is in prosthetic valve dehiscence or paravalvular leak closure. Mohammed showed you guys earlier the case, but all this was done prior to the procedure, CT planning. We can identify where the leak is, where the dehiscence is, and then essentially we can use the landmark, in this case prosthetic valve, in the fluoroscopy, fuse it with the 3D images. We'll co-register, and you can overlay exactly on the fluoroscopy screen where the paravalvular leak location is, and then basically showing a roadmap to the interventional cardiology exactly where to put the catheter to deploy the embolization device. We published our first experience in structural heart journal, about 25 patient, number of leak was 28. You can see that it's a very sick patient. This is ultimate, the last resort for this patient because they are not suitable for a repeat procedure. And this is just a baseline characteristic. As you can see, that in the co-registration arm, the mean time to cross the defect is much lower. We're talking about 10 minutes versus 35 minutes, which I'm sure Dr. Lin or Dr. Gold, they don't like to be spending too much time, so they can do more cases. And the procedural time is also total procedural time, duration of the time. I guess that's what it matters. Went down to about 2 hours to about an hour and a half. So you can shave half an hour. We're currently doing a randomized study to show that this is truly beneficial to the patient. And just not to forget our vascular surgeon colleague. This is one thing that we're working actively with Dr. Lamston. I'm not so sure why he's not playing the videos. Thank you. So this is the time result dynamic mode that I mentioned. This is a patient with endo leak, prior EVAR or prior procedure done, still coming back with recurrent endo leak. You can see this essentially. We can identify the feeding vessel and perform 4D, 3D CT fusion in the cath lab, and Dr. Lamson was able to selectively go after the feeding vessel instead of doing an aortogram in the cath lab, try to identify. And we have about 20 patient experience. We're going to be presenting it in the vascular surgery conference in Toronto later this year. But not the CT, the role of CT is not only limited to structural heart intervention. In complicated coronary intervention, such as coronary total occlusion, we've been working with Dr. Alpesh Shah in this. The limitation of fluoroscopy is obvious. We're not going to go through it. The advantage of CTA is, again, the same excellent 3D visualization of the important thing, the wall, and the calcification, which you cannot see very well with the invasive angiogram. And most important thing is, even the vessels occluded, you have structure that allow you to see the entire path that takes beyond the occluded segment where allow you to do the planning. You can see this is the baseline angiogram. It's a patient with occluded RCA, still had chest pain. We did a CTA with arterial imaging and delay imaging, hopefully to maximize the amount of contrast and to delineate better the vessel path. This is multiplanar reformat imaging and actual imaging, and we can do the planning, map it out, and show in the three-dimensional fashion. You can see rotating, mapping out exactly the path of the occluded vessel. Then time to go to the cath lab. You can project it in the screen. Obviously, this is not a perfect co-registration because of the cardiac motion and respiration, but by studying well the anatomy before going to the cath lab and having a reasonable path is very helpful, according to Dr. Shah, to give him confidence in terms of where to pass his wires and making sure he's not going to side branches and so on and so forth. And again, this is just One of the processes is all performed by Ponraj, who is enormously important for this program. His help is invaluable. So again, this is kind of like the ultimate roadmap for the interventional cardiology, and this is the final result. This case, this is a patient who was referred to us after failing a CTO, and they worked on the cath lab for 2 hours, and using 400cc contrast still couldn't cross the lesion, and I think he was able to perform this in under less than an hour. I think the future is I call multimodality interventional suite. Our vendor, the company that we work closely, has this angio MRCT solution system. Specifically, we can incorporate this multi-detector CT in the angio suite or operating suite. Hopefully, you can do the quasi real-time visualization and immediate feedback of the intervention, and hope to better improve the procedural guidance and ultimately the patient's outcome. And I thank you for your attention. Any question, please contact me. That's my email.
So our next speaker is Dr. Moaz Amala, who is the director of our cardiovascular CT and PET program.
Have slides up. Okay, so I'm going to take you a little bit into a different direction with cardiac PET. I'll show you the different applications that we are doing with cardiac PET, and I'll take Sumin's approach of showing more images and less data in there. So as you know that nuclear cardiology is a relatively new field, started like way before in 1977, but technology has significantly improved, and cardiac PET in specific started to flourish after 2000 when FDA started to approve tracers for cardiac imaging. And now we have systems that allow us to do a lot of nice applications, which I will summarize here. And with PET, one time one person walked into my office and just like, tell me in 2 words, what's the difference between SPECT and PET? I'm used to gamma camera, thallium, what is this PET thing? I told him, like, think of 2 cars, you have the lower end and the higher end. So PET is like kind of the higher tier among nuclear cardiology applications, and there are many more things that you can do with PET that you're unable to do with SPECT imaging. And this is in part because SPECT imaging has lower energy, so it doesn't allow you to see as much, and especially in patients who are obese and attenuated. But despite that, because of the shorter half-life, the radiation exposure is about 20% of what you get with SPECT imaging. So what do we do with PET? So first of all, we do perfusion. That's kind of the bread and butter, and we do it better than SPECT. I'll show you data. We can do viability. Also, this can be done with SPECT, but we do it better than SPECT. We can do inflammatory imaging that can only be done with PET. We can do infection imaging, which is way better than SPECT than we can do, and now we are even expanding to other infections like vascular graft infections and others. So let's start with perfusion imaging. This has been around for some time. People use it all the time to rule out coronary disease, assess patients with chest pain. But if you have an obese patient, if you have elderly patient who cannot lay on their back for like good 20, 30 minutes, it may be a problem. And this is a case from the literature with a BMI of 43, 43-year-old lady. This is the kind of images that you get with SPECT imaging. This is the same patient if you apply attenuation correction where images improve, but they are still suboptimal. And now this is the same patient getting a rubidium PET. So same study in different patients, and you can quickly assess the difference in the image resolution and the certainty when someone is interpreting these studies. Now we have newer tracers, and there are studies that looking at SPECT and PET in the same patient. This is the same patient, had a stress, SPECT, which any one of us would have called normal. Now he had the PET, and clearly a significantly abnormal study with major absence of radiotracer in the anterior wall. So when compared in the same patient population head-to-head, clearly PET was the most sensitive compared to CTA, compared to SPECT, and compared to just clinical assessment with cardiovascular risk factors. There are many reasons why PET is better than SPECT. I just want to show you one of the reasons, which is the myocardial blood flow assessment, which is currently clinically available on PET, but not yet clinically available on SPECT, where we do dynamic imaging similar to what you just saw with CT, and we just get good images and track it over time. We measure how much blood flow goes inside the myocardium, and we can tell with certainty how much blood is in there. And if there is normal myocardial blood flow, the chance of missing significant coronary disease is less than 3% across the board of patients, which is much better than other imaging modalities. And we can do all of that with minimal radiation dose. This is comparison between SPECT and PET. You can see thallium SPECT, which was used for a long time as the main test to assess for coronary disease, has much higher radiation, and now we're almost like 10% or 20% of what you used to do. But this is not what we do with PET. We do imaging in heart failure. A lot of our patients come from heart failure. And one of the reasons is to do viability imaging. I'm not going to dwell a lot on it because you ordered this test, and it can be done with SPECT, can be done with stress echo, but also can be done with MRI. And this is a patient who has a perfusion defect and which is fully viable, as you see here. The apex is scarred, and this is the patient MRI, where you can clearly see the viability is matching exactly what we see on PET. But then we have some scarring in there. Now, obviously, with MRI, you can see a clot, which we don't see by PET. And there is good agreement between assessment for infarct, transmurality, or infarct size. Now we have systems, a PET and a MAR, in the same patient. These have been around for 10 years, and viability and other inflammatory cardiomyopathies are studied simultaneously. And now we're seeing groups of patients where we can fuse images of both PET and MR, and you can see here that there is concordance. There is also concordance, but there is a scar on both studies. There are scars on both studies, and here there's some discordance, which allows us to study why we have metabolic discordance, while on anatomy we don't see a scar, which probably requires further studying and trying to understand the process of scarring in myocardium. We do imaging for cardiomyopathies. This is a patient who walked into an emergency room complaining of chest pains. Within a few minutes, he passed out. He had VFib arrest. The right place to have a VFib arrest. Got shocked, immediately come back, did not even require an intubation. Coronary angiography normal, LV ejection fraction mild reduction. He had an MRI which clearly shows some delayed enhancement there. There's another focus of delayed enhancement here. And he was referred to us because they thought that he might be having an inflammatory cardiomyopathy. So we went ahead and did cardiac PET using the inflammatory cardiomyopathy protocol, and you can clearly see that this is normal, but now you start to see foci of uptake most prominent in the inferior wall and same area in the septum as we saw on the MRI. So this patient clearly had the diagnosis of inflammatory cardiomyopathy, which could be sarcoid, but could be with lupus, could be with eosinophilic cardiomyopathy. And in another patient, we can, although the heart was normal, but you can see significant FTG uptake in the lung, tells you that this patient has something major, and this patient is known to have pulmonary sarcoid with very active inflammation. So we detect it in the heart, but also outside the heart. Going back to the first patient, this is his images. He was put on high-dose steroids. 3 months later, we re-imaged him. It's all gone. There is no uptake in the myocardium. all the FTGs in the blood pool. And this patient now is going through a taper of his steroid because he had significant reduction in his FTG uptake in the myocardium. We can also assess these valves that are sometimes difficult to assess by echocardiography because of shadowing and try to see if there is endocarditis. So this is a metallic valve. There is no uptake on PET. And this is another metallic valve that has significant FTG uptake. And this is a patient with actually endocarditis and ring abscess. So these are sometimes difficult to make as certain by echo whether it's active or it is old. Even by CT, if there is an abscess, we don't know if it's sterilized by antibiotic therapy for some time or not. And here we assess the physiology of the anatomic defect that you can see. This is another patient who has significant root abscess, but also has his root and ascending aorta is all inflamed. And this patient had a root graft in there and ascending aortic graft, and it's all infected in there. And this is another one which is just limited to the valve. And sometimes you can see it on TAVR cases. This is actually from the European Heart Journal, where you can see here there is TAVR endocarditis, which is not uncommon and presents a management dilemma. And you're not sure you want to take the patient unless you are pretty certain about the diagnosis. These patients have multiple comorbidities, and many of them got TAVR because they were thought they're not good surgical candidates. So now subjecting them to a high-risk surgery may not be an easy decision. We can also look at LVADs. You've seen some images with zoom in, but we can also look beyond that, look at the physiology of thrombi that we see, and if there is significant FTG uptake in there, whether these patients have significant infection in the LVADs. And this is something we are doing right now here. This is a patient of Dr. Lumsden who actually came in. He had a graft in his groin, and he was somehow cath through it and resulted in an infection. And his point was like, tell me where it starts and where it ends. And we started all the way from the knee, as you see here. And now I'm going up, and now you can see the graft with a lot of uptake around it, which you don't see on the other leg. So if I put it here, that's all this uptake. And we go up all the way to the groin. It's still infected until it starts to go away here. So you had the full SFA from the common femoral to the SFA all the way to the end of the graft that was infected. And you can see here how much FTG uptake you see here. And then finally, we're looking at other applications. This is still research, not mainstream clinical work, which is looking at, you see if sometimes abdominal aortic aneurysms, some of them stay stable for 10 years. Some of them, you see them 1 year, the next year is 5.5, and you need to operate on them. How can you predict which one will progress? And in this study from the UK, where they looked at some of these, if there is significant sodium fluoride uptake in these, then this predicts rapid progression. And you can see here that this is an aneurysm. There is a lot of uptake on it. And what they saw is that if there is uptake on the third tertile in their study, then the rate of expansion is much higher, the risk of rupture is much higher, and the need for abdominal aortic repair is much higher. This is a single study waiting for replication. Hopefully it will be a useful clinical tool in the future. And now we're starting to experiment here with some of these, because when we inject rubidium for our perfusion studies, we can do it in a dynamic fashion. So now we take images. So now I see rubidium coming in this superior vena cava. Now it's getting to the pulmonary artery. Now I see it in the aorta. And we take dynamic assessment of these patients. So if I run it as a movie, you can see it all happening very fast. Whether this is going to be useful, now it's being tried to look at for renal perfusion and renal artery stenosis and others, but there might be some other potential applications in aortic dissections through lumens, false lumens, and other. And here you see it like this is the RVOT, pulmonary artery, and now you see it later on in the aorta. So, and this is like relatively free information that you get when you do any stress test. So this is the way we acquire our images allows us to take these images frequently. So in summary, you can see that we've done a lot of procedures. All of these are clinical, but we have many more on the research frontier. I'm happy to take any question. Thank you.
All right, so next up is Dr. Maham Rahimi. Oh, there he is. All right, he's one of our vascular surgeons, and he's going to be talking to us about vascular imaging. Good morning, Maham Rahimi, Vascular Surgery Department. Thank you for giving me the opportunity to present with you. Angiographic imaging, the basics. If you could advance the slide for me. First, I'd like to introduce you a few historical figures that are important to understand how we got here. First is Werner Forsman. In 1929, he showed that you can insert a catheter from brachial vein into the heart. And he basically take a picture of it and showed it to the hospital, and he got fired. However, in 1956, he received a Nobel Prize for this. So this was the first time showing that you can pass catheters inside the venous arterial system. Next is Charles Daughter, or Crazy Charlie. He was the first person that showed that in 1964 that you can use balloon to open up arteries. And he tried that in Oregon Health and Science University on an 82-year-old female that otherwise would have get amputation of his leg. And he prevented that by doing this procedure, by using a balloon, opening up the narrowing inside the artery. Next person is Juan Carlos Parodi. In 1990, he used endovascular aortic repair by placing endograft inside the aneurysm and repaired the aneurysm from inside the artery using a C-arm. Hopefully by now you got your attention that angiogram is important, and we treat multiple different disease processes using angiogram. However, it's important to understand the radiation safety. Fluoroscopy is essential for me to perform my job. However, the pictures on the right are two of the giants in cardiovascular surgery that passed away from cancer. If you could play the video on the bottom. This is a short video. I recommend you see it if you have a minute or two. But I'm going to just show you the first beginning part of it to stress the importance of radiation safety. This is Dr. Go ahead and play the video, please. Edward Dietrich, that was trained by Dr. DeBakey. And he's basically telling you his experience.
I put my hand up on my button, and the garage door came down. And then I reached over with my hand to open the door, and I couldn't find the door handle. I lost complete control of my hand. By the time I arrived at the emergency clinic at Barrows, I was in a full-blown seizure. So then they put me in the MRI, and the next thing I remember, I wake up. The surgeon comes in, a young guy. He says, "Well, you've got a brain tumor. We have to take it out, and then we decide how we treat it."
What we see here are your post-op study. We see a small cavity there with a tiny nodule of enhancement along the anterior lateral margin, which is hopefully post-operative change.
And they said, "We removed the brain tumor. We think we got it all out." I said, "Well, what's next?" And then they talked about the next therapy. At that moment, it struck me that I will never be that cardiovascular surgeon again that I was.
You can stop the video there. Again, experience from Dr. Dietrich. He performed a lot of angiogram, angioplasty, and the cardiovascular world.
Not only he developed brain cancer, he also developed cataract and plaque in his carotid artery, most likely all related to the X-ray exposure. It's important for a vascular surgeon or cardiologist or anybody that uses X-ray for safety of themselves and others in the room to protect themselves by ALERA as low as reasonably achievable. And that's decrease the X-ray time and increase the distance from the X-ray machine and use shielding. Now, in next few slides, I'm gonna show you how I perform my daily job. First is I perform a CT scan in order to identify the disease process that I need to treat. Then I will use an ultrasound in order to access the artery or vein in order to introduce wire inside the disease vascular tree that I'm treating. And then I'll perform angiogram, and if the patient has chronic kidney disease, I'll perform CO2 angiogram, which I'll show you later on. And sometimes I require to place an intravascular ultrasound in order to image the inside the blood vessel. Because if you look at the artery in 2 dimensions, you see no disease over here and open artery. But if you look at it from the side, the artery might have a lot of disease and actually pancake and narrow due to the external compression. Therefore, intravascular ultrasound will give you that 3-dimensional picture, and I use it to treat aorta for aortic dissection or iliac vein intervention, as I'm going to show you in the next slide. Before that, I'm going to show you just some examples as how this process in my job works. It's not only angiogram, but it starts with a CT scan. This is a patient presented with a pulmonary emboli with showing here in the blue arrow embolus into the pulmonary artery on the left side and then the right side. This gives me understanding that diagnosis of the pulmonary artery. Then I take the patient to the operating room, perform angiogram in order to identify exactly the location where I need to treat, and then I'll treat it either using a lysis catheter or using NRE in order to remove the clots. Here, angiogram is performed. You can see the clots on the left and right, basically confirming what we saw in the CT scan. I can start my treatment here. Next few videos are going to show you how we access the different location in the body in order to treat the vascular tree that we need to. This is a patient that has peripheral arterial disease. On the bottom picture you see left medial malleolus, and a top picture you see the ultrasound image as in live as I'm accessing the artery. I'm using the back of the needle in order to locate exactly where I need to access. Then I flip the needle over and access the artery using ultrasound guidance. I use angiogram in order to treat this patient from contralateral common femoral artery. However, I was not able to, and this is the next step that I use in order to treat the peripheral arterial disease. Here I access the posterior tibial artery. I advance the wire easily without any difficulty, whereby before, when I came from contralateral common femoral artery, I was not able to treat. Now I will be able to. Again, what I'm showing here, the trend here is the integration of all the image modality I have, preoperative, intraoperative. Here, showing how I access the common femoral artery. Ultrasound shows exactly how the tip of the needle is, and you can see the right common femoral artery where I access with the needle, and then common femoral vein. And easily you can use that as a next step in order to perform your angiogram. Then I'm going to show you angiogram. I'm advancing a wire here from right common femoral artery into the aorta, and basically advancing the catheter over the wire into the aorta, and then I'll perform angiogram, and then I'll show you the example of a CO2 angiogram. What does that look like? And based on that information, is a two-dimensional information that I can use in order to treat the patients. Here I advance the catheter into the aorta at the level of L3, and then I'll perform my angiogram. Basically, this is a normal artery. However, there were several diseases below, which I'm not showing over here. Next picture, I'm going to show you a CO2 angiogram. This is a CO2 angiogram. Literally, I'm injecting CO2 gas into the arterial tree in order to see the vascular tree where the patient have chronic kidney disease. This is I'm accessing the right IJ in order to advance the wire into the superior vena cava in order to perform my next procedure.
So again, I'm using multiple imaging system. If you go to the next slide, using multiple imaging system in order to identify where I need to treat. In this picture here, again, if you look at the picture on the left, you don't see any disease processes. You see that there is a normal flow from the iliac vein inside the inferior vena cava. However, there's a hint of possibility of disease there, that you can see a collateral coming off the common iliac artery. You should not see that. That tells me there's a disease, there's a narrow compression of the outflow going to the inferior vena cava. So I performed the right picture. This is intravascular ultrasound. With the intravascular ultrasound, I literally put the ultrasound inside the vein and I visualize where the disease process is. So if you pay attention on the right picture, I am inside the inferior vena cava, coming down, everything is normal. However, at the instance where I mentioned to you in a minute, let's see if I can access the slide. That's all right. There is a compression. This is an inferior vena cava you can see over here. I'm coming down, pulling back the catheter into the iliac system. And then momentarily you're going to see a severe narrowing on the iliac vein, which is evident right over here. And you can see on the top of it where the iliac artery passing over. So basically the iliac artery is pressing on the iliac vein, causing the narrowing. On the 2D picture, on the angiogram, you could not see that. Again, you see a picture like this. But in reality, there is a severe compression. Next slide, please. And then I place a stent over there, if you could play the videos. And you can see that you can now see that collateral anymore. There is no cover stent. This is just a bare metal stent. That tells me that the stenosis has resolved. This is on the right picture. You see the stent. There is no more compression, external compression on the iliac vein, and is widely open. This patient presented with severe left lower extremity swelling, which by this treatment, the symptom gets resolved. In next few slides, next few minutes I have here, I'm going to talk to you how I use CT scan preoperative and intraoperative, and I use CT, dynamic CT and fusion imaging in order to guide me how to perform my operation that I need to do. This is a patient on the left side showing dynamic CT, a patient with type A aortic dissection. On the white, you see on the aorta that's a true lumen. On the darker adjacent lateral, you see the movement of the aortic dissection flap and then followed by the false lumen. By this image on the left side with a CT, dynamic CT, I'm able to exactly say where the innominate artery is, where the proximal tear is. And the right picture, you can see I fuse the images together, and I'm able to show exactly where the innominate artery is with that yellow circle there, and where the proximal tear is, and place this and appropriate and treat this patient. Next picture, this is one of Dr. Lumsden's patients. Thanks for the images. Patient treated with endovascular aortic repair. You can see the stent graft there. However, patient continued to have the expansion of their aneurysm sac, and we were not sure why, so we performed this CT scan, dynamic CT. If you could play the video one more time, you can see that there is a flow through the lumbar artery into the aneurysm sac, and then followed by the lumbar artery draining. So we use this image in order to take the patient to the operating room, access the aneurysm, it shows on the right side, after fusing the CT images with the angiographic image, and accessing the aneurysm sac, advance the wire into the lumbar system, and basically coiling them and stopping the flow inside the aneurysm sac. In summary, where we going in future, we basically using all these different imaging tools. We bring the patient in the operating room, fuse them with the angiogram that we perform in the operating room, and basically by integrating these images, we can appropriately treat these patients, whereby before was not possible. And we had only angiogram. But in this picture showing the future, that we can register this information into a robot, and we can perform this from distance be less radiation, so we have radiation safety for the physician, also staff. Remotely, we can go ahead and perform these operations. Again, thank you for giving me this opportunity to speak with you today.
So Dr. Clement is running a little bit late, so why don't we go ahead and take our break early. What I'd like to do is go ahead and have everybody back in here by 10:15 so we can resume with Dr. Clement's talk. I do want to encourage all of you, because this is a little bit more of an intimate crowd, I do want to encourage you guys to connect with our speakers. Definitely approach us and ask questions. Okay? Thank you.
Hello, I'm Dr. Alpesh Shah from the Houston Methodist DeBakey Heart and Vascular Center. I'd like to invite you to join us in Houston, Texas for the 4th annual Cardiology for the Non-Cardiologists Conference. This special event will be held on June 27, 2020 at the Houston Methodist Research Institute in the Texas Medical Center. This one-day conference teaches non-cardiovascular physicians and healthcare providers to identify common risk factors, guidelines, and treatment approaches for cardiovascular diseases. You'll learn about the latest medical and surgical therapies for heart disease and advances in managing common clinical cardiovascular conditions. Our expert faculty will also discuss the clinical challenges often associated with caring for patients with heart disease. The course is designed for physicians, mid-levels, and nurses specializing in cardiology, internal medicine, primary care, family practice, critical care, and emergency medicine. We also encourage residents and fellows in training to attend, as well as physical therapists, radiology technologists, and sonographers. I hope you'll join us and look forward to seeing you in June. Thank you.
The importance of this conference, and I think the uniqueness of it, is bringing people from different facets of imaging to talk about, one, what is the latest, two, how do we apply it in clinical medicine, and three, how can we be better clinicians and serving our patients, learning about all these imaging modalities.
The beauty of this conference is that it looks at the role that imaging, all techniques of imaging, have in the diagnosis and management of heart disease. And I think that's absolutely critical today, because imaging of the heart is really the gateway to diagnosis and management. This gives you a chance to look at the breadth of these imaging modalities, learn about something you don't know about, get a better appreciation of it, and really understand how all the integration of these imaging is going to make a major difference in the future.
Every time you come, you learn a little bit more. You get familiarized with the scans, you get familiarized with what's the latest out there, and you have to constantly be adapting to change, because we have to stay up to date with the latest inventions, the latest scans, the latest protocols that will better help the patient.
Hi, my name is Mahesh Ramchandani, and I'm a cardiac surgeon at the Houston Methodist Hospital, and I'd like to invite you to the 11th Annual Re-Evolution Summit. Our goal is to introduce you to the current state of minimally invasive cardiac surgery. The international faculty are chosen because they're leaders in the field and because they are great educators. There will be lectures, panel discussions, demonstrations, and a rich and rewarding hands-on experience in our state-of-the-art training lab. The topics will include minimally invasive techniques, both robotic and non-robotic, for coronary bypass surgery, aortic valve replacement, mitral valve repair, and atrial fibrillation. You'll also be introduced to sutureless valves and other innovative technologies that help to facilitate minimally invasive cardiac surgery. There will also be instructions on how to use advanced imaging to your advantage, This conference is for anyone who's interested in cardiac surgery as it should be practiced in the 21st century. There is an excellent social program and the networking opportunities are wonderful. You will certainly enjoy these greatly. So, come join us April 2nd and 3rd, 2020. It will be a very rich experience that will not disappoint you. You will take away many nuggets and pearls that you can use in your practice. Re-Evolution is a meeting that started 10 years ago. The goal over here was to teach people new techniques that they could use in cardiac surgery, specifically minimally invasive techniques. The meeting is geared towards physicians in practice, but also trainees that are doing their training in cardiothoracic surgery where they don't necessarily get exposed to minimally invasive techniques such as the kind that they need to use in practice.
As an early career trainee in cardiac surgery, going to this conference means a lot to me, to be able to be exposed to the entire realm of minimally invasive cardiac surgery, to be inspired by world-leading experts and all the new and upcoming technologies that are coming forth for our field, and to be able to be inspired to innovate and to learn these technologies so that I can one day apply these in my practice and to be able to keep our specialty surviving and thriving.
There is a significant increase in awareness that these are less invasive procedures that do have a significant benefit. And to be able to come and train in these if they don't already know how to do these or are not familiar with them is something that will certainly benefit their own practice in their local environments, but more importantly, it'll benefit their patients and allows them to be on the cutting edge of cardiac care. To be able to do these and get the hands-on experience at Re-Evolution Conference is an excellent opportunity.
There are a lot of conferences and everyone gives lectures and data, but this is one of a kind where you go in hands-on, using the new technology, experimenting it, getting a feel for the technology, and learning hands-on exactly how these procedures are done and why this technology is so important.
The ISCVS symposium that we are holding here at Methodist Hospital in Houston, Texas, is the largest hands-on symposium in a variety of interventions in the world. It has not been done or achieved anywhere else. This is something that's so unique because we have here state-of-the-art technology, the newest innovations in endovascular field to train and teach physicians how to use and implement this to provide better patient care.
Having such a great wealth of resources and having different X-ray techs at every station, having all of the equipment available to do the jobs that we wanted to do, it was really a great opportunity. It was like having a big endovascular playground where you could test out all of the different equipment in a controlled environment. As a physician assistant, being able to work with the different surgeons and really grow my depth of experience has been a great opportunity.
Well, there's certain things that you can't learn in the classroom, and obviously when you're working as a clinician, the mistakes are costly. So here, you can experiment with the devices, you can try things you've never tried. You have experts kind of guiding you and giving you advice as to how to deal with complications and the procedures. And that's always what I'm looking for. I'm always looking to increase my speed of learning and content. And I think that this hands-on approach is very effective for that.
Dr. Kleiman. On stage right now. Put me off part of the pass.
So it'll be 10:34.
Okay.
All right. So we're going to go ahead and continue with our next session. So it's my distinct pleasure to introduce Dr. Kleiman, the director of the Cardiac Catheterization Laboratory, and also, more importantly, my boss.
Okay. So this, I didn't have much idea who I was going to talk to or what I was supposed to talk about. So I called up Dr. Lin and said, Dr. Lin, what am I supposed to do? And he said, well, give him a whiz-bang summary with lots of pictures. So I'm going to give you a whiz-bang summary with lots of pictures. Now, some of you folks are deeply into these fields. This is going to be really boring. I see there is coffee outside, so you may want to get yourself adequately caffeinated. For other people, This may be of intermediate familiarity, and for some people, you may never have seen pictures like this before. So they are rated G, but they'll probably still be exciting. So here comes the whiz-bang summary. So here's the evolution of interventional cardiology. So I started with the creation of the universe, for which Dr. Lin and I were responsible. Big bang. And what I've done is I've shown you the progression of things that we do in the cardiac cath lab. So first cardiac cath was done by a urologist on himself in the 1930s in Germany. He was rewarded by being fired for doing that, but then about 20 years later, he got a Nobel Prize for doing it. Never made any other contributions to medicine. 1938, first coronary angiogram, approximately 1960 or thereabouts, by a cardiologist in Cleveland. He didn't do this on himself, but he did do it by accident. He was trying to take a picture of the thoracic aorta. Back in those days, they didn't have the imaging capabilities we have. They used huge cut films, so each film was about the size of this lectern. And as he injected into the aorta, the catheter accidentally, or in an unplanned fashion, bounced up, looped, fell into a coronary artery, and they ended up with pictures of the coronary arteries. Everyone was shocked that the patient survived, but Soanes was pretty smart. He said, wow, I think I'm into something big. So approximately 1960. Now we move forward only another 17 years. First PCI done by Grunzig in Switzerland. And what you will see is that if you look at these things, they're occurring with increasing velocity. So the distance between the labels and arrows is meant to be getting shorter and shorter and shorter. I don't know if these will eventually reverse or not. That may happen, but it depends on social more than medical things. Okay, so first let's start with TAVR. Probably everyone knows this. Survival in unoperated patients with aortic stenosis. Once you have aortic stenosis and you develop symptoms, things are either very bad or very good, depending on whether you get surgery or not. If you don't get surgery, you get symptomatic and you die. If you do get surgery, you feel a lot better and you live a lot longer. Not quite as long as someone without the disease, but it's still a pretty good deal. The problem, of course, is there's a challenge, and the challenge is you have to survive the surgery in order to benefit from it. I bet that's a surprise to most people. Okay, so as you are undoubtedly aware, newer ways of doing things have been developed. And what I've shown you here is as this advances, we've worked in opposite directions. So shown here on your left is Dolph Bachmann. He is the first guy to undergo PCI in 1977. Dolph is kind of a smart guy. He's ridden this to fame. He is still alive, making the circuit, getting lots of camera time, saying I was the first PCI. So healthy guy. He's lived from 1977 to 2020, however many years that is. 43, right? Shown on the other side is Alain Cribier, 2005, with his first transcatheter aortic valve replacement. Take a look at the guy under the image intensifier. First of all, if you're young, unlike me, what you may not know is that huge cylinder that's threatening to squash this guy like a pancake is an image intensifier. We still use the term, but we don't use the device. This doesn't look like the flat detectors we use now, which are slightly bigger than Dr. Lin's laptop. This is a big sucker sitting on top of a critically ill guy who's in cardiogenic shock from aortic stenosis and was dying of gastric cancer. He lived another 6 months. But he agreed to have this done. He spent a better remaining 6 months of his life than he would have otherwise. So just to move really fast, this is not to me a lecture on the medical aspects of it, but TAVR successes. We've gone from sick old guys like that to healthy 73-year-olds. Extreme or inoperable risk to low risk. Now we talk about it all the time. We crow about it, but say, oh, this is going to replace surgery in virtually everyone. I don't know whether that's true or not. It may be, but there's a lot of self-adulation here. There are limitations to it. We pat ourselves on the back probably too much. So unlike surgery for aortic valve disease, this is entirely dependent on imaging. And without imaging, we would not have these successes. Until we moved surgeon, back in the day, they did this based on physical exam. They sent patients to surgery based on physical exam and hemodynamic pressure measurements. We don't do that anymore. We get the measurements by echo and Doppler, which are critical for making and confirming the diagnosis, and we use CT angiography to prepare the procedure. And this just shows you a diagram showing some of the things that we do. So up in the state of Washington, you see the aortic annulus. This is not a physiologic structure. However, this is our landing zone. This is the plane created by the basal portions of the three sinuses of Valsalva. And then as you move up, as you know, the aorta gets larger. These are the sinuses of Valsalva. Those are critical measurements for us to make. We turn patients down. We sometimes do alternate things like protect the coronary arteries with stents, simply because if these sinuses aren't adequate, then as the new valve goes in and pushes the leaflets to the side, we run the risk of obstructing the coronary arteries, which, again, no surprise here, is not a good thing. We also make measurements of the aortic root, and we assess the amount of calcium in the valve. If there's too much calcium, we get worried because we're worried that we'll break something, tear the aortic root, which is also a very bad thing. The mortality of that complication is about 90%. Or we can tear the intra-aortic septum, which is also a bad thing to do. The mortality is not quite as high. Some people live with it. Some people do require percutaneous repair. But these are decisions we have to make. As you can see down in Florida here, there is calcium extending below the aortic leaflet. That's usually at the junction of the non-coronary and left coronary cusps. That goes down into the LV outflow tract. That can pose other problems as we try to expand the stent in which the valve is. The other thing that we have to do, and for which we are very dependent on the CT scan, is assess the access. If you don't know, these are legs, and we know how to use them. This is our highway to get these fairly large, bulky devices up to the heart. These are important decisions. What size sheath do we use? Can we use a femoral approach at all? Or do we have to choose one of the alternative approaches, which we use probably less than 10% of the time, subclavian or carotid approach? These are all critical decisions we make based on CT imaging when we implant a valve. Now, the other thing you see is a center line down in the Florida slide here. We've also tried to go above and beyond this, and some of the things above and beyond are important, and some have turned out not to be. We tried to, for example, plot the trajectory, the optimal trajectory of a valve as it's going into place, of a prosthesis as it's going into place in a native valve. We thought this would be useful for direct aortic approach when we open a portion of the chest to get access to the aorta in a patient who doesn't have other access issues. Well, as it turned out, it turned out not to be necessary. It really didn't help us much because the surgeons were very good at making those aortic punctures in line with the heart, and B, we almost never use a direct aortic approach anymore. So even if this had been useful, it would be dated and not useful by now. Okay, once we have the measurements, we then follow Einstein's dictums that make telephone books for a reason. We go to a chart. We take the measurements, and these charts are readily available. Based on the measurements we've got, we can choose valve sizes. And each valve that's available has a different sizing chart. Now, do I remember all these numbers? No, but I do remember where to find them. Well, 3 commercially available valves, 3 charts, multiple sizes for each valve, multiple parameters to fit. There are also other things we do based on the CT imaging. We don't always have to do them, but shown on your left is a case in which the calcium was very eccentric. As we expanded a balloon here, we actually could see the balloon and valve tip over and tear the aortic root. We saw that occurring, and actually we were able to save that patient very nicely. The other thing you can see here is the interventricular septum is quite thickened. That's often a consideration in implanting valves. Do we have to keep the patient beta blocked? Can the valve be implanted? Do we have to talk to our septal ablation guys about thinning the septum? And we also look for calcium distribution within the valve. So here's a balloon expandable balloon expandable valve going up. You can see the balloon and the valve together, and I think this picture is worth 1,000 words. The valve is contained inside that frame. There's really not too much else to explain. Yesterday, I could not find a self-expanding valve deployment that showed the whole thing. I just had parts of it. I didn't think we'd have time to do that. But there are other things that come up. And so this is a patient in whom we were not able to expand a self-expanding valve fully and couldn't get the catheter out. So what you see here is a cone beam CT we did in the lab. So it's not quite the quality of the multi-detector CTs we use for planning, but this turned out to be very useful in telling us what was going on. So what you can see is that rather than a round or oval appearance in the valve, this frame looks a little bit like an amoeba. And you can see the catheter is entrapped in this narrowed area that should normally be expanded out, but it's being held in place by the calcium. And you can see that a little better here. So knowing this, we know that we have to either do something to move the catheter, which is this thing, back into the center, or to get a balloon in there and expand the valve further. Okay, here's another issue. This is a transesophageal echo. When we do these under general anesthesia, about half the time, when we do that, we do it with a TEE. Now, I'm not the world's expert at reading TEEs. I'm actually pretty bad at it. But what you can see here is this TEE identified a very serious problem for us. This is the aortic root, slightly above the valve. Here is the lumen of the aorta. Here's a false lumen. So in this case, the catheter had dissected the ascending aorta, and we had to do some things which unfortunately weren't successful at repairing it. Okay, so we are running much behind time compared to what I thought. Let me show you a couple of other things. Mitral valve in valve. I don't need to tell you a lot about this. This is a guy who's very sick, was not a surgical candidate, prior prosthetic valve, very severe stenosis of the valve, very sick. I'm not going to insult you by asking you what you do with him. You would not operate on this guy. You would try something percutaneous. Here's some echo imaging of the valve. Transesophageal echo, obviously very useful, showing you that this valve barely opens. Just a little more. Take a look at his Dopplers at rest. Heart rate's, I don't know exactly what it is, but it's pretty low. His mean gradient is 18 millimeters of mercury. So here's what we did. We crossed the interatrial septum, expanded a balloon to dilate the septum so we could bring equipment from the right atrium to the left atrium. Now here we are. Actually, is this him? Yeah. Here we are across the septum, bringing a balloon expandable stent from the femoral vein up to the right atrium, crossing the septum. There's a wire coiled in the left ventricle. We're following that wire that looks like a pigtail. You can see there's also a pacemaker in place. And here we are moving it a little forward. And on your right, you'll see that the valve is expanded within the pre-existing valve. And here's our final result. 3 or 4 millimeter gradient now, no mitral regurgitation. So combination of echo and fluoroscopy, a little bit of angiography, and mostly this is an echo-guided procedure. So this just shows you a little bit more echo, transeptal delivery of the balloon, which is not shown here. You see the balloon inside the valve, delivering the new valve, and now you see the new valve in place with at least aesthetically pleasing leaflet excursion. Mean diastolic gradient of 3 millimeters of mercury. Okay, we are a minute behind. I don't have time to show you the rest other than this is a valve in ring. So this is a band that partially covers the mitral annulus. This is particularly challenging. We're extremely echo dependent because most of these patients end up with paravalvular leaks because there's still soft tissue surrounding the valve. We haven't got a good seal, and we're dependent on this to decide what to do next. So I think we stop here. And I don't want to run into the chief's keynote address. I'd be in serious trouble if I did that.
Please stay up there for just a moment. Here we go.
Neil?
Hi, Alan.
Yeah, you took 2 minutes.
What?
But I'm up here in the hybrid operating room. Are you going to come up?
Alan, there's a transmission issue here. What are you saying?
I said I'm up here in the hybrid operating room. But I'm waiting on you.
You want me to go to the hybrid OR?
Yes.
Okay, on my way.
All right. Thanks, Neil.
Are you serious?
No, I'm joking. I'm joking.
Okay. Yeah, because there's another meeting. I'm going to get my ass kicked if I don't go to it, so fire away.
No problem. Okay, so I will introduce myself. I'm going to go ahead and talk about where robotics meet imaging in the hybrid operating room of the future. We've also created an entity here which we're really going to focus on over the next few years called the Methodist Institute for Robotics, Imaging and Navigation, because I really believe that all of these things tie together, and I hope to be able to demonstrate that during the next 25 minutes. Here's another example. If you walk around Methodist Hospital, we have a remote robot that provides security with an entire imaging system built into it to transmit those images and to allow these to be seen, in a central command center. So we're all about the robotic systems inside Methodist. Here's some of my conflicts, and some of these are pretty significant. Actually, Siemens now has acquired Corindus, and Corindus really is now being integrated into the imaging system. So these are my conflicts. So you've seen this picture already. This is my operating room. This is where we work on a daily basis. The only robot that's not usually in there is the big one in the middle, and this is the intuitive surgical robot. And one of the questions, so I posed this, I gave this presentation at the Hamlin Robotics Institute at Imperial College in London. And the question is, how many robots do you actually see in that operating room? Now, I'm not expecting an answer, but I'm going to go ahead and introduce you to each of these guys and talk about how they get integrated into imaging. So let's start off with the one that we're going to talk least about, and this is the DaVinci Xi. It's the one really that completely transformed surgery. It was introduced really for cardiac surgery, but never really got legs. Actually, I'm incorrect, and it was its predecessor. It's the SI, which was used for cardiac surgery, was kind of given up but has transformed general surgery. And in our thoracic operating room, about 90% of the cases are now done using this robot. Now, what about the cardiovascular space? So when you put these robots into the chest and you collapse the left lung, this is what you look at. That's the descending thoracic aorta. Beforehand, if I can run it back, you'll see, let me just run it one more time. What you're looking at here is the left subclavian artery, phrenic nerve, and the descending thoracic aorta. That's the common carotid artery that's in here. And so these are remarkable, remarkable pictures. And I think that we in the vascular world have really missed the opportunity. We've spent a lot of time in trying to get back into this. Could we sew an anastomosis here? Could we put a stent graft in by putting a needle in it? There are all sorts of different applications we could potentially look at. But it's the one that we really, in the cardiovascular space, it is re-emerging in the cardiac world and has barely scratched the vascular surgery world. Dr. Grammy talked a little bit about this robot this morning. So this is robot number 2. Let me kind of explain what is going on here. One of the challenges in transcranial Doppler, not enough Zoltgaramis. We don't have enough people, not enough people to put the probes on the patient's head. And so this robot was designed actually to acquire these images. You put the patient's head in the head frame, and the robot autonomously, and actually looks like it's even faster than a human, will acquire the image. And these are the kind of images that it gets. And so what this is doing is interrogating the middle cerebral artery. And it shows you basically the flow that is coming from that middle cerebral artery. You've already seen this. Is not everybody is bought into this. There are a few skeptics based out in their anesthesia department. But essentially, this was built to actually be deployed inside ambulances. The idea would be, rather than wait for a patient with a stroke to arrive at the emergency room to get a CT scan and to have a diagnosis of a middle cerebral artery occlusion, could this be deployed in the ambulance en route? Could the MCA signal be shown to be, obviously it's not going to diagnose all the strokes, but can we actually pick up changes in flow patterns or actual occlusions so that we can short circuit and move these patients directly to the interventional suite? And what you look here is this area that the robot interrogates, and the speckle pattern on your right. And the robot learns. This is obviously the advantage of the learning processes, basically, which the robot can go through, is it searches in multiple different patients and refines the search pattern so it gets faster and faster at actually detecting that. And so it refines the algorithm, basically using AI as it moves forward. And this is just an example, basically, of showing how the robot is as effective as a human is in actually picking up these signals. And the nice thing is that sometimes when we're operating on patients, if you don't have the robot, the head gets bumped, you lose the signal, and this can actually autonomously go back basically and reacquire the signal. It's a bit bulky. It was actually also designed for the armed forces to be deployed in the battlefield. It's got to get a lot smaller for that. For looking at soldiers who actually had concussion, as may be reflected in changing intracerebral flow patterns. And so this is the beginning. It's got a long way to go. We're looking at this basically. We're particularly interested, in TAVR. We're particularly interested in the efficacy of embolization protection devices. And this robot is being deployed every day with people like Neil actually looking at trying to now ascertain the efficacy of these embolization protection devices. Okay. Robot number 3 that's sitting in here is actually the imaging system itself. And this is the Siemens, it's the latest and greatest imaging system from Siemens. It's called the Siemens Pheno. And where did that come from? It actually came from KUKA robots and car assembly lines. So this is where it began. If you strip off the nice shiny cover that's on it, that's what it actually looks like. And so, this is an article talking about how transforming these robotic components into innovative medical solutions. And I'll show you a little example basically of how this was developed and designed. This is what the KUKA robot looks like, and this is what is underneath that imaging system. And so it gives you a lot more control of the imaging system. This can potentially spin very rapidly around the patient because that's the way we acquire a CT scan. The faster it rotates, the less noise you actually get basically in the background. So one of the things that we talk a lot about is the other guy's toolkit. There are a lot of solutions that are in other specialties, and you're going to hear Gavin Britz is going to follow me in terms of how we've been working together around catheter robots. I think there are a lot of solutions in somebody else's specialty, but we often don't get the opportunity to actually see that. We're particularly interested, we're on this meeting called Pumps and Pipes, where we get together with the oil and gas business to look at other industries' solutions and basically see what they're actually doing. So when you dress this robot up and call it Siemens, this is kind of what it looks like, and this is a very complex system. The robot and the table are one integrated robotic system, actually. The table, or the robot knows where the table is and vice versa, so for prevent collision avoidance. So it's a very sophisticated piece of machinery. Here was an experiment in which the previous version, is called the Zigo, was actually trying to interface with surgical robots. We haven't gone too far at the moment, but maybe in the future. The advantage is that this can actually spin fairly rapidly around the patient, and this allows a 3D image acquisition, and that acquisition is automatically reconstructed into a three-dimensional CT scan, essentially. It's called a cone beam CT scan. Here what we're doing is acquiring a mask, then injecting dye, and then you just like doing a subtraction run, this is what you get. Now at the bottom of this, in our operating room, is yet another robot, and I'm going to come to that eventually. Stole my thunder in showing this. I always like to show, Jan says I'm making her famous, and that we have amongst the most flexible anesthesia team around in the United States, because they don't want to get in the way basically of this thing. And this is Jan practicing her limbo dance and trying to keep out of the way basically of the machine itself. So then I'm going to tee this up really for Dr. Brett. So I think he's going to spend significant amount of time talking about this. This is a catheter robot. The original catheter robot was called the Hansen Robotics System. I was introduced to it by Dr. Miguel Valderrabano. He was their chief of EP. And when I walked into his lab, he had this robot going transeptal from the groin, transeptal, and was moving it across the surface of the left atrium, millimeter by millimeter, to perform ablation, and could measure the amount of pressure that was being applied. And that's how we got involved in catheter robotics. Unfortunately, Hansen was actually acquired by Auris, and so this is the one robot that currently remains in the endovascular world, and this is called the Corindus robot. Now, again, our premise was always that you were never really going to get the true advantage of robotics until it interfaced with the imaging system. At the same time, it's great to have 3D imaging, but when you're an interventionalist, you really need to be able to use that to drive the robot. And that's the really exciting thing for us that took place, where Corindus actually was bought by Siemens. One of the challenges with the robotics companies, they're all startups, they're all high tech, they all burn through a lot of money. They've never really had enough money to actually push the envelope, because they're always trying to sell systems probably before they're ready to be sold. But now Siemens has acquired them and has the engineering capability to take this really basically up to the next level. I'm sure Gavin's going to tell you a little bit about that. This is Gavin actually, because again, an example of the other guys took it. This robot was actually built for coronary interventions. You have to navigate manually to the coronary ostia. Then the robot can actually take over, but it can only really control the catheters for about 20 centimeters. Well, that doesn't really help not much in the periphery. It is okay for the coronaries, but it was potentially transformational, we believe, when actually used inside the head. And this is an example of driving a microcatheter on a wire. You're going to hear a lot more about this, because we really believe there's an opportunity to change the way a mechanical thrombectomy for stroke is being performed, and this can potentially be done remotely. So not only are we going to be able to deliver the electrode remotely, but we believe we're going to be able to actually deliver therapy, in some cases, not all, remotely. And Gavin's going to talk about some of the work that was done basically by the team at Methodist, and it will show you basically how coils can be deployed, how clot can be removed, and increasingly how we can do this without being tethered, as we are in this situation, by a cord to the robot, be able to deliver it remotely. And this is a stent retriever where you can actually deploy inside clot and a model of the brain. This is the first time this has been done, to actually trap the clot and actually remove it. So that's one aspect of how this can be planned. The Holy Grail, and this is what was being done by Hansen immediately prior to Hansen being acquired. This was actually done up in Mighty in the hybrid room that you're going to be going up to this afternoon. This is using a fused model of an aneurysm. That model, on the model, we then essentially drew a glide path. So when you draw in a center line, or you draw in a line that goes from the renal artery to the groin, this essentially is, we've used it as a center line for measurement purposes, measure the length of the endograft, measure the the diameter of the aortic annulus. But every time you draw these lines in there, they can also be used as a glide path for a robot. And this was the Hansen robot locking on and autonomously moving inside with no fluoro at this point in time. What you're looking at is a virtual catheter. This is where the catheter started being positioned, but this is now moving autonomously. This is published in Journal of Vascular Surgery, actually, interrogating the renal orifice and then deciding autonomously when it could actually catheterize this. So you won't quite see this, but you'll get an opportunity to use the Corindus robot this afternoon when you go up into Mighty. But this is the capability. This is the promise of interfacing robotics really with imaging, and I believe this is eminently feasible. The first remote cornea intervention was actually done in India. This is Ryan Mutter actually performing a remote cornea intervention from Mayo Clinic basically to a remote lab. This was done basically in a pig model, but the first human one was actually done in India. This was actually published in the Journal of Vascular Surgery. What is now being tested is doing transcontinental control of these robots. Obviously, no, it's not wired. It has to be done wirelessly, and that worked very well. We're in the process. This is the first cornea intervention that was actually being performed. Let me go back for 1 minute because 2 days ago we tested our link up to the Woodlands Hospital to show that we can drive these robots over 50-mile distance in Houston, and we're planning to perform basic clinical cases sometime within the next couple of months as soon as we get basic IRB approval. So very exciting time to be involved basically in this. Last but not least is what we're going to use this afternoon for me to be able to communicate with you. It's really interesting that to be in a situation where we're running a symposium, can actually turn up for the symposium. In the break, I was actually talking to one of our colorectal surgeons who had 4 Singaporean surgeons were planning to travel to Houston to watch him do robotic colon resection. But couldn't come because of basically the travel ban and hospital regulations and somebody coming from Southeast Asia. And so they linked up and transmitted using this system. And so I think what we're going to see is a complete fundamental shift in the way medical education is actually going to have to be delivered. The fiducial pressures are huge. And now we've got basically an epidemic, that is going to change the way we deliver this. So I like to think that you're seeing the front end of what medical education will look like. This robot was actually, Zolt kind of touched on this, is here we're using it, we can plug in Zolt's TCD machine. He's, believe it or not, sitting in Hungary. He's looking at what we're doing in the operating room. I'm doing a carotid endarterectomy. He's telling me how to shunt, when to shunt, whether I need to shunt, and monitoring the middle cerebral artery circulation from Europe. And so we see this as a way in which we can actually take, and that's what the TCD signal was he was looking at. We see it a way of generalizing scarce resources. He mentioned that he's also done this up in the Woodlands this week. One of our fellows who was used to using TCD joined us up at the Woodlands. His name is Thomas Lowe. He wanted to use TCD when he's doing his carotid procedures, because believe me, when you know what's going on in the patient's brain right here, while you're clamping the carotid artery, reestablishing flow, it is very reassuring. Do you absolutely need it? No, but I can tell you once you get in the habit, all that really matters is what's going on inside the brain. Same thing with TAVR. What ultimately basically is going to matter is what the embolic load is and what's going on inside the brain as we're doing these complex cardiovascular procedures. And being able to transmit, so this is a robot that he can control that flat panel screen, he can direct it, he can zoom in, and he can communicate with us. So it allows us to take somebody who is an expert, but there's only one of them, and his family's in Hungary, so sometimes he's not here, but it allows us to make him work, even basically when he's outside of the United States. And here's another example of us using this. In this case, basically, it was a thoracic endograft. And so on the left, what you're looking at is the robot that was actually used to perform this, to transmit these signals, and you'll see this again this afternoon. So that kind of brings me to the end. If you can put me back up, and so hopefully that's a glimpse into what can be done. A lot of these devices, the Corindus robot, the Ziegel, how to optimize images, the remote viewing system or collaborators are all present up in the lab for you to see and to participate in this afternoon. So thank you again for the attention and the opportunity to talk to you. I think I've saved a little bit of time to get us back on track. Huey, I appreciate very much you manning the show and running the program. Thank you again.
Well, so we're going to continue our discussion on robotics now with Dr. Gavin Britz. Dr. Britz, is he here? All right, we'll just take about a 5-minute break.
I'm going to swallow this with it.
All right, so Dr. Gavin Britz is here now. He's our Candy and Tom Knudsen Centennial Chair in the Department of Neurosurgery, and he's been the real champion here for robotic neurosurgery. Dr. Britz.
Okay, thanks very much for inviting me. Sorry, this is going to be a quick talk, much like the debate last night. But I've got 10 minutes to give you an idea. And why Alan asked me to talk is that neurosurgery and imaging, I think Alan's a big imaging guy. You know, we believe imaging is very important in neurosurgery. So this talk is about how imaging is important. And I always say, as a divorced guy, this is the only perfect marriage I know about, imaging and neurosurgery. Brian, not even you and I. So just to give you guys perspective, before 1971, I call it the Dark Ages. This is what neurosurgery consisted of. Making a hole in the skull, imagining where things were, and draining out the spirits. So you may think this is really far-fetched, and that's not what neurosurgery was, more recently, but this truly was neurosurgery until 1971. I'm not going into the details for 10 minutes, but that's what the eras were. And these dark ages of neurosurgery continued until October of 71. So you may think that the primitive surgery, like the radiation oncologists do, even now, was more recent, but it wasn't. Because before those days, you used to rely on the clinical examination. Patient presents with a headache, papilledema, some hemiparesis. You'd figure out, say, well, this is the lesion, is most likely there. You'll get your best neurologist to come do an exam, and it'll be, okay, this lesion's probably there, and you do exploratory neurosurgery. That's what you would do. So up to 1971, what you saw done 3,000-4,000 years ago is what we were doing in the OR all the time. It was exploratory neurosurgery based on an exam. And obviously we know the human brain is the most complex protoplasm in the world, and that's just some examples of the hippocampus, which I do a lot of my basic science research on, and the fiber tracts. And we used to operate in the brain, exploring the brain. Just to give you an example of what the brain looks like, some of our brains are a little bigger than others. Neurosurgeons are a lot bigger than radiation oncologists, say, Brian, but that's what it looks like. Even though we as neurosurgeons can go inside and take away the brain, we know that most of the brain is extremely vital, and we've mapped the brain out to certain areas, motor cortex, sensory, visual cortex, etc., and the subcortical structures. But most of this brain, you try and avoid causing any problems. This is what neurosurgery looked like. As I showed you earlier slide, but this is what it was. You go inside there, explore, you'd open up on the one side, and that's just an example of Cushing's operation many, many years ago. It's pretty elegant, but still it's very, very primitive and very crude. So what changed neurosurgery? And it's purely imaging. When you look back, I always say it turned from the Dark Ages. The first brain scan done in the UK at Atkinson Morley Hospital, actually I spent a year, developed by Hounsfield and a South African scientist. And that changed neurosurgery. That's the first scan. You can show your lesion. Let me show you. There it is. There's your brain tumor that the patient has. And that's the first time we can say that's where the lesion is, and we cannot decide on a neurologist's examination, which can be obviously the opposite side, but we can see things. And then in 81, 10 years ago, the first MRI scan was developed. But this imaging modality completely transformed neurosurgery, and I'll show you an evolution. This is what modern imaging looks like. This is the 70 magnet on the top. That's what, now that's the brain. You can see the beautiful fiber tracts, the corpus callosum. You can even see nuclei. And for the vascular conference, you can see the blood vessels. That's all imaging. and that you can see on MRI. But that's just an example of where we've gone just from 1971 and 81 from the MRI scan. This is what, but this transformed it. So now not only can you, localize the disease process, but you can diagnose the disease process most times purely on imaging. So obviously this is a talk about surgery, and I think after knowing where the lesion is, the next phase would be, well, how are you going to go ahead into the brain, not cause collateral damage without causing trouble? So Torolf Sund was a very famous neurosurgeon in Mayo Clinic, and he said the art of neurosurgery is to go into someone's head, go into the brain, take the lesion out without the brain knowing you're there. I think that's the important thing. So even though we had this whole thing of imaging now, we can see these lesions, the next phase was how we can go ahead and take these lesions out. These are just cases that I've done before. Little cavernous malformation close to speech. Obviously, with MRI would show it, but how would we find that lesion? We'd guess. That's a thalamic cavernous malformation as well in the brainstem. So this was where we were before the new thing. And the next major change in neurosurgery was neuronavigation. And I think, second to MRI scan, this has been the biggest game changer for us as neurosurgeons. And what this is, it allows us to know in 3D, it's like the classical GPS system, where you can look at the X, Y, and Z trajectories, coordinates, and know exactly where the lesion is. 10-minute talk, I'm not going into details. And that's what we do. We put little markers on the skull, and using these different coordinates, we can know exactly where the lesion is. What we can do then, we take the patient to the OR. We've got this beautiful MRI scan. We can localize where the lesion is. We can now plan a trajectory to know where it is, and this is what a modern neuronavigation system does. But you can imagine, before having neuronavigation, how would you find? The lesion's close to someone's motor cortex or speech center. You'd still open up a big craniotomy. You'd go in, you'd still miss the lesion by a few centimeters sometimes if you're lucky. And I know when I was a resident, neuronavigation was just coming around, and my biggest concern was, am I going to find the lesion before the chair or the attending comes inside and causes trouble? But that's revolutionized things work. And I think now where we are with neuronavigation, we can localize a lesion anywhere in the brain in 3 dimensions, whether 1 or 2 millimeters in the brain. You can localize tumors, you can place catheters inside, and you can do precise localization, again, based on imaging. That's why imaging is so important as a neurosurgeon. So then, as I said, this revolutionized neurosurgery. It was a complete game changer. You never had to worry about, am I going to find the lesion? And even now, even if I do a 7-centimeter acoustic, I can find that in my sleep. I'll still use neuronavigation, and the reason being is I can make sure I'm operating on the correct side. So navigation not only allowed me to get to the lesion safely, plan my trajectory, but also allow me to always operate on the correct side, which is important. So the next step would be now we know we have the MRI scan. We can localize the lesion, we can find the lesion, we know what the pathology is, we can localize it on neuronavigation. But the next step is, as Torolf Sund said, how can we enter the brain without causing collateral damage? And the next thing, again, imaging-based, is 2 different imaging modalities called MRI diffusion imaging, which is for DTIs, and functional mapping. I'll give example, this is what DTIs look like. So now you can imagine, we take the lesion MRI scan, we superimpose where the important fibers are. So you can, for example, that's the motor cortex here. Okay, so you can go all the way down. So the lesion is close to the motor, I know exactly where it is. So not only do I know what the lesion is, where it is, how I'm going to get there using neuronavigation, I will look at the important fiber tracks and say, okay, this is the lesion, the part I need to stay away from to get better results. But that's the subcortical structures. Then, and that's again an example of lesions I've done before. Different. This is still a primitive versions, and again showing the motor cortex here, cortical spinal tract, the occipitalis, and just an example. Many neurosurgeons, even though we like neuroanatomy, none of us really knew what the occipitalis did, and it was collateral damage. We can operate, say, okay, I'm going to just take this damn thing out, wouldn't worry about it. But now, understanding fiber tracks, we can plan this and actually preserve even the fibers. We don't know we know what it does to some degree, but not completely. The next step would be obviously, we talked about subcortical structures, but obviously the cortex, as I showed you in the earlier slide, has function. So we know, for example, there's motor cortex, the sensory cortex, and we can look at hand movements, and we can preoperatively, again with imaging, find out where the auditory stimulation is, where the motor is, where the different cognition is, and you can preoperative plan. So you can imagine the power of imaging. So now we get the MRI scan, we can localize the lesion, we can find where the lesion is, we can see where it is in regard to superficial structure, so we can don't cause collateral damage going into the motor cortex. We can prevent us getting into the subcortical structure. This is, again, all imaging-based has made a huge, huge difference. And that's when I said earlier before, we can combine their technologies, and that's how imaging has changed neurosurgery. And so obviously the next thing is this example of a situation where we combine this whole thing. This is that lesion I showed you before. This is a little cavernous malformation. Surgically, a monkey can do this operation, but you've got to find the lesion. So now a situation, we can get those DTIs, we can see where motor is, we can see where oculus is. We can go inside using all this technology, the fiber tracks, all that type of stuff, and take the lesion out. The patient goes home the same day or the next day. We do this awake as well in this situation. So what is the next step? Obviously, as neurosurgeons and academic neurosurgeons, we always look into how we're going to push the field further. That's per se. Again, underlying theme of this whole talk is minimize collateral damage with your marriage to imaging. And the next thing, we were one of the first in the country to be involved in this, is the brain path. Obviously, this tubular surgery, we call it tubular surgery, has been around for a while, but wasn't really modernized. You could put the tube, but you still wouldn't know where the tumor was. So now when you combine all the other technology we had before, combined with the tubes, you can place these 40 millimeter tubes as a diameter into deep parts of the brain and without causing trouble. That's what it looks like. That's an adaptive exoscope. It's not a microscope. Microscope, you actually put vision inside. This is something that provides light from an outsource, and it's been adapted. Now you actually can get the light even in the tubes, but that allows you now to go inside and take deep-seated lesions out with these tubes as well. And again, this is a 10-minute talk, but again, you can see the combination of technology we use as neurosurgeons: neuronavigation, DTIs, functional mapping, brain path to axis lesion, using the exoscope, all to minimize collateral damage. Now, this example of one of the first cases we did. That's obviously one of the news stations showed it, but the patient did really well. We did it awake, and that was impressed. It's another case I did. Again, these lesions, you could take them out before, but they were complicated lesions. You had to navigate the thalamus, the cortical spinal tracts, the internal capsule, and again, using all that technology I described. So preoperatively, I'll get my imaging, I'll get my fiber tracks where they are now. I can plan my trajectory, and instead of opening up a huge craniotomy, do a 2-centimeter craniotomy, push this tube all the way down into the thalamus, not hitting the internal capsule, and take this lesion. Now, this is a kid from Austin I did, and we did him awake as well. But as you can see, this lesion, which was not, it always was surgically removable, but was always left with some deficits. This patient was actually better even during the operation. If you took the lesion out, he got better on the table. Even for strokes, obviously it's not technically demanding, but hemorrhagic strokes, that's an example. We can go inside using the same technology, brain path, put it inside, they take the hematoma out without causing further damage. What's the next phase? Again, we're going to the next phase now. So now we're using this augmented reality, and can you show the video? And this is surgical theater, where we actually now using augmented reality, again, imaging based. It's all imaging based, where we can preoperatively, now we can have the surgical side done, but what we didn't have done is actually even better preoperative planning. And so we can go inside, and the residents do it by themselves, or I do it before the case. I can put these goggles on, the patient can put the goggles on, and we can see the pathology in 3D. But even more importantly, and just PBS did an article about this just last week, we can actually now, using this technology, walk through the brain. So I can look at the pathology, know exactly what I'm going to do, know where my fiber tracks, know my functional cortex, but I can now walk into the brain. It's particularly important in the vascular and skull bases, and I can go ahead and plan my operation. But as you can see, Alan and myself share a common theme. Imaging and neurosurgery is the only perfect marriage I have. Then, what's the next phase? Again, robotics. I think we all talk about robotics in cardiovascular and in neurosurgery as well. But again, how can we do robotics? The only way we're going to do robotics safely is with imaging. And I think for some of you guys know, can you show the videos? Alan and myself were the first in the world to help this company get approval for neurointerventional, and show the videos where we can use imaging even this is in the cath lab, we can navigate microcatheters robotically, but again, it's pure imaging. So anyway, this was a 10-minute talk, but I want to give you guys an introduction into neurosurgery, how important imaging is, and how it's changed the whole field of neurosurgery. When I look now, even as a resident, which is in the late 90s, even the late 90s, you do a major case, and you expect a more mortality sometimes. Now, if I take a patient even with the most complicated neurosurgical case to the OR, I expect him to be fine. I expect maybe a little bit of weakness, a little bit of problems, but I can expect a great result. And this is all based on imaging, neuronavigation, and accurate preoperative planning. Thanks very much. Brian, no questions from you. You won't understand it, so we'll have to talk, we'll give you the small sheet later. Like the 5th or 6th grade level. For you, yeah, no, I know. Any questions, Jamie? Alan? Okay.
All right, thank you, Dr. Britz. So next is going to be Dr. Jamie Gaetano. He's professor of oral maxillofacial surgery, and he's going to show some pretty exciting stuff that they're working on.
Thank you for the invitation and my regards to Dr. Lumsden. We're going to talk about anatomic aligner. Anatomic aligner is a software that we have developed here at Methodist Hospital for craniomaxillofacial planning, and it's right now going through the FDA approval process, about 15 years of work into this software. And I have to give credit to my team. They're here in our labs thinking about new ways of doing the stuff. And in 15 minutes, I cannot highlight all the important things about the software, but I'll show you some clinical cases that will be more exciting for you to see the kind of work we do here. But I also have to thank NIDCR, NIH for the support. All this work that we've done here is because of them. So let's talk about an 18-year-old girl who came here from Panama, who had juvenile idiopathic arthritis in her temporomandibular joint when she was 80 years old. And that's her pictures from the profile. And when the juvenile arthritis will destroy the condylar cartilage, which is the growth plate for the mandible. And if it is destroyed when you're 80 years old, the mandible is not going to grow. And it was destroyed more on the right than on the left. So her whole face got crooked and twisted, and she has a pretty significant facial asymmetry, and they're obviously very concerned about that. So again, this is she has a malocclusion. It's hard for her to chew because the teeth don't come together. So what we do is we create a virtual model of the face. We scan their teeth with a small little intraoral scanner. We CAT scan them. We do three-dimensional pictures of the face. We merge them all together into having a virtual patient. And we have a virtual knife where we can make osteotomies on the face, create all the segments, and move it and realign them together to plan our surgeries. So this is all the cuts and movements that we need to do to this patient to fix her face. And the difficult part here is also at the end, we have 16 upper teeth and 16 lower teeth that have to land absolutely perfect in bite. You know, if you're biting on a hair, your teeth are that sensitive and will drive you crazy. So that's a thing that for us is actually fairly difficult to do. But planning in the computer is a piece of cake. How do you make that happen in the operating room? So these days, rather than using intraoperative navigation and imaging and guidance, what we do is this is the IKEA furniture store approach to surgery. All the hardware we're going to use is prefabricated and pre-bended or milled or 3D printed. And we have templates that go on the bone that will map the position of all the screw holes, all the cuts that we make. And we have these wafers that go in the teeth, in between the teeth, that tell us where the jaws are in alignment. So when we go to surgery, there's no artistic decisions. It's all basically just following basic carpentry with templates. So we have measurements of all the things we need to do, and we're going to operate on her lower jaw first, and in the middle of surgery, the bite is going to be off by this much, and then realign it and also help us save an enormous amount of time, because when you cut a piece of bone and trying to realign it, you have these areas of collision where bone is touching. You have to grind a little bit and push it again and grind a little bit. Here we know exactly how much we have to remove ahead of time and just move it in a single movement, so save us hours of surgeries. These operations that used to take us 8 hours and 6 hours, now we're doing 3 hours and 2.5 hours. So when we go to surgery, the folks in my lab create these templates that I'm going to put on the bone that mark the position for all the screw holes and all my cuts. And here on this side, because of the deformity, we have to go from the neck, but most of our operations are done from inside the mouth. We put the template, we make the cuts. All the hardware is pre-bent and prefabricated ahead of time. So just by screwing it, you automatically put in the bone segments into alignment. The old-fashioned way of doing it, we have to go, cut the bone, move it, have a resident holding in that position when we weren't bending in plates and putting them into position and screwing it. The pre-bent hardware tells you where things go. So this is her on the right before and on the left, at your right after. So you see, we can copy exactly what we plan to do. And we've published on this, and the accuracy is about 1.2 millimeters differences between what we plan to do and actually happen here. So it's incredibly precise. And you see her before and after a single operation, before and after. So this kind of outcomes we never could get before. So now we know exactly what we know to do to make them symmetrical. And we don't save lives like you guys do, we change lives, you know. And that's her 3/4 view and the other 3/4 view from the other. And that's her bite. All the teeth landing perfectly well into alignment. So let's talk about an 18-year-old girl who came here from Kuwait. She had left TMJ ankylosis in childhood. That means her lower jaw was fused to the skull base into a single mass because she fell and fractured her jaw. So when she was 8 years old, that mass of bone was removed so she can open and close. But again, they destroyed the cartilage, the growth site, the growth cartilage for her lower jaw. So her jaw was very retruded, and she had a very significant facial asymmetry. And now she's 18 years old with this residual asymmetry. Obviously, she wants to look normal. And that's her bite. And you see she has this large overjet. Her teeth don't come together. She cannot chew well, but a very, very significant deformity. She's missing a lot of stuff on the left side. And you hear she has no temporomandibular joint, and we have to recreate that one. In the past, this was a very difficult operation because right in this area, because this was removed, you have the internal maxillary artery here that if I cut, I get into horrible bleeding that is very difficult to control. And right on the side, I have the facial nerve. So I have to recreate a tunnel between the facial nerve I cannot cut and the internal maxillary artery that I cannot cut, so I can put a prosthesis or a rib there. So we have to go and dissect the whole parotid and the whole facial nerve and find all those things to go it. But we don't have to do that anymore. Surgery is a lot easier. So here we're going to cut the upper jaw in 3 different pieces, the lower jaw into 4 different segments, and realign them all. And here we need to remove this part because this doesn't help us for anything, but we're missing all this tissue here that we need to replace. So what we do is we can 3D print all the guides, all the templates that go between the teeth that tell us where the segments will go. And then we make these templates, again, that tell us where the screw holes will go for the plates and where the cuts for the bones will be made. Now I have to create a plate to get the contour here, but this doesn't exist in real life. So this is a mirror image of the other side that I bought here. So if I follow this contour, the patient will be symmetrical. So that helps us a lot. We cannot make those decisions at the time of surgery. You never get it. So we go to surgery. This is a sterile 3D printed model We have all kinds of printers in our lab where you see here the holes for the plate are already there, and this plate has been bended ahead of time to the perfect contour of the face. But here, we're in the glenoid fossa area where the rib graft that we're going to place needs to land, there's a central crater, and there are a bunch of bone growths, heterotopic bone that has grown around it. And I have to land this cartilage right in the middle of the fossa, because if I land it on the top of a piece of heterotopic bone, after surgery, the patient moves her jaw side to side, it falls into the groove, and the bite is off. Make sense? So I have to put it in very precise, but that's an area during surgery that I'll never be able to visualize because you're in the skull base and you're blinded. So again, this is the templates, and when you do these big movements, you have to overcorrect because here the bone seems rigid. We treat it as a rigid object, in real life it's not. So we have the ability to look at the bone deformation that happens during these big movements. So we go to surgery. This is a neck dissection, and we put this template in the bone, make all the cuts, and we harvest a rib. Our chest surgeons harvest a rib for us while we drink coffee. But we put this plate here on the model outside the body, and we set the rib perfectly exactly what we want in the skull base, and then we remove this whole construct and go to the mouth, to the neck. But the holes for this plate have already been drilled with the template. So we just put this inside the pocket, screw it, and it's automatically in the perfect position without having to dissect the skull base, without having to dissect the facial nerve, without having to get into the vessels. And I staged her. I did the lower jaw in a first operation because I wanted to be sure this was landed in the perfect spot, and here it is. You know, even though I was blinded to this, it was absolutely landed in the right spot. And then we cut the upper jaw and did her chin, also with templates and prevent things. And this is the comparison of before and after, before and after, before and after. You see how this landed perfectly, her bite. And that's her before and after. That's her with her smile. You change your lives. You can never have this kind of outcomes, this degree of symmetry in such a difficult case without this technology. So in the last few minutes, I want to show you some cool work that we're doing in the lab. I've shown you the bone, but we're also working on soft tissue simulation because at the end of the day, how the patients look depend on the soft tissues. That's the part that we see, the face. So we have this big project, an NIH-funded grant. It's called eFace, where we created a generic model of the whole face. They have skin, fat, all the muscles of facial expression with all the mechanical properties. And we can take this mask that is prefabricated, we do a CAT scan for the patient, and we automatically morph the mechanical model to the surface of the skin and the internal part of the mechanical model to the surface of the bone. And then we can move the bones to the new alignment, and we'll automatically morph all the soft tissues for it. And it's very elaborate. There's no other piece of software in the world that is as accurate as this. And I'll show you a picture here how this works. This is the animation, how we can now morph the whole soft tissues in a color photograph and predict how the patient is going to look after surgery. This is another rendition on how we can predict the whole soft tissue changing on the face. And then that's predicted and that's actual, predicted and actual. And we finish some programs. So the next thing is we want to automatically, our software, these days, about 20% of the cases, all the hardware is patient-specific, and it's going to be the future. So you plan in the computer, you design your hardware right in the computer, you 3D print the hardware, you go to surgery, you place it. So we have the automatically, just by touching a button, the computer will generate a file that has the hardware, and we can automatically select where all the screws will go and send that to a 3D printing machine and go to surgery. Just yesterday, I did a case from another fellow who came from Saudi Arabia with a very complex deformity, and the whole plate was 3D printed for us. So I just went there, put a template, drilled the holes, put the plate, and I saw him this morning. He looks amazing, and a fairly straightforward surgery would have taken me a long, long time back then. So thank you so very much. If you have any questions, I'll be happy to answer.
Great. Well, thank you. Thank you very much. That was phenomenal. Dr. Paul Holman is next. So he's the assistant professor of clinical neurology, and he's going to talk to us about image fusion and spinal surgery.
Good afternoon. I guess this is a cardiovascular imaging meeting, so I guess the neurosurgery department was hired to provide some comic relief. Britt's probably told you about all these brain aneurysms and facial surgery, but I bet that from a clinical relevance perspective, back pain might be something that members of this audience have dealt with at some point in time. So hopefully, if anything else, this will be somewhat clinically relevant. So the truth of the matter is that low back pain affects about 90% of the population. It's a very significant part of disability and chronic pain in our country. It leads to lost work days and decreased quality of life. And as you can see, it's non-discriminatory. We have some famous athletes in Houston, and obviously people probably know about Tiger Woods. And so it's something that really is a very common issue. From a financial perspective, it's very costly to take care of patients with back pain, and obviously as the debates about universal health care and how we spend our dollars are becoming increasingly important, we do need to keep cost in mind when we're designing the treatments from a surgical perspective. One of the things that I do is I actually do a lot of adult scoliosis surgery, and people that I see in the office are surprised to know that about 70% of patients over the age of 65 actually have some degree of scoliosis, which is basically a 10-degree curve. And so when we treat patients with scoliosis, these can be very difficult operations. They're hard on teenagers, but someone that's in their mid-70s, these are difficult surgeries for the patients. And there's a high complication rate, about 20%. So we really need to make sure that our indications are sound and that we're managing patients conservatively before committing them to surgery. With all the fancy technology that you're going to see in different disciplines of medication or different disciplines of medicine, for me as a spine surgeon, really, the robotics and all the things that I'm going to share with you are really important. But probably the thing that's changed our practice as spine surgeons in the past 10 years is just a fundamental knowledge of what normal alignment of the spine is supposed to be. So the French get a lot of the credit for this work. There's a concept called the cone of economy. So basically, as you get older and your spine starts to degenerate, anything that's going to throw you out of this narrow range of balance where you're standing up straight leads to pain and disability. So you can see, this poor individual on the right with this was, I believe, was a 62-year-old woman with pretty bad scoliosis. So getting people realigned and back into this cone of economy is very important. So there's a concept called pelvic incidence, which is basically a fixed parameter, and your spine is basically driven by your pelvis. So we call the pelvis the fifth vertebrae. And so it turns out that however your pelvis is shaped, that drives the requirements for you to be able to stand up straight. So your lumbar spine has to have a certain amount of curvature to match this fundamental parameter in the pelvis. And there's a big classification system, so there's no such thing as normal alignment. There's a wide variation in terms of how much curvature somebody should have in their lumbar spine. So when I was a resident, if we looked at someone for fusion surgery, we basically would get lower lumbar spine x-rays, and we didn't really look at this full-length scoliosis type x-ray, we call it. So this is just an example of how you can have two people that if you measure the amount of lordosis in the lumbar spine, it's exactly the same, but you can see that based on the pelvic incidence, if you have a match between your lordosis and pelvic incidence, you have good posture, and if you have a big mismatch, you can be severely deformed and have a high degree of functional disability. And so we know now, when I see patients in the office, they say, well, I've been told by my grandfather and my dad, never have an operation on your spine because when you get one, you're going to need another one, and so on and so on. And it turns out that they're actually right. So what we know now is that when we do spinal fusion surgery, if we don't match the alignment with the pelvic incidence, that patients are already 10 times more likely to need more surgery. So this is very, very important in terms of setting our patients up for success. So with regards to delivering on these concepts, one of the problems is that, for years we've measured things with a micrometer, we kind of cut with a chainsaw. We didn't really have the tools, the imaging, the intraoperative navigation and robotics to be able to deliver a precise result. So it's really the image acquisition that we get before surgery, married with intraoperative technology, that's kind of the glue that kind of brings all this stuff together. So I'll talk a little bit about this. So as a spine surgeon, we get x-rays, MRI scan. We still use CT myelogram for patients that have pacemaker and so forth. But we do a lot of intraoperative imaging and bone density testing as well. We have a machine here that's called an EOS x-ray. Actually, the individual that made this system got the Nobel Prize for this. So this is basically a full body x-ray, but it delivers a full body x-ray with 1/7 the amount of radiation that you would get from a standard chest x-ray. They have this over at the Children's Hospital as well. So kids that have scoliosis, they get sometimes 2, 3, 4 x-rays in a 12-month period of time. So we're very cognizant about radiation exposure. The other thing about this technology is that it's scalable. So if you try to measure something to do preoperative 3D printing, you can take an x-ray and measure very precisely, and there's not a lot of magnification error. So when I was finishing up with residency, we really didn't have this. We would take a preoperative CT scan and basically then do spinal navigation in the operating room using different tools to try to put screws into the spine. All this was based on preoperative CT. So when you scan someone in a CT and then you position them under anesthesia, the relative alignment of one vertebrae to the next can be very different. So for this reason, there was a lot of error, and really we were very, very much impressed with how much cranial spinal or cranial brain navigation changed our practices. But it's really been over the past 5 or 10 years that people really feel that navigation in the spine has added a lot of value. So there are intraoperative CT scans which are very precise. They give amazing images, but they're difficult to work with in the operating room. So we were fortunate at Methodist Hospital to get the 4th, what we call O-arm. So it's basically a cone beam CT scan, but you can see it kind of opens up and then it can close around the patient, and it's also mobile. So when we do surgery, we typically will have 3, 4, sometimes 5 spinal surgeons doing instrumentation simultaneously. And we have 2 of these machines, and they can move from one operating room to the next, so we can use them simultaneously. It's not a fixed structure that only one surgeon can use during one operation. So like I said, we've had this now since 2007. I think we've probably done about 8,000 cases. I'm getting up there in terms of the number of cases that I've done. So the way that this works is that the patient is positioned, and then we have to have a frame of reference. So we typically will put a little pin into the patient's iliac crest, and then this O-arm creates a cone beam CT scan. Those 3D data set images are sent to a computer. During the acquisition of the O-arm scan, there's an optical camera system that shoots an infrared beam. It reflects off of these little spherical things that are attached to the reference frame, and that's how the intraoperative anatomy is registered automatically to the patient's anatomy. So when I was a fellow, if we put screws into somebody's spine, minimally invasive, we basically would do it with 2D fluoroscopy. So this is just an idea of how you would use 3-dimensional anatomy and say, okay, there's the ring of the pedicle, and take a bunch of fluoro pictures, but you really don't get a cross-sectional view of the spine. So now you can see this is just an example of us putting one of those reference arrays, and this is the type of image that we get in the spine. So we see sagittal and axial plane. When patients get a screw put into the spine that's a problem, it's usually a screw that's too medial. So by having that cross-sectional view, we can see exactly where that pedicle is, so we can very, very accurately put in screws. Every instrument that we want to use, the drill, the tap, an osteotome, this is just an example of us putting the screw in. So the computer software gives us a CAD model of everything that we want to put into the spine. We do now a lot of minimally invasive surgery. So instead of making an incision in the middle of the back and stripping all the muscle off the spine, we use these small tubular retractors. So you can see we're kind of using the image guidance to aim the retractor at the part of the spine that we want to operate on. So through a 14 millimeter tube, which you see on the left, we can constantly put our probe in and say, okay, where am I at? And we can drill the bone that needs to be drilled away with very little exposure of the spine. After we put in our screws, we learn to trust the navigation, but the truth of the matter is that navigation, even though it's better than us doing it freehand or just using our knowledge of anatomy, there's still a possibility that you could have an error. So the nice thing about the intra-operative image acquisition that we have is that once we put in the screws, we can take another cone beam CT scan and we can look at each of the screws. So we really, in 2020, there's never an excuse to put a screw into somebody's spine and then have to take them back to surgery to remove hardware that's misplaced and causing some type of neurological problem. So of course, no great surprise, robotics is also starting to heat up in the spine space. We now have 3 FDA-approved robots that you can use to put in instrumentation in the spine. So again, Methodist has been very supportive of us developing a robotics program. So again, similar to navigation, the robotic arm that we have, it's a passive robot. It's not like the DaVinci where we're using it to actually do decompression. That's kind of the goal of where we want this to go. But again, we can do all of our preoperative planning of the screws, and it helps us to be more accurate and actually do more of the planning before we get to the operating room. So the way that the robot works is we can either use a preoperative CT or our O-arm to develop the 3D data set, and then there's a registration process. The nice thing about the way that the robotic system works is that as opposed to doing the registration where one vertebrae is compared to its neighboring vertebrae, so the alignment makes a difference, the robot does segmentation. So each vertebrae is registered independently of its neighbor. So if you have movement relative to one vertebrae to the next, it doesn't affect the accuracy. So just as an example, I always tell my residents that there's a chance that I might burn in hell for doing this surgery, but this is a 90-year-old woman that came to see me. Texas Medical Center, drove by herself, no family. I had no idea that she was 90. She said, my back is killing me, it's ruining my life. I want you to fix it. So amazingly, she had very few medical problems. She actually did have a cardiac device, but no osteoporosis, just a super healthy woman. So you can see this is one of those full-length scoliosis x-rays, so she has a pretty significant lumbar curve. And we get the CT scans a lot of time to look for what we call air vacuum. So you can see the little dark spots in the disc space, that's air. So if a disc space is so degenerated that there's nitrogen gas inside the disc, it's very mobile, and that's actually good for us as spine surgeons because we can correct that a lot more easily than something that's rigidly deformed and we really have to break the vertebrae apart. This is our preoperative software. It's actually free software called SurgiMap. So we go and measure those pelvic parameters. In general, we make all these measurements, but when we fuse someone, we want their head to be centered over their pelvis. So we draw a plumb line from C2, and we want that to basically be over the hip axis. So if you look at this individual's alignment, it really doesn't look that bad, but she's actually doing what we call pelvic retroversion. So she's rotating her pelvis around her hips to compensate for the deformity. So with this preoperative software, we can kind of correct that. So you can see if we normalize the position of her pelvis, she's standing further forward. So we know that even if we correct her scoliosis, if we fuse her in this position, she is not going to have a good clinical outcome. And that's the big difference between what we can do now versus even 10 years ago, is just the knowledge of what is normal anatomy. And all this is adjusted for the patient's age. When we do these scoliosis operations, we typically do them in stages. It's a lot of work. So we build the foundation of the house, so to speak, on the first day. So we go through a series of small incisions in the abdomen. We take out those discs that are collapsed and we reconstruct them, wait a couple days, and then we put in our instrumentation from the back. So here is our robotic software. So basically, sit in the office, drink some Dunkin' Donuts coffee, go level by level, and we can position the screws that we want to put in level by level. And you can see we basically get everything lined up. If you're going to do minimally invasive surgery, we really have to align the screws so that as you go level to level, they basically line up, because you're passing the rod underneath the skin. You're not exposing any of the spine. So if things are crooked, it's a lot more difficult to position these things correctly. That's how we want it to look. We actually do preoperative planning. We send those images to a company in France, say this is the number of levels that we want to do, this is how we want the spine. Within a week, they ship us a rod. It's pre-bent, so we know that if we make the spine flexible enough to put it in the rod, we'll get the alignment. We do our robotic instrumentation, series of small incisions. Here's our x-rays after surgery, pre-op to post-op, very good alignment of the scoliosis. And then more importantly, if you look at that global plumb line, her head is centered over her pelvis. We don't want to do too much correction. If we're over-aggressive and try to make a 90-year-old person's spine look like a 21-year-old person's spine, then sometimes they'll basically collapse and bend forward, which is not a good thing. So this is just, again, an example of how the preoperative imaging can be translated to the operating room. And there's a lot of room for improvement. This is a hot area of research. I love coming to these conferences because we look at what people are doing in cardiovascular medicine, ENT, and I think we kind of feed off of one another. So where are the limitations for us? When we do this type of imaging, we have this optical camera. If somebody puts their arm in front of the camera, if there's blood on those spheres, we stop navigating, we have to clean that off. So if we can come up with a way of improving or coming up with a different technology other than optical imaging, it's going to make this a lot better. If we do the navigation and we bump that reference frame that we put into the spine and it shifts that relationship, you're not going to be accurate. We have to take another scan that's more radiation than the patient needs. So being able to re-register, there's some new technology that's coming out to be able to do that without taking another scan. We'd like not to do preoperative CT. MRI scan is obviously better in terms of radiation exposure, but that's still been a technical challenge. And then obviously with what people are doing with a robot like DaVinci, we want to transition our robotics to do more semi-active work so we can actually do laminectomy, work around the nerves robotically. And one of the things that we're working on now is we're developing an endoscopic program. So we're going to be able to do some of our minimally invasive surgery with even, instead of using those tubular retractors, with an endoscope that's 7 or 8 millimeters in diameter, so less trauma to the patient. We have all these patients that are going to need MIS surgery, so this is what we're hoping to deliver. So with that, I'll say thank you. Take any questions. Well, I think I'm the last person before lunch, so that's a beautiful thing. And like I said, if there's any questions, be happy to take them. If anyone here has a background, be happy to see you, but hopefully nobody shows up anytime soon.
Thank you very much. Appreciate it. Thank you. So we're actually a few more talks. We're going to keep moving on. Dr. Brian Butler is the Jim and Joan Harrell Chair in Radiation Oncology, and he's going to talk to us about image visualization technologies from that standpoint. Oh, there he is.
So I'm the chairman of radiation oncology. The work I'm going to talk to you about today is supported by my endowed chair by Dr. James Harrow, who was, it's not flipping over. He used to be chairman of radiology at the Houston Methodist Hospital. So one of the things, I know you're going to do some hands-on stuff here afterwards. And of course, I want to thank Dr. Lumsden. It's an honor to be here today discussing my work. But there's a thing called Plato's Cave, and it's about a mile down the road, down Fannin Street. A cave is a computer-augmented virtual environment. And okay. Thank you. So basically, it's a visualization center in terms of clinical visualization, interacting with three-dimensional and even four-dimensional data. And how can we use that for what you do and what we do in radiation oncology? So I don't think this wants to advance. Here we go. Mm-hmm. For some reason, it's not. Huh? Yeah, I'm trying to do it manually too, but it's not. So just press here. Okay. So one of the people I work with is Dr. Romero-Pino. Dr. Romero-Pino is my chief physicist. He wanted to put a lot of slides in my talk, but I told him that I'd lose most of the audience once I did that. So I wore my tie that has a lot of formulas on it. So, so again, the Methodist Annex is about a mile down the road. It's the Plato's Cave is in sort of an old cobalt room. It's not in the high rent district like it is here. For Dr. Lumsden to come down and visit us, he usually brings some bodyguards, and sometimes he calls and says, I want to do a stress test on a patient. If they get from your parking lot into the annex, they'll pass the stress test. So it's an older building, but it's a historical building because that's where Dr. DeBakey used to see all his patients before bringing them to the Methodist Hospital for surgical procedures. So we're here about all this technology today in terms of robotic devices and other devices, 3D printing and things like this. And I think one of the things to think about is, this is a quote from Einstein, imagination is more important than knowledge. What is the best way to use this new technology and the technology that's available? Which of course is Dr. DeBakey. It's a picture of I went on a trip to find a neurosurgeon in Europe, and I think I was in South Africa, and we cleaned him up, and now he's doing very well in neurosurgery here at the Houston Methodist Hospital. You may have heard him speak a little earlier. Sort of looks like him a little bit. So one of the groups we work with a lot of surgeons. That table there is what we're trying to do is not only look at data and visualize data, but interact with data. So that table there is created by a guy from MIT. Your iPhone, only one person can move things around. This allows 4 different surgeons to move data around on that particular table. This is a group of ENT surgeons. We work with the ENT department a lot. Dr. Mas Takashima, who is now chairman of ENT surgery. So we have a lot of collaboration between different silos of people to come up with the best solution. We work with gamers because, again, we're using visual data. Visual data from DICOM data or imaging data can be processed very quickly now because of graphics cards basically from the gaming guys. But oftentimes they can create this visual picture for us that allows us to understand a disease process. So what I want you to do is think of a patient as a data cube. And basically I'm going to interact with the data cube. So you have to remember, in radiation therapy, this symposium is about robotics and imaging. Well, everything we do in radiation therapy is robotically controlled. We put a patient on a table, the table moves into a position. We use the imaging to tell us where our target is, and our beams come at different angles to hit a target. So if you think of a patient as a data cube, I want to be able to fly into that data cube, make measurements in that data cube, interact with that data cube, connect the data in the data cube to an instrument, a robotic device. So the question is, I want to fly into the area where the data cube, and look for Waldo. Where's Waldo? Some people say, well, younger people don't know who Waldo is, a comic strip. But I want to fly into where the problem is. So there's a lot of correlation between radiation oncology and surgical navigation. For instance, the imaging. All our machines now have imaging built into the machines. What do I mean by that? Cone beam CT. Some of our machines have MRIs built into the machine. So the MRI, we heard about how you're worried about dose to the patient. The MRI scan can be on the entire time the patient's being treated to watch making sure you're hitting that target. So we've developed multiple ways to make sure we're hitting the target within that data cube. Methodist was the first institution to use robotics in radiation therapy. You've heard of intensity modulated radiation therapy. We were the first people in the world to do that, where beams open and close to create a pattern of radiation therapy. We can hit a target within 1 to 2 millimeters with our radiation beam. But that means the patient has to be registered on the table, or the data cube has to be sitting on the table in the exact position we scan them. So in that manner, we should be able to create sort of corridors of safety to hit our target. Fields in radiation therapy have gone from big fields to small fields, just like laparoscopic surgery. One of the unique things we do in radiation oncology, we pre-plan every single patient we see. And that pre-planning takes 3, 4, 5 days in order to verify and make sure we're going to hit the target and make sure it's reproducible. We image while the patient's being treated. We align the patient. We record everything the robotic devices do. So once the patient enters the room, sits on the table, it's completely robotic delivery. We look how the target is being evaluated during the radiation therapy. We look at as if normal structures are moving into our target while we're treating, for instance, bowel, other things like this, and we may have to rearrange our plan because of that. And we acquire data extensively during radiation therapy. So all imaging has an XYZ coordinate system. So you do a CT, an MRI, a PET scan, it has every point in that image has an XYZ coordinate. I think Dr. Britz mentioned that previously. Now, delivering surgical techniques and radiation therapy techniques in the brain, it's easier because organs don't move in the brain like the lung and other parts of the body. But still, what we're trying to do is to create a planning system where we can say, we can tell you the best corridor of pathway to hit that target, just like we do in radiation therapy. Because our job is to avoid spinal cord or avoid bowel, avoid this. And the computer tells us, knowing that I put constraints on the system, I can tell you where the best beam should come, just like we should be able to tell you where the best trajectory should be coming into somebody's brain if we know where the fiber tracks are. Just like in the brain, there's serial fibers and parallel fibers. You don't want to knock out a serial fiber because there's no, it doesn't have ability to repair. Certain fibers in the brain are redundant and other fibers aren't. So you need to know where they are if you're going to create a treatment planning system for surgery. In radiation therapy, we have a term called adaptation in terms of what if the target changes, what if the data set changes, what if things within the data set change, how do we adapt our plan? And again, because computer speeds are so fast, we can almost do it on the fly. Well, what do you do when you're trying to treat a disease in the lung or biopsy a disease in the lung? What we do in radiation therapy, we do what's called a 4D scan. We bin the data into 10 segments. We define exactly which segment we are in when we turn our beam on or turn our beam off. And if you don't know where the target is, you're not going to be able to hit the target. But all this is possible from what we've done in radiation therapy in creating a treatment planning system for radiation oncology. So as I said, once the patient comes in the room in radiation therapy, everything becomes robotic. This data set is placed on the table in the exact position it was obtained. If the data set is not correct, we change the in and out, the right and left, the pitch and yaw of the table to make sure the data set is where it should be before we start treatment, just like you would want to do with a surgical treatment planning system. Everything's registered with the robotic device in the room, and image verification occurs, and we begin tracking what we're doing. And we're getting constant feedback to our robotic devices to make sure we're not off by more than 1 millimeter or 2 millimeters. So we build tolerances in terms of how much motion or change there can be. And everything is recorded. So in pre-planning, what we do is we basically create a personalized GPS system or data set. We create objects within the patient's body. An object would be the target. An object would be things we want to avoid, which would be a constraint. Object could be blood vessels, could be a number of things. Because that data is going to be put into our treatment planning system, and a solution will be obtained to tell us where the best direction or where the glide path of the radiation beam should be, just like where should the glide path of the surgical instrument should be. And constraints will be put into the algorithm, and we'll come up with a solution. In radiation therapy, for instance, we have all these little beams that rotate around the patient in a 360-degree arc. For instance, we used to treat with these big 15 by 15 centimeter beams. We broke those beams into 40 different beams, and they used to stop and shoot and stop and shoot. Now they rotate around in an arc, and these little beams can be on or off for increments of 10% every 5 degrees of rotation. So now we have almost 2 times 10 to the 6 possible beamlets to come up, possible solutions, which the computer will tell us the best solution or the optimal solution. Pre-planning takes about 5 days. So in surgery, what we want to do is treat a lesion in the lung or some part of the body, either ablate it or remove it surgically, and we need to know where's the best entry place to, and where's our best glide path to get to that. Again, we volumetrically define structures so we know where they are in space in the data cube. We take into account where the structure moves or doesn't move. We take into account where it should be within your respiratory cycle. And then we consider where the best path or corridor of safety would be in terms of entry, knowing all these constraints. Now, who makes the constraints? The surgeons make the constraints saying, hey, I never want to go through bowel. I never want to go through an artery that's of this size. Instruments can be deflected by arteries with calcifications and other things like this. How do I give feedback to the instrument as I come through fat or muscle? I should be able to get immediate feedback knowing whether I'm in fat or muscle. So we need to create all these objects. We need to know where they are in space. We need to create constraints. And we need to know where our target is in relationship to the constraints, or what we call in radiation oncology, organs at risk. We need to define, is it mobile or non-mobile, and we need to have constant verification of things moving or not moving. Maybe a single access point that you're coming through to get to your target to create your path. There may be multiple access points, but all these kinds of things can be modeled within a modeling system, a mathematical modeling system. There needs to be penalties. Certain tissues will have more value than other tissues as you enter the body with an instrument, which makes your solution completely different. For instance, it's okay for me to go through certain types of tissue, but not other types of tissue. Some of that tissue can be defined by Hounsfield numbers or by all the imaging. So every patient we see, what we do is we take all their images, CT, MRI, PET scan, and fuse them all together so we have all the data in one place, and then we put the patient on the table in the exact position they were scanned in. And then we begin interacting with that data set. When something's removed from the data set, all of a sudden you rescan the patient. Again, you guys now have cone beam CTs in most of the operating rooms. We've had cone beam CTs for a while. And if you go up to the operating room that Dr. Lumsden has alluded to today on the 5th floor, you'll see a lot of radiation therapy and equipment in there for what we're trying to do. You'll see cameras on the walls, which will create an optical image onto the patient's body, constructed from the CT scan. That is not like the images that we just heard about, but it's 20,000 points that have to align on the patient to make sure they're in the right spot before we enter with an instrument or anything else like that. You'll see laser lights on the walls. The laser lights help us align the patient that they're in that position, and the data set has been registered on the table in the exact position. So a lot of the time that gets taken is in terms of creating objects and how do you create objects quickly. And there's a lot of deep learning programs that can almost auto-segment these objects within your data set. And you'll say, well, I only need to see these few things, or I need to see these many things before I make my decision, and that's where my constraints will be on my treatment planning system. You need to have the uncertainty of the system that you're in, and that has to be measured by multiple ways. And certain things, as instruments come into the body, that the anisotropy will mean that if you had a round vessel, a portion of it may be completely calcified and you'd be deflecting an instrument. There's all kinds of mechanical properties that you have to take into account when you're creating an algorithm. And that's the only formula that I think I allowed in the system. So you have hard constraints, soft constraints. Hard constraints are things you want to stay away from, but you have to weight them. Which one more important? If I'm going to come up with a solution to tell you where to enter, and I have to get all this information back to my robotic device and have constant feedback, I have to define what my constraints are, and each type of surgery will define different types of constraints. For instance, neurosurgery, you don't want to go and cause problems with the motor strip or other areas like that that are going to be significant or eloquent, what they call eloquent areas of the brain. So these are all the algorithms, all the mathematical formulas we use to create our algorithms. And if you really want to, fall asleep, you can read about all these from Nethermead, Powell, simulated annealing, quasi-Newton, Raphson. But these are the type of mathematical models we use to create a treatment planning system, the same type of treatment planning system we used in radiation therapy to create our algorithms after we place constraints on structures. And these are just terms we use in radiation therapy to define our targets, and OARs are organs at risk. And our planning margin is just basically what our uncertainty is. So if you look at, so this is something Dr. Britz watches a lot. I think it's Lost in Space. And you can see we're creating a three-dimensional data set that's going to superimpose into the patient's data. So it's really, you've basically created the data set you're superimposing into the patient. So you've basically created a model for what's in that data set that you're going to interact with. Here's an example of tagging and labeling everything in the body. So here in our cave, we created a three-dimensional, you can see here, and we can interact with this data. I can look under the pancreas, the side of the pancreas. A pancreatic surgeon makes his decision based on is the tumor engulfing the superior mesenteric artery or not. All this kind of thing is this concept of pre-planning or pre-surgical planning becomes extremely important, especially if I can tag and label everything in your body. Now I have a personalized GPS system. Now I have to take into account organ motion. I have to take into account what, for instance, a brain tumor, what has moved a fiber track in a certain direction, things like this. But these are the type of images you can create from existing data sets, because now we have 3D processing capability, proprietary and open source that we can use to create these objects. And then all of a sudden, almost immediately auto-segmenting things. So here's just 3D reconstruction of enlarging type 1 endoleak. And here's, for instance, demonstrating the optic pathways in the brain itself. You can see, so if you had a tumor superimposed in a certain area, you could superimpose on those fiber tracks and say, oh, I can tell you what type of clinical, significant clinical problem the patient was having based on where in space that lesion was. Here's another patient again with a area of stenosis and an aneurysm. And just like Dr. Cateno with his a 3D printer, in the future, you could print out a graph for that particular patient, figure out exactly where in space this was, and do reconstruction in pre-planning before you walked into the room. This is a patient with a, how important it is to measure. If you look up top, we're measuring valve size within 1/100 of a millimeter. So now we're flying into the data set using 4-dimensional data, time, and making measurements and saying, oh, I'm not gonna grab the wrong valve to put into the patient. And of course, I don't do much, I'm a cancer doctor, so I don't do much cardiac stuff, but this is something you could do, you know, take a multi-phase scan of the heart and reconstruct it in 4 dimensions. And again, graphics, and this becomes part of the patient's permanent record. And then look at the valves, look at wall motion, look at all these types of things. And all of a sudden extract data on the patient, and all of a sudden it makes importance in terms of the clinical decision making. So what we're in the process of doing is trying to create a treatment planning system with Dr. Pino. Of course, we're looking for anybody who wants to work with us. A lot of our instrumentation is already up in the operating room, the hybrid room up on the 5th floor. We have our radiation therapy and equipment in there. We have some cadavers we just purchased. And we're going to start creating these algorithms to see what kind of solutions we can come up with. Thank you very much.
Thank you, Doctor. That's really fantastic. So our next speaker is going to be Dr. Sachin Goel. Oh, there he is. Okay. He's going to talk to us about some of the additional really cool stuff that's happening in transcatheter valvular interventions.
Thank you to Dr. Lin and Dr. Lumsden for this invitation. It's my privilege and honor to speak about a topic that is very close to my heart, which is transcatheter mitral interventions. And this being a imaging-focused topic, we're going to talk about multimodality imaging and its role in transcatheter mitral interventions. My disclosures. So just a quick background slide. Transcatheter mitral valve interventions are growing. We all know about the success of transcatheter aortic valve replacement. Mitral valve and tricuspid valve are sort of the next frontier. The important things with mitral valve is, like any other valve or any other cardiac situation, is mitral valve anatomy, function, procedural access, and procedural guidance, which is live imaging with echocardiography, fluoroscopy, and fusion. These are really key. This is a standard mitral valve anatomy slide. Mitral valve is much more complex compared to the aortic valve, and the mitral valve apparatus consists of the mitral valve leaflets, the anterior and the posterior leaflet, the chordae, the papillary muscles, and the ventricular myocardium itself. A problem or a pathology in either of these components could result in significant mitral insufficiency. And then to the right, to the right you can see the anterior and the posterior mitral valve leaflets are divided into scallops from lateral to medial, A1, A2, A3, P1, P2, P3. This is kind of the surgeon's view looking at the mitral valve from the left atrium. The left ventricle is sort of behind the screen. This is very important to understand and have the same language as the echocardiographer as we're doing these procedures, so that everybody's on the same page. So the causes of MR, I like to keep it simple. There's primary MR and secondary MR. Primary MR is when there is a problem involving the mitral valve leaflets or the chordae. Secondary MR is MR related to LV pathology. This is the Carpentier classification, which was described by Alain Carpentier decades ago and still holds true, and we use it in daily practice. Type 1 is essentially where the annulus is dilated. As a result, the leaflets have non-coaptation. Type 2 is when there's excessive tissue or excessive motion of the leaflets, which is characteristic of degenerative mitral regurgitation or prolapse or flail. Type 3 is restricted or tethered leaflets. Type 3A is typical of rheumatic heart disease, and type 3B is typical of ischemic cardiomyopathy, when you have patients who have had an inferior or infraposterior myocardial infarction and have a restricted and tethered posterior leaflet resulting in mitral regurgitation. Just a couple of slides showing what degenerative MR and functional MR means. So in this example, you can see there is excessive leaflet motion. This is a Barlow's example of a Barlow's valve. This is a 3D TEE image showing excessive prolapse and tissue flail of the posterior leaflet, predominantly in the P2 scallop, resulting in severe mitral regurgitation. So this is a Carpentier class 2. This is primary MR when there is a problem with the leaflets or the chordae themselves. In contrast, functional MR is usually a result of the LV pathology. The leaflets, the mitral valve leaflets themselves are fine, but there is mitral regurgitation due to annular dilatation. In this case, this is a patient with severe dilated non-ischemic cardiomyopathy, and you can see the annulus is dilated. There is non-coaptation, as you can see. This is the short axis view of the mitral valve. The leaflets do not coapt, and clearly there is central severe mitral regurgitation, which is again seen here on the long axis views. And you can kind of see here again that the leaflets are not coapting. So there is no pathology with the leaflets themselves. This is a large ventricle, secondary to cardiomyopathy, dilated annulus. The papillary muscles are displaced ventricularly, and these leaflets are tethered, and mitral regurgitation is a result of this. So in functional mitral regurgitation, you often have what we call the tenting or the tenting area. The greater the area, the greater the pathology with the LV. And this plays an important role in decision-making process when we talk about transcatheter mitral repair, particularly with MitraClip. And imaging is critical in identifying the tenting area, the coaptation gap, the coaptation width, and so on and so forth. So moving on, quantification. So after identifying the pathology, the most important step is, of course, quantification of MR. So imaging, again, is critical in quantifying the mitral regurgitation. You have qualitative measures such as a flail leaflet or ruptured pap muscle. These are qualitative. When you have something like the slide I showed with the Barlow's valve with excessive prolapse and flail, the mitral regurgitation is generally severe. And you have semi-quantitative measures, which include vena contracta, E-wave, and then the quantitative measures are what we use most commonly to identify severity, and typically the effective regurgitant orifice area, regurgitant volume, and regurgitant fraction are commonly used. And these are the guidelines, both European and American, that are used for classification of the severity of mitral regurgitation. Cardiac MRI is becoming increasingly used, particularly for assessing LV dimensions, LV function, looking at areas of scar, particularly in patients with ischemic cardiomyopathy, because the MRI measurements are very accurate with regards to LV dimensions, volumes, and also cardiac MRI can be useful in identifying pathology. I just put a couple of slides here showing a similar example of the posterior leaflet flail. You can clearly see the posterior leaflet of the mitral valve has a flail segment, and you have a very eccentric anteriorly directed jet of mitral regurgitation. And this is a corresponding short axis view showing the flail segment. So MRI has become increasingly useful in evaluation of patients with mitral regurgitation. There are pros and cons. MRI does have superior image quality, larger field of view. The measurements regarding the volumes are very accurate and reproducible. Can be used for multivalvular lesions. Of course, there are some cons. It is less readily available, of course not in a center like this. And of course, availability and expertise is important. CT also is very, very important, particularly in planning transcatheter mitral procedures. CT provides very, very important measurements as listed on this slide. The mitral annular dimensions, the perimeter, intertrigonal distance, intercommissural distance, annular calcification can be assessed very accurately with the CT, leaflet lengths, interpapillary distance, LVOT, and the predicted neo-LVOT. This becomes very important when we talk about transcatheter mitral valve replacement. This has been shown to predict the incidence of LVOT obstruction, which is a marker of poor outcome. Coronary sinus, there are some coronary sinus-based devices I'll share with you in subsequent slides. And of course, the course of the circumflex coronary artery, relative to the annulus, which is important in these transcatheter annuloplasty-based devices. So these are various measurements that are very accurately obtained with cardiac CT. So this slide just shows what the neo-LVOT means. So here's your mitral valve, the left ventricle aortic valve, and this is the LVOT. So when we put a transcatheter mitral valve shown in this blue block here, sometimes it can impinge on the LVOT and reduce the LVOT area, increasing the risk for LVOT obstruction, which can be catastrophic. So CT has been studied extensively over the last 5 years, and based on the CT measurements, we can predict whether a patient is going to have LVOT obstruction or not, and whether TMVR can be performed safely. In fact, there is good correlation between measurements obtained on CT and neo-LVOT after TMVR. This slide just shows the relationship of the coronary sinus with the circumflex coronary artery and the mitral annulus. We have some transcatheter annuloplasty-based devices. This is the Carillon device, which is placed inside the coronary sinus, which is right behind the annulus. And by placing this device there, it cinches the annulus and reduces the coaptation gap, thereby reducing mitral regurgitation. So these measurements are important and can be very easily obtained with a dedicated cardiac CT. So transcatheter mitral therapies are evolving rapidly. There are many devices that are being studied as we speak. And there are different approaches. There are leaflet-based approaches where we approximate the leaflets, the anterior and the posterior leaflets. For example, this is the MitraClip device, which is the only approved transcatheter repair system in the United States. You have transcatheter mitral valves, dedicated valves, which can be used for transcatheter mitral valve replacement, either through a transapical approach or through a transfemoral transeptal approach. And then some of the devices have a annuloplasty type mechanism whereby they cinch the annulus and reduce the coaptation distance. And each of these specific devices, technologies, has specific imaging needs based on the type of device. So the major categories are leaflet-based devices, annulus-based devices, and then of course transcatheter valves. And depending on the pathology, it's usually a combination of live 2D and 3D echocardiography with fluoroscopy, and then there is some role for fusion imaging here, which I will share as well. So MitraClip is the most studied device. As I mentioned, this is the only device approved in the United States. It was first approved for degenerative mitral regurgitation or primary mitral regurgitation back in 2013. And then last year we acquired FDA approval for functional mitral regurgitation. Based on the anatomy, there are optimal, conditional, and unsuitable characteristics that are gleaned before the procedure based on the transesophageal echo. And then based on this, we plan the procedure. Patients obviously who are unsuitable for MitraClip are evaluated for other devices, including annuloplasty-based devices or transcatheter mitral valve replacement. I won't go into the details of this procedure, but I'd like to share with you, some of the imaging that is critical in MitraClip. We do MitraClip as interventional cardiologists. We are used to fluoroscopy. So when I first started doing this 7 years ago, it was very counterintuitive because, in this procedure, there's practically no role or very minimal role for fluoroscopy. This is purely a transesophageal echo-guided procedure. So we go through the femoral vein, transfemoral, transvenous axis. We go up to the right atrium and obtain transeptal access. This is a slide demonstrating tenting of the interatrial septum. As you can see, we use biplane transesophageal echo to gain access into the left atrium. The location of the puncture is critical for a successful MitraClip procedure, and we try to puncture at a height of about 4 to 4.5 centimeters from the mitral annulus. This is a critical measurement because the success of the procedure depends on this. If you're too high, then you may not be able to reach the leaflets. If you're too low, then you are too deep in the ventricle and may not be able to grasp the leaflets appropriately. So this is a critical first step of the procedure. Fusion imaging has been demonstrated to be useful. This is a slide demonstrating fusion of 3D TEE and fluoro, and you can see the tenting superimposed on the fluoroscopy screen, and this can be useful going forward. The second step is steering down of the catheter. This is again live 3D transesophageal echo. This is the MitraClip catheter, which is across the septum into the left atrium. This catheter has, we can maneuver the catheter and have it, face the mitral valve. and then move it anteroposterior or medial lateral and steer it towards the mitral valve. And that's what you see. In the final picture on the right, we have the catheter sort of at a 90 degrees angle across the septum and aiming for the mitral valve, which is down here. So this is very important, live 3D TEE imaging in steering the MitraClip device down to the mitral valve. Then the MitraClip arms are opened, and the next important step is orientation of the clip arms. So this is a nice slide which is showing the MitraClip arms open and the mitral annulus down below. And we want to orient the MitraClip perpendicular to the line of coaptation before we cross the valve into the ventricle. Again, live 3D TEE, in addition to biplane transesophageal echo, is really critical in achieving this. The next step is to cross the valve, is to position the clip in the jet, because that's where the mitral regurgitation is. So this is again biplane transesophageal echo, trying to position the MitraClip in the jet, and then advancing the clip under the valve. You'll see the 3D TEE up here and the live biplane TEE demonstrating the MitraClip under the leaflets in the location of the jet. And then, of course, the next step is grasping the leaflets. So this is all done by echocardiography. Fluoroscopy really has minimal role here. And this is an echo-guided procedure. And as you'll see on the bottom left here, these are the grasping views where we see the two leaflets inserted between the clip arm and the gripper arms. And that's what we want to see when we do this procedure to demonstrate that we have grasped both the anterior and the posterior leaflets adequately. And this is the successful results showing near elimination of the mitral regurgitation, which was severe to begin with, and traced to mild. And the MitraClip creating a nice tissue bridge in the center of the valve, anterior and posterior leaflets, and two orifices on either side. This mimics the surgical Alfieri stitch based upon which the MitraClip was designed in the first place. Of course, the next step is assessment of the gradients. We don't like to see this. If we see this, then this is a good result. We haven't created any mitral stenosis. So those were a few slides about the MitraClip. I'll just share some of the other newer exciting devices that are in the pipeline. And again, imaging is critical in planning, selecting patients, and guiding these procedures. So NeoCord are artificial cords that can be implanted on the mitral valve. This is used for patients with a prolapse or a flail where the chordae have torn. And so these are artificial cords that surgeons are used to doing surgically, but this can be done now via transapical and also most recently transseptal approach. The catheter is inserted across the mitral valve and the chordae are implanted and the excessive motion of the leaflet is eliminated. So I'm afraid these are not playing here, but this is again a very multimodality guided approach from planning the procedure, selecting the patients, and guiding the procedure in the hybrid OR. Pascal system is somewhat similar to the MitraClip. It again has a spacer and it has two paddles, and the goal is to grasp both leaflets between the spacer and the paddle. And again, the procedure is guided by, there is some role for fluoroscopy, but mostly echocardiography, 2D and 3D live in the cath lab. Cardioband system. So those were the leaflet-based approaches that I shared with you, the MitraClip and the Pascal. The Cardioband is an annuloplasty-based system where a band is placed around the mitral annulus starting from the anterolateral commissure to the posteromedial commissure, and eventually this band is sort of tightened and the coaptation or the absence of coaptation is eliminated by cinching the annulus. So this can be useful in patients with mitral regurgitation, which is predominantly a functional type, and this is being studied actively as we speak. So again, in the interest of time, I'll skim through this, but this is the band. As you can see, this is the pre-adjustment where these sort of pledgets are placed around the mitral annulus, and then eventually you can see these come close to each other because this is now cinched, and the mitral annulus is cinched and the coaptation is achieved. This is just a video demonstrating before and after the adjustment and corresponding echocardiography views showing elimination of mitral regurgitation. Transcatheter mitral valve replacement. This is the next step, of course. where we can put a new valve inside the mitral position. This was a case we did a few months ago. Patient also had concomitant aortic stenosis. As you can see, the aortic valve is very restricted, and the mitral valve is restricted, thickened, calcified, and there's significant aortic stenosis as well as mitral stenosis. The CT is very important. This patient had very significant mitral annular calcification. If I can go back. You can see almost 360 degrees of mitral annular calcification. This provides anchor for the transcatheter mitral valve. And this is a live fluoroscopy and TEE image. This is the transcatheter aortic valve. This patient had TAVR, and then concomitantly we did transcatheter mitral valve replacement via transeptal approach. This is a balloon through the septum, dilating the septum. This is the valve being positioned across the mitral valve. You can see the mitral annular calcification there, and then the transcatheter mitral valve being deployed in the mitral position. And this is done with fluoroscopy and 2D echo guidance in the cath lab or the hybrid OR. In the interest of time, I will skip through this. And then this is the final result showing the competent transcatheter valve with no significant mitral regurgitation or gradient across the valve. Finally, paravalvular leak closure. This is another tool in our armamentarium. Patients with previous bioprosthetic or mechanical surgical valves sometimes develop paravalvular leak. So this is again a 3D color echo image looking at the mitral valve from the left atrium. This is a bioprosthetic valve, and you can see a lot of color regurgitating from here around 2 o'clock. This is a clock face view, as we like to call it. So around from 2 o'clock to 3 o'clock, there is a lot of paravalvular regurgitation, and this patient presented with heart failure, hemolysis, and need for recurrent blood transfusions. And so we planned this procedure. This was corresponding 2D echo image, and we go transeptal and cross the defect. And in this case is echo, fluoroscopy, and fusion imaging with CT is very useful in the procedure to guide the procedure. So these are markers that are placed on the fluoroscopy screen showing the location, the ideal location of the transeptal puncture. This is the bioprosthetic valve. This is the inferior vena cava, superior vena cava. And in this case, we were able to put a muscular VSD occluder. As you can see, again, multimodality approach here, fluoroscopy, fusion imaging, 3D echo and 2D echo, and the paravalvular leak is eliminated here. This should play, but you can see the plug here at the 2 o'clock, 3 o'clock position, and there's no more mitral regurgitation in this patient. So multimodality imaging is really critical to the success of these procedures. And then we have dedicated transcatheter mitral valves, such as the Intrepid valve, which are being studied, and extensive multimodality imaging for planning of these procedures, measurements of the mitral valve, prediction of the neo-LVOT, planning of the apical approach. These procedures are transapical. They're working on transfemoral transeptal delivery systems, which is again the next step. And this is really the goal, is to eventually be able to put a new mitral valve by way of transeptal approach without having to go transapical. And so there's a lot of work being done in this space. So just to conclude, transcatheter mitral interventions are a therapeutic breakthrough, providing treatment options for high or prohibitive surgical risk patients. Multimodality imaging here is key for patient selection. Echo, CT, MRI, or a combination of these are beneficial. And echo and fluoroscopy are key for intraprocedural guidance with some role for fusion imaging in these patients. Thank you very much for your attention.
We're going to move on quickly. Dr. Valderbano? Okay. All right. Dr. Stone? All right, we're going to go ahead and move on to Dr. Stone, who's going to be teaching us about surgical simulation using 3D printing.
Well, I just want to thank Dr. Lumsden and the committee for having me out here from New York. I'm actually a neurosurgeon, and I got into 3D printing and surgical simulation in combination with the vascular surgery department at the University of Rochester. So I'll tell you a little bit about my experience with that and what we're working on. Major disclosure, from the technology that I'm about to show you, I did develop a company that now sells these products. CEO and founder of the company, and I don't see that as a drawback because I want to emphasize the importance of commercialization, and I try to teach students about commercialization, and without that aspect of technology development, we never would be able to reach the public with our ideas. So as is publication is to research, commercialization is to technology development. It's interesting, why do we call it the practice of medicine? And when you think about the way that's called, we practice every single day, and we spend our entire careers getting better and better at what we do. And unfortunately for patients, that means at some point we're learning using them as tools. And it was back in 1927 that William Mayo said, there's no excuse today to practice on a patient. And even back then, what he was talking about was going and visiting other surgeons and observing them rather than trying new things yourself. But fast forward to today, we still have much of an apprenticeship model of surgical education. And the reason is because we don't have a good platform for open surgical education. Now, there's been many advances in virtual reality and augmented reality, but there still is nothing that provides the good haptics and the ability to develop technical skills outside of the operating room. So what you're looking at here is actually the hydrogel phantoms that we're making. This is all fake, and this is using a microscope, so it's zoomed in. And not only have we done that for vascular disease, but we've done that for urology, where on the top left you're looking at a model on the DeBakey robot for partial nephrectomy. This is an endoscopic model for TURBT for bladder tumor resection. This is OBGYN doing a myomectomy, again on the DaVinci robot, and then the carotid endarterectomy that you're seeing. But we're branching out into these other surgical fields that are requesting. Of course, this can't be done by one person. I have a huge team at the University of Rochester who I'd like to thank, including the Department of Urology, who a lot of these studies were completed with. This is becoming increasingly important because of the awareness around patient safety and quality of healthcare delivery. In recent publications, medical errors are now considered the third leading cause of death, and they're right behind heart disease, cancer, and then medical errors. And so us as surgeons and healthcare delivery agents, we need to combat that and show that we are actually actively attempting to reduce these medical errors. When it comes to surgery, there's really, in my mind, two classes of surgeries. You have the regular common surgeries with low surgical error rate. And yes, as you do more, you get better. And then you have these complex surgeries where when you first start out, they have a very high complication rate. So how do we bring those complex surgeries down to the level of the regular surgeries where we're not performing those errors on patients? So let me show you a little bit about what we're doing, how we create these models. It's all about the geometry of the organs. So essentially we are sculpting human organs out of hydrogels, and we're using 3D printing in order to achieve those geometries. So we make negative molds, and we 3D print those molds using just regular basic 3D printers. You can buy now a 3D printer for under $1,000. You can also buy them for $350,000. So there's a wide range of printers, but the point is you don't need to actually have an expensive printer to do this. So you start with a polymer. We use a polymer called polyvinyl alcohol. This is published in all the works that we've created. And you mix your concentration, you color it if you want, you put it in the injection mold, and out pops organs that look like human tissue, and you can make all sorts of things and practice surgery. We're very procedure specific, so if you're doing a partial nephrectomy, you may want a flank of an abdomen. If you're doing a thoracic aorta, you may want to include lungs and the cavity. This is where we started. I started with a urologist, Ahmed Ghazi, and he came to me and said, I want to practice surgery. And so this was our first kidney we ever made, and the goal was for it to bleed. And so it turned out pretty good. And this is where we came to now. This is a leg, and I'm actually a peripheral nerve surgeon as well, and so this is meant to be a schwannoma model. And you can see how the textures are more realistic, the coloring is realistic, we've gotten better with our bleeding, it's multi-layer. Every tissue layer is a different stiffness property, so you're actually recapitulating human tissue with these models. And not only that, but now we're putting in engineering. So for this project, I actually put in these fine wires that are 40 gauge so that you can actually measure the electrical conductivity. And because they're hydrogels, you can ultrasound them. We put barium sulfate in them so you can CT them. And we have other agents that you can use for MRI. And then you end up with these beautiful simulations that you can train residents on. And this was after the tumor removed. You can see that the cables were preserved. For the carotid model, we create an idealized carotid artery, and although you're molding it as a straight Y shape, you can actually, when you're building the model, you can actually build tortuosity into the vessel. And this is one of the cool things, is you can make however complicated of a model or simple of a model if you want. So if you wanted to make a challenging model, you could, or a very basic model for early learners. Even the skin is a multi-layered thing. So we have, dermis, subcutaneous tissue, platysma. You try to add in there all the elements so it's as realistic as possible. And things that you don't interact with, you can just straight 3D print, like the skull base or the mandible. And then you layer it back in anatomical fashion. And this is great for medical students who are trying to learn anatomy and participate in research. And you end up with this slab of tissue that looks like human tissue. And then you can operate on it. And so these are just some examples of surgeries being performed. The pot scissors through the vessel. That's the other part about this, is you see a lot of these virtual reality systems coming out where you're holding these controls that aren't real tools. And I feel like using the real tools is a critical step to your motor memory. We spent a lot of time on the plaque interface for the carotid model. So you can see here this plaque intima media, the plaque media interface came out quite realistic. You even end up with these little strings of plaque that you have to peel off, kind of like a real surgery. And so you can really get down to the details. Of course, you can do angiography on them, so you can deploy stents and whatever you want to do to the model. This was a study we published looking at attending versus resident performance, and just looking at these times, I think is very telling. So the attending spent about an hour doing a carotid endarterectomy on this model. And that's pretty good. I mean, that's about what they would spend skin to skin on a human. Some are faster than others, obviously. Carotid clamp time of 43 minutes. Now, our carotids were a little more challenging, so they had to do some sharp dissection to get the plaque off. So that's probably a little unrealistic. But if you look at the resident time of 140 minutes, now if you're a patient and you're about to have a carotid endart, are you going to say, I want the resident who's still at 140 minutes to do my surgery, or the senior resident who's shown that they can actually do this faster already, not in a human, to do it? And then nerve injuries. We put a vagus nerve, we put a hypoglossal nerve. The residents cut through the nerves. And so is that a safe thing to have them do in human before they learn those mistakes in the model? The other cool thing is training for new technology. So do you patch or do you do primary closure? That's something, and you do one because that's how you train, but maybe data comes out that it should be the other. Or there's a new technology that comes out that you want to try, but you're afraid to do it in a human. So there's cadavers, which is a great learning model, but in cadavers you can't always build in pathology that you're treating, so there's a little bit of mismatch with the education. So when we first did TCAR at our institution about 6 years ago, or maybe 5 years ago now, before we put it in a human ever, we put it in one of these models. And so we did a complete procedural rehearsal, and we were able to actually run through all the steps, again, skin to skin, and make sure we were comfortable with that procedure. And so here's our team. This is Dr. Marampuri, who is a neurosurgeon, Dr. Stoner, who's the chair of vascular surgery, and then a proctor from MGH who came to teach the procedure. And so he was there for the live cases as well, and that's usually all it is. Usually all it is a proctor doing a live case the first time you've ever used a device. And so you can do your vascular flow loop and practice the whole thing. This is one of my favorite pictures here because Dr. Stoner is actually smiling. And he's smiling because he's get to play with a new toy without any risk to any patients at all. So this is on a Sunday. We're here working in the angio suite, putting a device in, and he's happy because he feels confident about tomorrow's case that he's going to do. And this is the view of the simulation, and this is the view of the real patient the next day. And much like the patient, the simulator is pulsatile. We use a VAD to actually create pulsatile flow within the model. The other cool thing is you can try emergent procedures. So after we did that T-car, you can see this is the T-car incision here. I just stabbed the model with a knife, and I gave it to the trauma surgery team. And so these are incredibly versatile. Once you have the anatomy, you can do pretty much anything with them. And so I gave it to the trauma fellow, and he said, "Well, I've never seen anyone come in with a knife still in their neck." So he said, "Oh, I guess we'll get control in the OR." He pulled it out and he went to work. And you can see the pulsatile flow coming out of the arterial injury there. And he got control with vessel loops, and he was able to do primary repair of the vessel. And there was actually a lacerated nerve too, just by coincidence. And so it really affords an opportunity for people to practice rare scenarios or emergent scenarios where the training staff is usually pushed aside because it's a life-threatening situation. So there he is repairing the nerve as well. The hypoglossal nerve got hit. So we have a ton of other examples, and unfortunately I don't have too much time to go in depth on all of them. This is a neurosurgery model. Dr. Bliss had showed ICH evacuation. So that's an incredible amount of technology in the neurosurgery OR. You have stereotactic navigation, endoscopic surgery, an aspiration device. Many of the tools that surgeons aren't used to using in neurosurgery. And so we've been working with Penumbra, the company that makes an aspiration device, to actually put on training symposium using this sort of technology. This is another example that's published about cervical spine surgery. So when you're decompressing someone's cervical spine, you're putting a metal, dangerous, sharp instrument right next to their spinal cord. And I don't know about you, but for my neck, I want to make sure that no pressure is put on my spinal cord. So for this one, we actually built in a pressure transducer as the thecal sac. So the dura and the spinal cord actually is measuring the pressure as you're putting the instrument in. And we could actually differentiate, again, expert performance versus novice performance. And the amount of pressure put on the spinal cord was much higher in the novice. Not only that, but we looked at the amplitude of the force and the number of bites altogether. And so again, when we move towards an environment of safety and quality of healthcare delivery, are we going to come up with certain ACGME simulation rules that a resident has to go through? And they're going to be program specific. The question is, what is the platform they're going to use? Is it going to be a virtual reality platform? Is it going to be a physical model platform? Are we still going to rely on oral board metrics? It's really unknown, but it's going to change in the favor of simulation over time. The other aspect of this that I wanted to mention is patient-specific simulation. So what I just talked to you about, this kind of, we're going to do simulation to make better doctors, which will hopefully make better patients, is a crowd phenomenon in training masses. But can we use simulation to help every single patient? And that's where patient-specific simulation comes into play, where you actually take their imaging, their DICOM imaging, you do segmentation to it, and so Materializes is one of the FDA-approved segmentation software. There's some free ones that are out there. And you highlight all the different aspects, the tumor, the kidney, the vessels that are going to it, and then you create a CAD, again, using our three-dimensional printing injection mold techniques. We then can inject that kidney and practice that patient's-specific surgery prior to the actual event. And you end up with these beautiful looking, these organs that are patient-specific. And if you can do this fast enough, you can actually rehearse surgeries, or you can have your fellows and residents rehearse surgeries before it's done. We did one small pilot study on this on percutaneous partial nephrectomy, which is basically through the back, where you go into the calyx system of a patient and break up the stone using laser or sound. And so we did 10 patients like this, where we actually simulated prior to their surgery. Here's just a short video of each version, and for time I won't go through that. But basically, what we saw was that there was a significant reduction in fluoroscopy time. the number of needle sticks to get into the KLCL system, the number of complications that were generated, and additional procedures, mostly for persistent stone formation in form of shockwave lithotripsy. So basically what we're showing is if you rehearse a procedure, you can actually improve quality of care delivery. You know, the question remains though is who do you need to rehearse in and how often? You know, these procedures are if they're common enough, then a rehearsal is going to, you know, double your workload. And so it's not practical to actually rehearse every single case. The complex ones, the difficult tumors, the complex aortic aneurysms, those are the obvious uses. But that's what we're trying to figure out is the right patient population that necessitates this patient-specific simulation. So as we look forward, you know, we use a combination of patient-specific and idealized simulation to train the resident staff and gain new skills with advancing technology. Thank you very much.
Wow, that was definitely the one to end on. So at this point, we're going to go ahead and break for lunch. But what I do recommend is go out, grab your lunch, bring it back in here because we have two really fantastic talks that are going to be coming up right afterwards. So lunch should be outside. Grab it and come right back.
From all faculty, you can follow me. You have a separate area.
Dr. Lumsden, everybody can see you. You can say bye.
Bye. Ethan, I think the lunchtime talks are incredible. Thank you.
The vascular masterclass in ultrasound is really designed to teach somewhat of the basics principles, but we emphasize much more the hands-on experience. In the DeBakey CV education programs that we run, we pride ourselves with the concept that we can deliver lectures to you anywhere in the world. We can do that using electronic media.
It has been an amazing course. Small groups, very approachable, very personable, and tons of great information. There's lots of information I can definitely bring down to our practice, to our physicians, and hopefully involve TCD into our daily practice.
Having the ability to talk one-on-one with the physicians in a small group, in a small room, and being able to understand and listen directly from them what's useful.
So we pride ourselves here in providing what we think is a premier hands-on experience. In order to do that, we need two groups of people to be vested in this. Number one, it's very important to us, and we're very grateful for the imaging vendors who bring in the latest and greatest technology and imaging equipment. But in addition to that, it's extraordinarily important that patients participate. We really want you to be scanning with known pathology, and we have a number of patients who very graciously agreed to give up their weekend, come in here, and be subject to applications for this new technology. So in that respect, we think we've got the best of all worlds. Very grateful patients with known pathology and the latest and greatest in imaging technology.
We are here to showcase our Accuson Sequoia for the sonographers and physicians at this conference. It's been a real pleasure being able to share our new technologies as well as showcase everything that the Sequoia has to offer.
Having the chance to attend the conference this weekend allows for the opportunity to partner with Methodists and find new and innovative ways to bring products to the marketplace to help improve patient lives.
So I'd like to invite you to come and attend the next Vascular Ultrasound Masterclass. It really excels in having world-class faculty, the best technology that you can get your hands on, and patients with known pathology where you can get actual scanning experience and real-world interpretation classes. So please come and join us in Houston next year. Thank you.
The Society for Vascular Surgery came up with an initiative a few years ago of creating vascular surgery interest group chapters across the nation, with the goal of raising awareness about this great specialty in medicine and fostering interest in vascular surgery in current medical students. The goal of creating this vascular surgery interest group here at Houston Methodist is to allow medical students from the various medical schools in the area to engage in fun and beneficial learning experiences, and to allow them to learn more about our great specialty.
My name is Jacob Watson. I'm a second-year medical student at McGovern Medical School. We really enjoyed coming out today to Methodist Hospital for the Vascular Surgery Interest Group workshop. We learned a lot of great skills and got to practice some interventional procedures and work with the residents and attendings, which was a great experience.
We have multiple ideas in mind, including multiple hands-on workshops, suturing and knot tying workshops, venous access using ultrasound imaging, as well as many other ideas in mind.
I really enjoyed learning about vascular surgery and mingling with the residents. I really enjoyed learning how to use the ultrasound machine to guide catheters into the neck. And I think it's really a really good experience this early on in my medical education to get these sort of hands-on skills before I go to the clinic, just to be more prepared and understand more about what it means to be a vascular surgeon.
We will also have industry-sponsored events during which medical students will have the ability to play with demo gadgets as well as deploy stents and look at grafts as well as catheters and wires that we use on a daily basis during our interventions. We will also have meetings during which students will be giving tips and tricks on how to be more competitive applicants, as well as answer them any questions regarding their application and match process, which can be a scary and stressful stage of these medical students' career.
My name is Kyle Shepard. I'm a third-year medical student at McGovern Medical School, and today I got to learn how to do ultrasound guided central lines with Houston Methodist. There's the practical skills that you can walk away with, like how to place a central line, but also just like knowing how to network with other people and making sure that you are asking the right questions and prepared for the next step when you're looking at applying for residencies.
We also aim to engage students in more hands-on workshops, as well as allow students to be more aware of what vascular surgery is all about and help increase the interest in this great specialty.
Hey, I'm Don Yap, and I'm a nurse education specialist here at Houston Methodist Hospital, the Texas Medical Center. I was asked to be here today and be a guest speaker on pacemakers and EKG rhythms, as well as give an overview on ventricular assist devices for the breakout sessions.
Hi, my name is Tracy Kennan. I work here at the Houston Methodist Hospital. I'm one of our nurse clinical experts. My specialty is in transplantation, heart and lung transplantation, along with mechanical support.
The concepts of blood conservation have really evolved over the last couple of years to really include a team-based approach. And we're trying to go through and discuss in a team-based approach how to limit blood transfusion or do blood transfusion but in a responsible way to benefit patients, to be cost-effective modalities.
Today, while I'm here at this conference, you're going to enjoy meeting me upstairs when we talk about ECMO, extracorporeal membrane oxygenation. We'll do some simulation, we'll run through some plays, get your hands on, and you'll have a lot of fun today.
I'm very excited to have my team here as we grow our CV program at Willowbrook, and to be able to bring the techniques of our HMH, as we all know, standardizing that care to the suburb area, so we will be able to provide the same paramount of care to our patients.
So I'm most excited about doing the hands-on things, working with machines. I heard we're working with the ECMO today.
And so I'm excited to use that and kind of get more experience with that so I can use it on my patients.
The one that interested me most, being here with the simulation. I love to be in the simulation, especially with, doing the sternotomy. I haven't done it yet, and it really helped me, especially the gowning up and the preparation of the sternotomy.
Really surprised to hear about the blood conservation and the things that we're doing with that in terms of our campuses, and that's definitely something that I think that we can carry into our smaller community hospitals.
This is all about community, and having this dialogue is really very, very key to understand that somebody else is going through a similar type of problem. But when you find out that the person next to me has the same problem, the person across has the same problem, it gives you some solace that you're able to get through these very tough times when there's a community and you have other people to reach out to.
This conference is great, and I enjoy coming here. It helps me with encouragement. It's also to have hope, and to provide hope to others. Because sometimes we can get a little down, or it's dealing with this over and day after day after day, and I kind of need to hear that message more often.
In today's world, to get information on the condition, especially for conditions like congestive heart failure, it's very easy to get lost in. This is one of a few kind of conferences where we are doing it for individuals who are affected by heart failure, not for medical professionals. So I think this gives an opportunity for us to break that barrier and let them come to the right source where we as health professionals can clarify all possible questions, and in fact sometimes learn together.
awesome lunchtime series of talks. So I'm really thrilled to introduce the next speaker, Panraj Chinadurai. He's a scientist, staff scientist with Siemens. But more importantly, many of you guys who actually work here at Houston Methodist actually know him because he's really the glue that holds us all together. His official title is that he's in collaborations. But what that really means for us is he's the bridge between the clinical application and the really advanced imaging techniques that we can do. And so he's going to talk to us a little bit about what he does and the magic that he performs. Panraj.
Thank you, Dr. Lin. Thank you, Dr. Lin. My first disclaimer is I don't have any magic tricks here up my sleeve. Thanks again. Good afternoon, everyone. This is going to be a very high-level talk. There is no graph, no data, no numbers, no p-values. Let me see if I can go forward. So, as Dr. Lin introduced, I'm one of the on-site research scientists for Siemens. I've been privileged to work here in this special place called Texas Medical Center for the last 10 years or so. And I'm a physician by background, and I'm very much interested in image-guided interventions, how we can make procedures safer and better by using image guidance. Of course, my disclosures, and one other disclosure I wanted to make sure is there is no investigational component that I'm sharing here. Everything that I'm showing here is commercially available. And one other obvious bias here is I was there in most of the cases that I'm talking about or sharing in these slides. So before I go to my topic, I would like to acknowledge some of the people I had the privilege to work with. I spent some time in neuro space and did some body IR work, and lately at Houston Methodist I've been exploring how we can use imaging to change minimally invasive surgical procedures. And I didn't have time to kind of put together every individual case, so I'm crediting everyone who has taught me a lot, and I worked with them, and each one of the cases has been a learning experience for me that I'm going to share in the next few slides. So I think this is just a setup slide to show that the procedures are getting more and more minimally invasive and catheter based, and TAVR is classic one example. And most of these, when we go into catheter based procedures, obviously we don't have direct vision like we have in open surgical approaches, so we need advanced imaging equipment like what you are seeing here is a C-arm. X-ray tube is here, the detector is here, and here what I'm showing is how you can rotate the C-arm around and get a cone beam CT-like picture. So why do a 3D image? So the answer I'm trying to show here is this is a luminogram. What we are seeing is just contrast flow. We are not really seeing anything about the wall. We are only seeing the lumen here. Whereas here, by doing a 3D spin at the end of the procedure, we are getting, in this particular case, a non-contrast high-resolution cone beam CT image that shows clearly how one of the snorkel of the stent that's going into SMA, this is a stent in the celiac, has been pancaked or compressed. And this is a good case where we are seeing after a fenestrated endovascular aneurysm repair where the stents to the renal arteries are not really kinked or compressed. So this is an information you can get right at the end of the procedure without waiting for a post-procedural CTA. So that's the advantage of getting both 2D and 3-dimensional cone beam CT imaging. This is the one text-rich slide that I have, bear with me. So this is kind of how I lay out the solution. For example, most patients who undergo these minimally invasive procedure undergo some sort of diagnostic imaging modality, whether it is CT, MR, or ultrasound, or like even diagnostic 2D cath images. So what we can do, or we have especially in a hybrid operating room, we have access to so many other imaging technologies like fluoro, angiography, cone beam as I showed, all the other ultrasound-based imaging modality, transthoracic, transesophageal, intracardiac echo. And one other part that often I find fitting in and trying to bridge the gap is how do we use all these imaging modalities together with the intraprocedural imaging to achieve the task that we wanted to do. And that part relies quite a bit on how well we select the data set and how well we use these technical tools, like for example, image fusion, which could be hardware-based, calibration-based fusion, or pure image-based fusion, or I think there are plenty of talks before me on individual applications of how these image fusion has been used. And optical, we talked a lot of neuro, and EM is electromagnetic, and fiber optic shape sensing is another exciting upcoming technology where you can, not just the tool tip, you can get the entire shape of your catheter or wire or your delivery system without using fluoroscopy. So the reason I put this as a layout here is because I'm not going to go through each one of these. I'm going to focus primarily on how we can optimize the inter-procedural guidance by processing all these diagnostic imaging data that we already have for these patients. So I'll take a step back and address it from a philosophical standpoint. I'm going to throw in two concepts here, two themes, so to say. One is the perspective. So I'm going to go through how it is in endovascular procedures and how it is in open procedure. For the art enthusiasts in the audience, so this is an art that was kind of quite popular in the early 20th century, where it's called Cubism. So if you look at a painting, typically it's all from an artist's one viewpoint or one perspective. Most of the paintings are like that. So when the Cubism was became popular by Picasso, it's actually you can take any object, let's say a water bottle like this, and you can view it from so many different perspectives and create a composite picture. And this is one of such a composite picture. So the reason why I'm bringing that up here is when you talk about 2D fluoroscopy, often it is one angle or one projection that we are imaging. There are so many things that we can find if you had that other perspective, and that's kind of what we are trying to bridge here by other imaging modalities. Like what fluoroscopy can give us is often planar, and what we can get from other three-dimensional imaging modalities like echo or CT or MR is how we can make that current imaging data that we are using to make a decision of deploying a device, how we can make that better. And that's kind of the first concept I wanted to address across different examples. So it's not going to be one particular clinical specialty. All I'm trying to do here is share what I saw as a common theme when I go from neuro to IR to vascular to cardiac procedures. And the second concept I wanted to touch here is how do we are in the data overload era where we are patients walking into our clinics with tons and tons of CDs and MRIs and CTs. So how we can decode the information that we have in the multimodality data and encode them in a form that the surgeon, who may or may not have in-depth understanding of how these images are being acquired, and so how we can kind of put it all together in a very simpler format, so that way the data becomes very rich as we climb this pyramid. So currently we are in the phase of like, how do we make it better so we can enrich the surgical decision-making process without having to go through 5 different PACS systems. So this slide is credited to Dr. Lumsden. So this is kind of what I was looking at, say, how is this challenge of data visualization addressed in other specialties or other industries, for example. So I don't think anyone in this room would be willing to kind of change this default view that we have in Google Maps and drive their car, because the key differential factor is at any point of time, your local position is tracked and your the display is adapting to the user's perspective. And that's kind of what I wanted to address. The same applies to the Cessna cockpit engine view that you are seeing here. So when it comes to endovascular, so I'm starting with endovascular and kind of moving and trying to spend more time on open procedures. So if you take an X-ray image or endovascular procedure, you don't have direct vision, so you're relying on X-ray images. So here you have an example of a biplane. So these are the A plane and the B plane X-ray images. And in a hybrid OR, typically you find a single plane system. So the very first and foremost important task is, how do we use the preoperative imaging data to derive the optimal CM angle for that particular interventional task? It could be very simple as groin axis, where you're trying to stay above the profunda branching point, or if it could be a TAVR deployment, or it could be a endovascular aneurysm stent graft deployment. It doesn't matter. So it is up to the physician to understand what kind of tasks that we are planning to do and find that information from the pre-procedural images and derive this working projection or optimal CM angle in this particular case. So then the next step is, once you are at that particular projection, you can always reacquire the data intraoperatively and get an updated, most up-to-date picture, and you can still have the ability to overlay information from the prior images onto your current imaging modality. So for the CM angulation, I'm talking about, so here in a system like this, we have real-time data of where the CM and the table is. So you can, once you have a three-dimensional image, you know exactly what view you are going to achieve without even having to use any more x-rays. So this is kind of one advantage we can make use of in a fixed angiography system like this, which is not often the case in mobile CM, although there are some of these assumptions are still valid even when you use a low-end mobile CM-based intervention. So this is kind of like an overview slide of all the applications or all the cases that have been talked this morning. So I don't want to go through each one of them. I just kind of wanted to point out a couple of things. So in cases like this, aortic coarctation or aneurysm, it's quite obvious we are overlaying the pre-procedural three-dimensional data on top of the fluoroscopy. The fluoroscopy is in the background. That is used to guide the procedure. For example, a pulmonary valve or a tricuspid clip in this particular case to orient the clip. And one other thing I want you to pay attention to is all these angles, right? So these are not just random numbers that we came up with. So these are angles that are based out of the particular task. So for example, in this particular case, we were trying to stay away from the left subclavian, same here, and here we are trying to see the en-face view of the tricuspid annulus. So for that particular interventional task, the CM angle has been optimized, and once you have that information, that is step number one. It's not all these fancy overlays that we are seeing. So getting to your working projection is your foremost goal of what we can derive from the pre-procedural CT, and that's what I'm trying to get to here. So for example, here, this yellow circle is a paravalvular leak of an aortic valve that is overlaid onto the fluoroscopy, and the guide wire is used to get in through that hole without using any more contrast. So this is another example of how you can use a pre-procedural information to guide your procedures. And the last one is probably non-CV, or it's more on an intracranial aneurysm, where you could see us trying to find an optimal view where we have very less overlap of these coils. So it's a huge MCA aneurysm on the left side. We are trying to find an optimal view, and then you drive the C-arm to that particular angle, and then you do your roadmap. So now taking a step back, so this is kind of conceptually how most of the image fusion algorithms work. I have not gone into the details of how you fuse the data, because the very first step, I believe, is getting the angles right. And when we go to the lab in the afternoon, we can talk about how these data sets are fused and how you have multiple approaches to incorporate CT or MRI or ultrasound onto your fluoroscopy when you're deploying these devices. So for now, I'm going to switch gears and spend some time on open surgical procedures. So for open surgical planning, we are kind of trying to see how else we can visualize the data with better depth. So the main difference between the two images that you're seeing here is the depth. So it's the same CT data set that is rendered. The one on the left is rendered using some advanced 3D rendering techniques that are typically done in like Hollywood movie graphics. So it is more computational intensive, because every ray that you shoot through the 3D volume has to compute how it's going to get that intensity values based on quite a lot of computation towards how that photon is going to be reflected, if it is bone versus muscle versus vessel. So that's why this takes an extra few seconds to render, but you can already see for a skull-based surgeon, this already gives a lot of depth information that they may not be very obvious from this image. So this is another example. This is the standard volume rendered image that you get from CT. And this is one of the cinematic renderings showing an abdominal wall hernia of intestinal kind of herniating through the abdominal wall. And you see all the fine surgical landmarks that you would often see during an open surgery without actually having to open the patient. So this is just another example of how you can use the existing data to plan and get ready for your surgical procedure. So this is an example of one of the recent cases we did with Dr. Lumsden. So what you're seeing on the left is a patient's left carotid body tumor that's being resected. And this is the corresponding view of a preoperative CTA, which is manually oriented to what the surgeon is viewing. So this is kind of going back to the first theme that I was talking about. It's all about the perspective. If we do not show a data which is in sync with the surgeon's perspective, it is better not to show that data as well. So that's kind of what I have learned. I have made that mistake as well. I have learned through this, and it's always first to study what, if it's a spine surgery or laparoscopic surgery, what is the perspective, and then we have to figure out what is an ideal way of showing that data. So the key here is it's very simple nature of how our human brain works. Left has to be left always, right has to be right always when you're kind of mapped to your surgical field. So, and then currently we are in the process of how we can use this pre-procedural CT for open surgical procedures. We haven't done a lot of integrating into the surgical field. So I'm going to share a couple of examples. So this is a CT rendering of skin to subcutaneous tissue. So you can see the sternocleidomastoids, the veins, and so now we are kind of peeling away the muscular layers, and now you have the left internal carotid, and that's the carotid body tumor and all these veins. And this is rendered from a CTA. So one information which is key, which we are missing here, is nerves, which we are kind of trying to get from MR, but we are not there yet. So this is just one example of how a simple, I shouldn't say simple, how a straightforward carotid body tumor can be planned with the richness of data that's already there in the CTA. More often, the surgeon, the standard workflow in most operating rooms is the surgeon scrolls through the axial images and then goes ahead and makes the incision in the chest. So that's kind of the paradigm I'm trying to change here, is how can we make use of all these rich 3D data sets for open surgical planning. So this is another cardiac surgery example where you see a patient had a redo chest. So here you see the Lima to LAD bypass. So I'm kind of going through layer by layer, and this is the left internal mammary to LAD bypass, which is often good to know when you are trying to kind of make an incision so that you don't injure this bypass graft, for example. So this is a simple, quick rendering, but gives you an idea of how you can visualize that data. So now coming back to, okay, now we have identified how you want to render the data, but now we're kind of trying to see how we can give this or show this to the surgeon. I apologize for the, it was working well, and it kind of for some reason flipped. So what you're seeing here is a tracker that is being used, and this tracker is registered to the patients. So this is, in this particular case, it's a cadaver CT data set. And as you are advancing the tracker, this is a very low infrastructure, very cheap tracker to kind of like navigate through the volume while you are scrubbed in the surgical field. So we are kind of in the process of testing this, and this is another way of, there are so many other platforms, AR, VR, MR, but the ultimate challenge here is going to be, what is the least intrusive way of getting this data? For example, in this particular case, you can manipulate the CT data set while you're in the surgical field without going through lots of steps. So the key here is seamless integration to the surgical workflow. And then all these procedures could be used a lot of, you can maximize a lot of these imaging data that we already have, that we are generating. We are not acquiring any extra data. None of these patients got any extra scans. Most of these scans are already done as a part of clinical routine. I just kind of wanted to show, this is one other like non-clinical slide that I threw in. So it is so important to often like understand what is the knowledge that we are gaining from this data. So I can claim that I kind of had the privilege of working in some part of this pie chart where so once you understand a particular procedural steps, to me that's the very first step in working on a problem. Then you try to see what kind of steps you can automate. So this is one example where this entire center line and the mesh of the aorta has been segmented automatically without any user input. And the only exception here being the pelvic kidney. So usually you see the kidneys somewhere here. This is a transplanted patient. So we wanted to make sure we are not injuring this kidney. So we planned this case, and once you had this information, then whether it is open surgery or endovascular surgery, you already have the plan. You knew your angles, you can fuse these data sets as we have shown in the example slides before. So, and this, I'm kind of showing a few more examples. So these are not just images that just popped out of the CT scanner. It took kind of a few minutes, and sometimes even more than a few minutes, for me to generate these data sets. So this is one of the cases with Dr. Huey Lin, where we tried to cross this coarctation, and we stented this coarctation. This patient underwent a bucket handle surgical repair before, and then this is one of the adult congenital cases as well, where we were trying to find or characterize the right coronary artery fistula, where it is inflow and where the outflow is, and trying to kind of find optimal views. So most of the procedural part is done the day before. We knew exactly what angles we were going to work on, and in a case like this, where you have to inject contrast because we often cannot provide accurate, reliable guidance in the presence of coronary motion, for example. So I'm going to skip through in the interest of time. These are some examples of thoracic aneurysms. And this is an infected EVAR patient who has pneumatosis, so you can see even the air pockets. So I added this example. It's not just vascular information. We can also try to get soft tissue information. So again, now we are transitioning from 3-dimensional to 4-dimensional space. So we saw some of these images earlier, gated CTA and dynamic CTA to rule out endoleaks. So all these, so now we have this rich 4-dimensional data which can be used. So the very first angiogram that was done in this particular patient was this angiogram after we gained trans-abdominal access, and we parked a catheter, microcatheter here, and we injected. We clearly identified this is our target vessel that was known from the day before. So this is another example of how you can clearly plan the procedure without having to repeat. So this is another example of dynamic imaging of MR and CT, and we are trying to characterize where the fenestrations are to decide how much we need to cover the patient's aorta in the risk to balance the risk of spinal cord ischemia. And once you have this rich dynamic data, you can also play a what-if scenario. For example, this is a patient of Dr. Lin's coarctation case, where we were looking at the flow patterns right distal to the coarctation. So it's not just the contrast filling, but in cases like aortic dissection and coarc, we are not just treating the morphology, we are treating the physiology. So if we don't understand the physiology baseline, we cannot make sense of what the physiology changed after the device deployment. So this is an example of a 4D flow MRI. I know we have a talk tomorrow. I'm looking forward to that as well. And this is one of our recent cases where a type B aortic dissection, where we were planning to see how much of a stent coverage we're going to use. We haven't treated this patient yet. So this clearly shows how much flow is. So what we are seeing here is the true lumen flow in red or reddish, and what you're seeing in blue is the false lumen flow patterns. So there is a lot to explore from this data sets. I'm not an expert yet, but all I'm pointing out here is we have enough data today to look at, and especially in a company like Siemens, we have technologies to generate data, but we also have to focus a little bit more time, and there is a learning curve to all these things that I have shown today, is how do we make efforts to do a good visualization so the surgeons are not spending minutes or hours of data, hours of their time to look at these images. So one last thing I wanted to finish up with is all these imaging is just good if it's not combined with navigation. If you are still relying on the users manually driving the catheters and bumping on the vessel wall, we are still relying on the user's skills. By no means we need the user's skill, I'm not underestimating that, but the technology can not just show where the target is. If we have the right navigational technologies, like for example, it is currently becoming popular in the pulmonology space with endobronchial robots. So in potential, I'm looking for to have some endovascular robot which can streamline this process of understanding the anatomy, updating the plan in the operating room, and then driving to our targets with very minimal risk to our patients. So this is kind of my summary, where I don't have to repeat it, we really are at a pinnacle of how we can push the field by understanding imaging. And for endovascular, I think we talked about this, where it's so important to set up our views. And for surgical interventions, we are still scratching the surface of how best to visualize this data from a surgeon standpoint for individual surgical procedures. Thank you very much for your attention. I'm sorry I went over a little bit. Any questions?
How long does it take for each image to acquire one image? The last movie that you showed.
Oh, the 4D flow MRI. So the current acquisition time we have, I would say between 8 to 10 minutes. We have some latest compressed sensing license for MR. So on an average, it adds an extra 10 to 15 minutes to the scan time of your regular MR protocol.
So the individual frames that you are showing in the movie, they're probably about 1 second. I thought they're about 1 second apart, right?
Yeah, so they're close to 1 second to temporal resolution that we are looking at.
Right, so acquire that one frame, how long does it take?
So the streamlines that I'm showing are computed. So when the 4D flow MRI is acquired, it's acquiring in X, Y, and Z phase contrast images. So it's acquiring each time points. I don't know the exact time for each phase, but the total phase for the total cardiac cycle and the dynamic time that we set is usually 10 to 15 minutes. Yeah. Oh. Now it's my pleasure to introduce Bruce. Bruce Blausen Works has a company called Blausen, which is a leading medical animation company. I had the pleasure of collaborating with him on that carotid case that I was showing you, and Bruce here is going to share how he's going to change and revolutionize medical education with all his animation technologies that he's working on.
Thank you. So normally I present this in conjunction with Dr. Alan Lumsden, but I have the honor to do it myself and take all the credit. So we were having lunch one day, and he said, if I gave you real patient data, like what can you do with it? And my background, I have an art degree and a biology degree from Penn State. I did research in diabetes for a year, went to Johns Hopkins. I have a master's degree in medical illustration. I worked for Dr. Red Duke for a number of years. 1991, I started my own company. We now own the largest 3D medical and scientific animation library in the world. And at that point, when we were having lunch, he's like, we're doing all of this stuff for patient education. How do you see this real patient data being transformed into something that we can show patients and or show other surgeons? So I said, well, let's take a look at an example, and we started working with all of the content from the carotid tumor removal. So basically, this is the patient as he presents. We go through with Siemens Healthineers, and we start to look at all of the data and try to begin to identify what we want to keep and what we feel is unnecessary. So you've seen this. This is essentially just sliding back and forth.
For planning in most institutions. Using Siemens cinematic rendering, the CT scan is made to look anatomical and the location of the carotid arteries marked.
Let me see this. So there's another company called Materialize. They have a product called Mimics. And Mimics essentially allows you to bracket the anatomy. And so by picking the different densities, you can then begin to isolate different anatomical structures.
Using a software program developed for 3D printing, we extract the relevant anatomy for animation. The extracted anatomical structure is then imported into animation software where a patient-specific model is created.
So this all happens fairly easily, but what you end up with are certain artifacts and certain things that aren't anatomically correct, and you need to essentially clean it up a little. And so we pull all of those models into a program called 3D Studio Max.
The animation wireframe is manipulated for texture, function, and tools added.
So it's at this point that we start looking at the structure itself. We start to go back to the video, and we start to look at colors, textures, the instruments, and so on, and we bring all of that into the scene.
Store's HD overhead camera are used for recording.
I don't know the exact length of time, but I think this was like a 3-hour surgery. You're not going to be able to really show something like this to a patient. So we go about looking at all the data, creating these models, and then we create a storyboard that reenacts the surgery. And then we showed it to Dr. Lumsden, said, what do you think? And then we sort of abbreviated it so that we don't have a 3 or 4 hour animation. It's like I'm clicking this, but I don't want to double click. So we add a camera, and in this case, we didn't want to stay with the same surgical view. We wanted to show what you could do in terms of cinematic license and recreating the surgery to add sort of a drama to it.
Different cameras equal different views, not even available otherwise. Animation allows specific important steps to be highlighted.
So now that it's all put together, we'll play the animation for you.
Bringing it all together. Advantages of surgical video, patient-specific CT scan, and animation. The patient is positioned to grant access to the site of the carotid tumor. A transverse incision is made in the neck first with a scalpel, and then continued with electrocautery. The anatomy below is carefully dissected to preserve important structures and to reveal the tumor. Retractors keep the surgical window open. The common carotid artery, the bifurcated division of the external and internal carotid arteries, and tumor are dissected away from surrounding anatomy to gain control of these structures. Feeder vessels that extend into the tumor are identified. Via electrocautery, these vessels are ligated in order to minimize bleeding as they are removed. Once all the feeder vessels have been ligated, blood no longer reaches the tumor. The tumor is separated from the adventitia of the external and internal carotid arteries. The portion of the tumor that rests in the bifurcation of the carotid is the last to be removed. After the tumor is resected, the incision is closed and sutures are placed.
So now, we could show this to a patient, but we said, what else can we do with the data? I was fortunate enough to be asked by Intel to go out to their office to look at entering into the field of virtual reality. My first project was on skeletal muscle contraction, and our second project, we decided to create a room that is essentially on the 14th floor of an imaginary building. And you can look out the windows to the left and to the right, and you can have any college campus or medical center. You can brand the whole thing to a particular medical center. And then what you do is you have the animations, which are essentially IMAX type size in front, and then anything that you see on the screen, that 3D data set, I'm able to pull into VR. So the surgeon now can actually be in the room with the patient and rotating this data.
Welcome to the Blossom Experience VR app. From the main screen, we will select the carotid tumor removal animation. The animation will appear on the main screen with the 3D model in the center ring. The patient will be able to see for the first time their real CT data. The model allows the patient to literally look through the body to see the tumor. The animation in the background reenacts the surgery. We believe this will be the future of patient and student education.
So that's it. Any questions? Thank you.
So, hello everyone. We're going to get ready to go to Mighty, but I first want to release all the faculty members up to their stations. So if we have any faculty members still in the building, we all go up to the 5th floor before we release the learners. And how we'll be doing it is everybody has a badge and they have a colored dot. And we have these ladies up in the front. They have different colors and they'll follow you guys up to Mighty, and then we'll start the rotations. We have 4 groups, and each of the different rooms will have 40 minutes, so you'll be rotating around. And our group leaders will also give 5-minute warnings for what's ever left in the room. If you do want a refresher, what's on each lab descriptions are available in the front where the registration is. So you can just go grab one if you want a review before going up the stairs. So, thank you guys. And then everyone will have time to visit every station, but it is free.